Very good morning to all. Welcome to the 49th workshop on respiratory allergy diagnosis and management. To start with, I would like to invite Tarike Rokenachtamov who will read you the DEET workshop.
Good morning, everyone, and welcome to the network. It is just a sharing. As you know, Baladas Batches and Shade is the parliament chapter. Established in 1939, although the count of this ship was to Dunning Netherlands, but founded to Stern was a puppy. And since then, the ship is subject to the Meshi. And all the Star Wars they said I will paper you. Then the hit and is that and the national we call them the minister and on the book basis of ground. Then suffix Jodi Padmati Nasir and Mirabati involves. And of course the PhD programs ran together the we have the different departments also. And these departments work correctly with each other, focusing on the chest diseases, Basifa. Like the pathology, lung pathology, pharmacology, non-pharmacology. So all these prepare. The second objective is the research. We are very strong in the research. We do not advertise, but really very, very strong in the research corporate. I don't know how many of you know about the J receptor. How many of you know about the J receptor? Everybody must have read the Danone and the Brighton and everything. Where it was in the J receptor was invented in during this institute and become a pathogen. And apart from, because you'll be there for 5 days, so you are just like a family to us. So I request the people to take you to the place where the J receptor was invented. It has been made as it was now. So research is very strong and we encourage our faculty member to write the research projects and then funding from the funding agency and of course do the research. But all researches are to other set diseases. The third component is patient care. So we have 128 bedded hospital. It's a referral center. We get the patients from all over the country, including for some diseases, some investigation from AIMS Delhi also. And nearby neighboring countries also, Pakistan, Nepal, Bhutan, and all that is. And we are proudly say that all the alumni of this institute basically, most of them you name anyone, Delhi at least, big name, all are from all of the let's say such. So with that background, so I'll focus on today's subject basically. And we have few centers basically. You must visit those centers also like National Tobacco Fitness Services. That's a very prestigious project with the government of India. And it runs from 8 o'clock morning, 8 o'clock evening. And they are giving their services, counseling in 15 regional languages. We have center at Vallabhbhai Patel Chest Institute initially started. And then we have the satellite centers at NIMHANS, Bangalore, Tata Memorial Cancer Institute, Mumbai, and Regional Cancer Institute, Guwahati. So the other places. And with our effort, nobody can come with the nicotine containing products in the market without the helpline number printed on the packets. So each packet will have the helpline number, which are here packet. We have the other centers like virology center is there, mycology very strong, virology and mycology. In other places, it's a part of the microbiology, but we have the virology and the mycology very strong. Here the area centers, pulmonary rehabilitation centers. So people who are interested, they may visit during these times. Before I start, I just wanted to know how many people are pulmonologists. How many people are ENT people? So this time they say good. He say almost 50%. ENT in the pulmonary medicine. Very good. And how many are pediatrician? Pediatrician. So generally we cater these people. And before I start, basically, my whole aim is theoretical portion. You can read it from anywhere. So I'm more concerned about the practical aspects. And my whole aim in 5 days will be basically to train you only three or four things. One, how to take the allergy history, means how you go ahead with the detail about the allergy history. Then how you choose the allergen to do the allergy testing, because choosing the allergen, which allergen has to be uh, taken for the allergy testing, that's very important. That becomes a challenge for leadership too. So how to choose the challenge, the allergens, and then how to do the test and how to interpret. History taking, allergy testing, how to interpretation. And the third is you have interpreted rightly, then how you go ahead for the immunotherapy. So these are the three things which I will expect that when you leave this place, you should be able to know in detail. And that also that when you go back to your SHU clinical establishment, you should be able to start the allergy testing soon. So that's my objective. Clear cut objective is here. Recently, just I think last week only, we conducted a workshop on this allergy and immunotherapy only, and it was customized for through an app day. But we had the limitation. But now it's a 5 days course, so it's nothing. How many people have done any course from any? I'm not going to ask where and all those things. Just wanted for my knowledge. How many people have done any course from any place, maybe 2 days, 3 days, not one day, 2 days, 3 days, 5 days, 1 month, 1 year? How many? Okay, so fine. That's fine. So with that background, I will just, because another 5 minutes is left, so I will just hurriedly go. So whole your 5 days is summarized in this studies. If you know this one slide and the other slide I will show in the last. So the only two slides will teach you everything, whatever you wanted to know and for whatever you have come. One is the proper history, take allergy history involves determining the symptom complex, any relationship to the allergen exposure, and a careful physical examination looking for the specific signs of the allergy. So proper history taking is very, very important. For next 5 days, at least I will be repeating the same thing, allergy testing, by history taking, allergy testing, immunotherapy, only 3 days. Other people are there to teach you only there, but I'll be focusing on only treatments. So proper history taking is very, very important. You take a proper history, you have to become a detective basically to go and understand what are the means to which the person is allergic to. And always allergy history taking will be coming. When you are going to take the initial phase, you are going to take the history. Then after that, you are going to understand and you are going to make up your mind that the patient is allergic to particular allergen. One. Then how to go ahead for the establishing your allergy testing kit basically. What are the allergies to which I have to test? Second, when you do the test, the positivity comes. So it is just only the positivity, nothing else. Nothing else. Interpretation is just positive. And scientifically, this is a sensitization, not allergy. Then again, you sit down with the patient, take the history, and then correlate the history. So again, history taking is very, very important. So 3 times it will come before you really make up your mind and diagnose that the patient is allergic to that. Immediately it will come what is sensitization and what is allergy. Sensitization is a different thing, allergy is a different thing. We are concerned with the allergy, not sensitization. We have to treat allergy, we don't have to treat sensitization. So that much you have to keep into the mind. So history taking. Once allergy disease is suspected, a confirmatory test, skin test, or IG antibody serology is performed to verify sensitization by the presence of the allergen and specific allergy. So once you have taken the history, then you need to go for the diagnosis specific. So diagnosis need to be done by the allergy testing. One can be by the skin prick test and the other is by specific biopsy. Till now, the golden standard is field prick test. But yes, some of the places specific eyes is needed. So after history, diagnosis is very important. Where it can be performed and interpreted, the skin prick test remains the primary confirmatory test because it is safe, fast, sensitive, minimally invasive, and results correlates with the nasal and the bronchial challenge space. So the skin prick test is the golden star. Quantitative IG antibody serology is accepted alternative. When we are going to discuss about the in vivo and in vitro test, then we are going to tell you what is the difference where in vitro test is reliable, where the in vitro test has to be done and sure. Of course, SPT and IgE serology are essential adjunct to the history and the physical examination. So interpretation of the result has to be with the history. Provocation tests are sometimes needed to confirm the sensitization. Provocation test can be done, but that should be done in the tertiary centers and everything. So history taking, allergy testing. Last slide will be about the immunotherapy design. In between, I have already told to the VBCI how it has been made. So I'll just hurriedly go through this. These are some of the photographs. These are the mandate objective of the Vallabhbhai Patel Chase Institute. Again, we have the separate department of allergy and applied immunology, and people are working since 1963. At that time, no concept of the allergy was there, and Dr. D.N. Shivpuri is called as the father of the allergy in our country. So since then, the people are doing the work in the allergy and immunology and immunotherapy as per the methodology. I'm not going to detail about all these things. These are the centers which you will see. These are the old department, now never renovated. You will be going to the department, all these laboratory. Now this department is called as the National Center for Respiratory Allergy, Asthma and Allergy. So many tests are being done, specific IG, total IG. We have the website for this thing. Pollen count station basically. So we have the pollen count station at our place also. You'll be visiting that place also. I'll not go because there is a separate demonstration about this. I'll skip this. Then we have the Indian College of Allergy, Asthma and Immunology. You know, every year this college does the annual conferences. And last year it was at Vallabhbhai Patel Chase Institute. This year in 25, it is going KGMU is going to organize this conference, and that is going to happen in Lucknow. So more detail in between, you'll give you more about that. So these are the conferences details. I'm just trying to put at the perspective background so that we are oriented toward the allergy, what is going on. The workshops which we are doing, it is being done since 1974. Initially, the workshop was for 15 days. Then it was cut down to 7 days, and now it is 5 days, possibly at Chapel. Literally 4.5 days. Because 15 days, nobody is going to spare the time of this. There is a no recognized, and let me make you very, very clear. There is a till now not a single recognized by the government of India MCI courses, training program, certificate course, diploma, or whatever you name is going on in our country. We are trying for that, and very soon, basically, the DNB and the MCI is going to come out with the PDCC, PFCC, or the diploma, or the in the another. So very soon they are going to come. All whatever the programs are there, they are just sensitization basically. And you need to be very, very sensitive to learn also, because this branch is a very important branch and it's an upcoming branch. You can see earlier ENT people were 1 or 2. Now the 50% of the people are in the PK. Shift in the ENT people are aware basically. A lot of people are towards that. So whole perspective of another 10 years, I am going to tell you another 10 years, this branch is going to go at a different place, at a just different place, which you will not imagine. So you are lucky enough that you are going to learn these things so that you get prepared. So I'll not go about the training programs and everything. So these are just photographs and all the faculties which are there. So they become, our institute has been labeled as Institute of Excellence for Allergic Diseases in the Cabbage. These are the workshop photographs. I'll just hurriedly go ahead on just another 2 minutes all rounder. This is the 49th workshop. So what in this workshop we are going to do, that's very, very important. Another pioneer sign by Coco. There will be the directed lectures which will be there by the renowned faculties which are expert in their subject basically. And all means there will be some topics will be missing. I think you can get it from anywhere, but we have tried that the objective or objective fee objective, history taking, allergy testing and immunotherapy. So be focused basically. So different people we are going to give you the lectures on the different subjects. We are going to tell you the history taking them in vitro, in vivo, how you differentiate, which is better, how do you do it. So all these things are going to covered today. And there are guidelines which has come, that is the Indian guidelines of the diagnosis of the allergy. So whatever I am talking to you basically, there is an Indian guideline for the diagnosis of allergy. So you can go through that, and that has been, there is a lecture on that also. So that has been divided into 3 parts. Again, how to take the history. Second, how to recognize and find the aeroallergens, different kind of the allergens. And the third topic is how you do the test in vivo, in vivo test. And also some topics will come that who can, because there is no recognized courses which are going on, which is recognized by the government of India and the medical council, national medical council. So who can do this practice? So all these things are in the guidelines, so that tomorrow you can tell, yes, I am following at least some guidelines which is scientifically written by somebody and associations or the institutes. So that will be a big platform for you people also. So guidelines you must read, because you'll sensitize, we'll give you the details, but of course you have to read it basically. And I think Sonam guidelines you should just WhatsApp. There is a WhatsApp group also. We should say whatever the literature is there, we should put it in the WhatsApp to that out. So from tomorrow there is some small inauguration program is there in this room. So it will be very short, maybe 15, 20 minutes, half an hour. Then how you standardize the allergen, because there is always issue which comes, good allergen, which is good allergen, how can we get it, so how to prepare the allergen. So all these things will be there. So preparation, then how standardization, how it helps and everything. And under the limitation, whatever the allergens we have in our country, how it works, is it worthwhile or not? So those things will be also discussed during this program. So from tomorrow morning, so we'll again divide into 2 groups tomorrow. So one group will give you exposure of the pulmonary consent test, one group, and the another group will be going for the allergy testing. There we are going to demonstrate you how to do the stink prick test, intradermal test, and then everyone will be given the chance to do initial phase. You people will be made the partners. So one person will do on the allergy test and you, so that you can hear how it pricks looks like when licking. So other person, so it's a vice versa, will do it tomorrow. And then after that, again day after tomorrow, the group will change, PFP and allergy test. Then on the third day, everyone will be allowed to, we have requested the patient, consent has been taken, and everybody will be allowed to have a hands-on experience on the patients also, for allergy testing, for immunotherapy, in taking the history, everything will be allowed discipline in the hospital side. So tomorrow the group will be divided into 2 parts. Subsequently we will tell you, and one group will be here, another group will go day after tomorrow, same group. Then again we have the lectures. Then Then after history diagnosis, you'll try to sit towards the immunotherapy. So what is the mechanism the immunotherapy? And then tomorrow we are going to tell you sleep state, which is better. For me, all immunotherapy are good. How you take it up and how you practice is all depends upon you. So sleep, new advances in the immunotherapy. So all these things we come, allergy and awareness, all these topics will become. And then in the evening part, day after tomorrow, I think tomorrow, on Wednesday, day after tomorrow, and subsequent day, on the Thursday also, you have the case discussions. So history will be there, then investigation will be there. See, it's just a discussion among ourselves. So case will present, the faculty will be there also, yearly also there. So it's a quite good interacting and all these things. Then again, after that we are going to there or there only when you go to the department, you'll be given the exposure for the pollen counts, how the pollen counts are done, how it looks like, what is the importance of it. And then how to do the specific IG and the total IG, that is also exposure given basically how to do it, both specific IG and the total. And the third is the FANY is also being used, so that experience, that practical demonstration will be also. So 3 demonstration will be there on the pollen count, the specific IG, total IG, and FANO. So these are the 3 things also will be very big course. And then, of course, on the last day, then some of the topics like how to, what is the role of the biologicals, and then there is a guidelines uh, of guidelines for the immunotherapy also go. Indian guidelines for the immunotherapy. So that also you be dealt, and of course those things you have to go into detail. But that is a quite old guideline. Many things have changed, but that also happen. Specifically, food allergy will be also there. Food allergy, how to take the history in the food allergy, how to diagnose food allergy, and then how to manage food allergy, also topics are there. So we have tried to cover everything. If you had any topic in the mind which you feel that this topic need to be adjusted within this, we will be happy to do that. There's a and setting up how then pediatricians are there, so one of the pediatrician is going to come, and he is going to deal with the immunotherapy uh, in children. So what is the role, how to do it, and all those things, so we're going to discuss up that issue. And of course for the ENT people, Achal Bulati, I suppose Adhor Bulati is going to come, so he'll be also dealing for the ENT people and everything. So it's a mixed faculty also which is going to come. So I told you all the experiences will be there. So one thing is very, very clear. Please, in the morning and in the afternoon, sign the attendance. If the single attendance is not signed, I'm not going to give the certificate. That is 100%. No certificate will be given within this in class. Even you may be senior resident, you may be post PG, you may be assistant professor, you may be professor also. I humbly request that you should attend. If you don't attend, please do not ask us to give the certificate, because we are not giving the certificates to the professors also. So please do not ask for the certificate. If you don't mark your attendance, you don't go through each and every, because it's very, very important that each and everything is linked. Whatever I am telling you, I am no in the sequence wise, everything I am putting it. History table, review testing, advances of the data, and so. And we have uh, our faculty, whole faculty will be of the institute, pulmonary faculty will be there almost uh, means all 5 days we all will be here only. So anytime if you want any assistance, uh, you can talk to Dr. Bala Menon, who is a Baripur professor in the Vallabhbhai Patel Chase Institute. Bala, एक दफे पे हो जाओ. Bala Menon is there. He is also going to take, and you can discuss with him also. Then Dr. Nitin Goyal is here. He is associate professor here. He'll be also here. He'll be taking the classes also. But anytime you can interact, free to interact with them. Then we have Parul. Dr. Parul is there. Dr. Parul. and Dr. Sonam is there, Dr. Siddharth is there, and so there will be all these are the faculties, our faculties. Vidushi is going to also join sometime because OPD may have, so we know OPD. And anything in between, if you want to go and see our bronchoscopy room, if you want to go and see our pulmonary rehabilitation, you want to see tuberculosis, and you want to see, or anything is whatever there in here now, you can just tell us so that we can squeeze the time better. And we will slightly late 10 minutes, so we will have our introduction also. Like I think some of the people have come in, and other faculty member Dr. A.B. Singh is there. Dr. A.B. Singh is I think a well-known person. He is the secretary of the Indian College of Allergy, Asthma and Immunology, and he is the person who एक कहावत है ना कि बीड़ा उठाया हुआ है एलर्जी के लिए. इन्होंने मेरे ख्याल से कितने वर्ष हो गए हुए सर आपको बीड़ा उठाए हुए? 50 साल हो गए हैं बीड़ा उठाए, और हम लोगों ने यहीं से सीखा है, और इनके बीड़ा उठाए हुए वो हम लोग एक आगे की तरफ ले जा रहे हैं. बस यही हम लोग काम कर रहे हैं. सो ऑलवेज सीनियर्स की ब्लेसिंग हमेशा अच्छी रहती है. एंड अनदर फैकल्टी वी हैव डॉक्टर Nitesh. He is from the associate professor from the Submarine Hospital. So with that, I think we'll just start with the lecture series program. So I think the first lecture is, the first lecture, of course. Then we start with the basics basically. So the I think the chairperson's name is there, Dr. B.K. Menon, Dr. Sonam, Dr. Siddharth. So I think you should start the proceedings with the basic lecture. Yeah, Mr. Bala.
The first topic would be taken by Dr. Nitesh. It is the basics of allergy. Dr. Nitesh is an associate professor at the Department of Pulmonary Critical Care and Sleep Medicine at the VMMC and Safdarjung Hospital in Delhi. He's done his MD, his DM, and his FSM. And his areas of interest are interventional pulmonology, COPD, ILD, systematic reviews, and meta-analysis. I invite Dr. Nitesh to take his talk.
Thank you, sir, for the invite. At onset, I'd like to say that sir, and the team at BTCAT for the invite. I'm an alumni of this place. There is having a bad background from this place. And it's always a pleasure to keep coming back to the place where you have been on the other side of this place. So as sir has told that attendance is mandatory, it is actually mandatory. It was the 49% never till the day sir has given a certificate without बताइए. So how many of you have actually read allergy कम है? किसी ने कुछ पढ़ा इसके बारे में, उसके बाद है या सब सीधे यही से सीखने हैं? तो कोई नहीं पढ़ के आया तो we are sure you will get the right knowledge and the right wisdom about the allergy. So हर चीज़ हिस्ट्री से शुरू होती है, किसी ने कभी भी सोचा होगा. So it was in 2641 BC where the allergy was first thought of, when they observed some Egyptian pharaohs died after being bitten by jaundice. So they thought that something must have happened to those. In the extinct, something must have been there temporary person. Then it has progressed. The first discovery of definite cause of allergic rhinitis named hay fever. Hay fever came in 1890, almost 200 years back. The cycle continued with the evolution, and now hygiene hypothesis, we all are aware, 1989. And now we have not only the diagnostics, we have treatment, we test response to it. So long time we have diagnosis, we have treatment, but we do not find that great degree of response. Patient still keeps coming back to us, and मेरे तो अभी भी दिक्कत हो रही है, despite the best possible therapy. But that say has been overcome, and futures is again great for the allergic disorder as far as shown. The shift from pulmonologist to ENT to pediatrician. So practically it will evolve into a brand new course where a lot of people would be eligible, and then they would be start practicing it. So our immune system has two types of immunity. We all know, one is innate and one is adaptive. Very. कुछ तो basics याद है. So innate is problem is innate is बच्चा. It lacks the specificity. It will react to each and everything that you give. It has limited diversity and rudimentary memory, but manifests rapid engagement. So it's a first line of defense. It will attack anything which is abnormal to the body. That is where innate has a role. It is not that innate is bad,
You need innate to have something to prevent a catastrophe to begin with. Then by the time innate works, your body cells starts functioning, they get the message which they want, and your second line and third line of better defense starts activating. So adaptive immunity has specificity of antigen recognition. It particularly recognizes what is causing the problem rather than saying everything is causing the problem. It has diversity of antigen receptor repertoire. That means lot of antigens can be recognized by a single molecule. It has rapid clonal expansion. Once it recognizes, it will activate the whole army to overcome the problem. Adaptiveness to the changing environment. It is not like if antigen has changed, your antigen receptor has changed, or antigen proteins have changed, your cells will stop recognizing them. They will also adapt to it. May not be at the first attempt, but in every future attempts. It has immunological memory. Memory is needed to mount a response. Memory is something where you learn, you store, and next time something similar happens, you activate it. Lymphocytes are primary adaptive immunity. So your adaptive immunity begins with lymphocytes, which includes T cells, B cells, and NK cells, right? This is something which we don't see, which in the actual clinical practice, it is something which we see in the labs and in the test reports. So we have how many types of immune responses? We have 4 types of immune responses: type 1, 2, 3, and 4. So everything begins with immune factors. So type 1 is done by IgE, type 2 is done by IgG, type 3 is again by IgG, type 4 is by T helper cells and CT lymphocytes. Antigen, again for type 1 you need a soluble antigen which leads to activation of mast cells, for which further lead to effector mechanisms through antigen receptors and leads to hypersensitivity reaction, which is your allergic rhinitis, your asthma, and your systemic anaphylaxis. So all 3 are practically IgE based reactions. That's why we look for IgE, total IgE and specific IgE. We do not look for IgG. When it comes to IgG, there is antigen associated with the cell matrix which leads to phagocytosis. That is, macrophages get activated, and which is allergic to some drugs like penicillin. So whenever you are suspecting a drug allergy, the test of choice changes. You need to look for IgG instead of IgE. Again, type 3 reaction where Fc complement cells are there, which is like serum sickness or Arthur's reaction, rarely seen now. Type 4 is something which we are more interested in because it leads to activation of macrophages, activation of eosinophils, and cell-mediated cytotoxicity. So this leads to contact like of allergic reaction. So contact dermatitis, you are meant to test. Your chronic allergic rhinitis and chronic asthmas, they shift from type 1 to type 4 and contact dermatitis. So if you are looking for a dermatological allergies, you need to look for type 4 allergies. You are looking for asthma allergic rhinitis, you are looking for type 1. If you are looking for drug induced allergies, you are looking for type 2. So this is again the repeated diagram. Now this has become more complex. From T helper cells, you have now a lot of interleukins, which are in between mediators which decide which type of response or which type of T cells is going to get activated. So when you have T helper cells as IL-12, which activates gamma interferon and TNS alpha, which leads to viral induced reactive airway disease, asthma, atopic dermatitis. If it has IL-4, again allergic rhinitis is asthma. If it has TGF beta, it has role in allergen immunity. So from helper cells, in between comes interleukins, which leads to activation of various types of T helper cells, 1, 2, 17, and T regulatory. Again, this is something we have translational research, and once it passes the translational research, it comes into the clinical research. So we all say now healthy gut, gut-lung axis, gut-kidney axis, gut-brain axis, we talk about microbiomes. That ultimately everything comes from a microbiome. So when you have healthy microbiota, that is normal healthy lungs, you have normal monocytes, eosinophils, neutrophils, they mount the response in the form of IgG and IgA. But when you have depleted microbiota, where you call it as dysbiosis, susceptibility, this leads to susceptibility to allergic disease, where you instead of IgG and IgA, now you have IgE, which is again we know as a mediator of type 1 and type 2 reactions. So it begins with the gut. So there is gut microbiota and metabolites, which leads to epigenetic factors, that is those persons who are predisposed or those genes they already had. They cause modulation in those factors which are produced by genes and leads to allergic diseases, as well as some environmental factors, triggers, smokers, pollution, some drugs which leads to allergic disease. So practically you have something at the basic level, which type of molecule, which type of antigen, which type of response. Between them you have lot of modulators which take them to those pathways, and it all begins with a normal microbiota or alternative microbiota. So when we go to the microbiota, metabolome and allergy axis, we have external factors like age, diet, infections in children, breastfeeding, whether they were purely breastfed or they had an external feeding or formula feeding, natural birth versus cesarean. All have been studied in huge population and they have shown to be protected. So natural birth is protective, breastfeeding milk is protective for microbiological organisms. So once there are dysbiosis, there is a qualitative and quantitative, which leads to difference between the inflammation and the microbiome being just a commensal. So we all know there are a lot of commensal organisms who have a pathogenic potential. So what it all does is, from that commensal organism, shift the pathway towards the pathogenic mechanism where you have manifestations of allergy. So this is diagram you are going to see throughout your 5 days. So when you have allergen exposure of any kind, this is what happens at the epithelial membrane, where they activate the epithelial membrane. They leads to lot of interleukins, which leads to lot of T helper cells, Th1, Th2, Th17, which leads to lot of eosinophil recruitment, neutrophil recruitment, may lead to asthma symptoms. Activation of B cells will lead to activation of plasma cells and will cause epithelial change in form of mucus hypersecretion. So this mucus hypersecretion is not only seen in the airways, it is seen in the nasal also, it is seen in the gut also, it is seen in skin also. So lot of, practically the pathology remains the same, that allergen comes at the epithelial membrane, leads to cascade of reactions, which if not controlled in time leads to symptoms. If it gets controlled in time, it leads to sensitization, but once that sensitization phase is over and now you start having clinical symptoms, you call it as allergic disorders. So as we see, the antigen has come through the blood, crossed the tissue, activated the allergen, goes to the antigen presenting cell, activated the B cell, the T cell, goes to the lymph node for the memory, leads to mast cell degranulation, again activation of true interleukin 4, activation of IgE and IgG. So practically everything reaches the epithelial membrane either through the contact or through the tissues or through the direct or through the blood. Anywhere it just reaches the epithelial membrane, which makes it sensitized and leads to cascade of reactions. This is something which we don't see with the naked eye, we just see the end product, which are the test reports and which are the clinical symptoms. We don't see anything in between. This is for the translational research, which takes years for it to produce some therapy. So that's why it is not that it has stopped over one interleukin. Once they have identified the interleukin, they have tried to stop it through the mechanism and see whether clinical symptoms stop or improve or not. So as Sarah has told, we will be talking about clinical evaluation, we will be talking about laboratory evaluation, and we will be talking about now treatment for the allergic which has been identified. So whenever there is a history, it is always a multi-system involvement, it is never a single system. That there may be a time difference when one system affects first, produces symptoms versus other. Or one has produced symptoms few years back, it has gone, patient has also forgotten, now he has come for something new symptom. But you must always in a retrospect as well as in a prospective must inquire for all those symptoms. Begins with the skin. Skin has features of pruritus, urticaria, cutaneous flushing. Mucosa, especially external mucosa which is exposed to allergens like swelling of lips, tongue, conjunctiva, fullness in the throat, difficulty swallowing. Then comes lung symptoms, GI symptoms, cardiovascular symptoms, CNS symptoms, ocular symptoms, urinary or sexual organ symptoms. So practically you should have this checklist with you whenever you are suspecting a patient of any allergy. This all must be inquired for because one may be present previously, one may be present now, and in future also if something happens, patient will at least come back to you and tell कि आपने ये बताया था कि ऐसा हो सकता है, अभी हो रहा है, आप आगे बताइए क्या. ठीक है? So you must know your practically or whatever you are inquiring patient, you must know it yourself through in and out. Rather than patient coming and telling you ये भी हो रहा है and you are ignoring it, नहीं ऐसा तो मैंने पढ़ा ही नहीं है, ऐसा नहीं होता. ठीक है. So this has all been just basics for allergy. This has all been about my talk. One thing which sir will keep on telling you and everybody will keep on telling you is focus for 5 days because you have to go back and practice it on your patient for rest of your life. You can always come for a refresher course anytime in future. Sir always welcomes a student who just wants to refresh themselves, as there may have been a time lag when you have trained here and gone back and not practice, initially started practicing. So you can, sir is always available. You can even contact sir after the course also. So just for 5 days, focus from 9 to 5, and you will learn an entirely new thing in your life and change your practice and your patient's practice. Thank you.
Invaluable insights on research allergy. So, for the next talk, I would like to invite Dr. Nitin Goyal to be taking the talk on bronchial asthma and its phenotypes. So, I welcome you, sir. Sir is a faculty at PPHS Institute, University of Delhi. He is associate professor and has received many fellowships. He is editorial member of Indian Journal of Asthma, Allergy and Applied Immunology. So, I welcome you, sir.
Thank you, Dr. Siddharth. So, a very good morning to all. In today's era of precision medicine, as we look at diseases, we don't look at diseases as uniform entities. Rather, we try to look at them at the heterogeneous clusters. Case in example being the oncology, whereby in oncology, molecular phenotyping has helped us to form precision medicine-based treatment and have better outcomes. Similarly, in asthma also, we have heterogeneity, and we will try to look at them, but all phenotypes are there with us. And but although I will admit upfront that there is no standardization of the phenotypes of asthma, and it still remains a challenging topic. So if you look at the classification of asthma over the past century, it has undergone a paradigm of shift. Initially, it used to be known as a single disease entity, and later on it came to be identified as intrinsic or extrinsic asthma. Moving on, we had eosinophilic, non-eosinophilic asthma. Later on, we had cluster studies in the 2000s, which led to development of endotypes and phenotypes of asthma, and Th2 based phenotypes now are known, which we will look in the talk. So, GINA 2025 also says asthma to be a heterogeneous disease, and it has chronic airway inflammation along with history of respiratory systems which are variable, like wheeze, shortness of breath, chest tightness, and cough. So, what is actually a phenotype? Phenotype is an observable quality of an individual which is the result of genetic and environmental interaction. For example, in asthma it can be nasal polyps, presence of allergic symptoms, presence of obesity, etc. And then what is the endotype? Endotype is actually the endogenous mechanism behind that phenotype. To say it is actually distinct functional or pathobiological mechanism which results into that phenotype being manifesting clinically. For example, it can be type 2 kind of inflammation, it can be mast cell activation, obesity associated inflammation, gender hormone abnormalities, etc. So, why do we need to characterize these phenotypes? Because this helps us to understand the etiological mechanisms involved in that phenotype, to identify the specific causes, and hence enable us to get better management and prevention. Simultaneously, this helps to development of newer therapeutic measures for treatment of the phenotypes. Looking at GINA 2025 again, it defines asthma phenotypes to be recognizable clusters of demographic, clinical or pathophysiological characteristics often referred to as asthma phenotypes. But it also states that in general, phenotypes have not been shown to correlate strongly with clinical patterns, specific pathological processes or treatment responses, except in patients of severe asthma. So that is what I wanted to stress upon, that there is a certain degree of ambiguity still in the subject and there is no standardization of the thing. Again, if you look at the management protocol for asthma in GINA 2025, it stays on step 5 when the asthma remains uncontrolled despite higher levels of medications being involved, then refer the patient for assessment of phenotype. So that is important, that we have to assess the phenotype and the patient still remains uncontrolled despite all usual medications. So in the initial phases, as I mentioned, asthma used to be simply known as either allergic or non-allergic, where the patient has symptoms to when he is near to his pets or some other substances, some clothes, etc. He may be allergic asthma, or if he doesn't have symptoms that way, then he is non-allergic. Similarly, there were other early asthma phenotypes which were again based on single variables and hence were subject to bias, like age of onset, early or late, presence of allergy, reversibility of airway obstruction, whether it is present or absent. Similarly, persistence of symptoms, severity of airway obstruction, steroid responsiveness, etc. But these were all subject to bias and were not a targetable traits. So this led to development of what is known as cluster analysis. In the early 2000s, we had cluster analysis studies. Cluster analysis studies actually are hierarchical statistical tools which predefined variables like age of onset, atopy, all these kind of variables, gender, etc., and try to form the cluster of asthma patients so that we have certain homogeneous clusters and we can identify them. The earliest of these studies were by the Helder et al. From UK Leicester study. It was published in AJRCCM in 2008, and here on the y-axis we have the symptoms and on the x-axis we have the eosinophilic inflammation. They were able to form 5 clusters of asthma phenotypes, and the middle one, the benign asthma and the early onset atopic asthma, had the concordant disease where the inflammation and the symptoms matched, and then the inflammation predominant group had more of inflammation but the symptoms were lesser. Whereas the other 2 groups of phenotypes, early symptom predominant and the obese non-eosinophilic, had lesser of eosinophilic inflammation but the symptoms were much more. So there certain other mechanisms were into the play. Then the next multicentric large study, which was SARP study, was done in the US and was published in 2010 in AJRCCM again. And this analyzed severe asthma patients into 5 clusters. So we had the 3 clusters, cluster 1, 2 and 4, which were allergic clusters, and they had early onset with increasing severity of the disease. The cluster 1 being mild allergic asthma required mild medications and was controlled. Cluster 2 being mild to moderate allergic asthma again, but required more of medications to get controlled. Then cluster 4 was a severe variable allergic asthma and has much more severe symptoms and much more medication dependence. Then we had cluster 3, which was severe late onset asthma, and these usually included obese females and with late onset of the symptoms. Then cluster 5 had severe fixed airflow asthma, and more of COPD-like similarities were seen in this cluster, and atopicity was variable in this cluster. So after these cluster analysis, there have been many other studies which I have skipped for the sake of brevity, like UBioPret study, etc. Then these cluster analysis studies and their research further into them led to development of what is known as T2 high and T2 low kind of inflammation, and now the asthma phenotypes are divided based on whether T2 high or T2 low kind of inflammation is present, the mechanism is present. So what is T2 high? So where we have asthma with different symptoms coming to us, onset or exacerbations, lung function, and the inflammation of T2, which can be variable degree, T2 high or T2 low, and we have different phenotypes depending on the combination of these inflammation. So what is actually T2 inflammation or the T2 high asthma? As this diagram has already kind of shown to you, I'm just going through it. When the allergen exposure is there, certain interleukins like 25, 33 and TSLP are released, which lead to activation to Th2 kind of a pathway and release IL-4, 5, 9, 13 of interleukins, resulting in the eosinophilia, airway activity, mucus production, which is seen in the asthma. So here the biomarkers for T2 high kind of asthma would be eosinophilia, high FeNO, high Ig, and is mediated by interleukins 4, 5 and 13. Contrast to this, we have the T2 low kind of asthma, whereby more of infections, smoke, pollutants, they play a role. Activation of bronchial epithelial cells again, but here the activation of pathway is different, whereby Th1 or Th17 kind of inflammatory pathways are activated, and we have different set of cytokines, interleukins of cytokines being released, and then it leads to more of neutrophilic inflammation. Simultaneously, there is certain neurogenic component as well, which leads to airway hyperresponsiveness and increase in the airway smooth muscle mass. So the biomarkers for non-T2 or T2 low kind of asthma is neutrophilia and mediated by IL-1, 6, 17 and TNF. So what are the clinical phenotypes based on this T2 high and T2 low asthma? This diagram beautifully summarizes all the major types of T2 high and T2 low kind of asthma. On the y-axis again we have severity of asthma, which is going increasing as we go up, and on the x-axis different onset of asthma is being given. So we have T2 high asthma, which comprises of allergic asthma, exercise induced asthma, aspirin accessibility respiratory disease, and the late onset eosinophilic asthma. Whereas non-T2 or T2 low kind of asthma, we have very late onset, obesity associated, smoking associated, neutrophilic, and smooth muscle mediated paucity. Looking at all these phenotypes in brief, the early onset allergic asthma, again mild to severe as we have seen in the diagram, allergic symptoms present, onset usually in childhood with positive allergy skin testing and increased serum specific IgE. This is classically usually steroid responsive, and actually this is the kind of asthma we are mostly treating. Then we have the late onset eosinophilic asthma, which is again a T2 high kind of a subset, but is more of adult onset and is more severe asthma. There is association with chronic rhinosinusitis with nasal polyposis and is steroid-resistant eosinophilic phenotype with unknown molecular mechanisms. It has prominent blood and sputum eosinophilia, but despite that, it is refractory to the steroids. Generally, high pheno and increased IgE may be seen, and recognition of this phenotype of asthma is an indication to escalate the therapy early. Then we have the AERD, which is again a subset of late onset phenotype, again a T2 high kind of asthma, characterized by asthma along with chronic rhinosinusitis with nasal polyps. Usually COX-1 inhibitor or aspirin-induced respiratory reactions are seen. Again, eosinophilia is prominent, and simultaneously we have high urinary leukotriene E4 levels, and it shows good response to leukotriene receptor antagonist as an add-on therapy. Then we have the exercise-induced asthma, which is a milder form asthma and is again T2 high. Usually patients have experienced reactive bronchoconstriction on exercise, sustained exercise in cold, dry conditions, and is again associated with mast cells and their mediators, is responsive to leukotriene antagonist and the inhaled corticosteroids. Then the other one is the T2 low kind of asthma, which is obesity associated asthma, is non-atopic, usually adult onset, and predominantly middle-aged females are known to suffer from this. And there is a lack of T2 biomarkers, that is pheno and eosinophilia is not present. Weight reduction plays an important role while doing the asthma management in such cases. Then we have the smoking associated asthma. This is seen in current or former smokers. It's a kind of a COPD-A that we see in the GOLD or a ACO in the GINA guidelines. It's considered T2 low asthma and has more of neutrophilic inflammation with fixed airflow obstruction. Again, this is a steroid-resistant phenotype, and smoking cessation is important, and also antimuscarinic agents help in the management. Then we have the very late onset asthma. The age for the very late onset asthma is not consistently defined. Some studies stated to be more than 50 years and others have stated to be more than 65 years. Mechanisms possibly include the aging lung, which lead to decreased lung function, loss of elastic recoil, and mechanical disadvantages. Increased sputum neutrophilia is seen, again activation of Th1 and 17 kind of inflammation is observed. So as I mentioned in the initial phase itself, that the classification of asthma phenotypes is not standardized. If you look at the GINA 2025, it states certain other phenotypes like allergic asthma, non-allergic asthma, cough variant asthma, adult onset, late onset asthma, asthma with persistent airflow limitation, and asthma with obesity. What we are actually trying to look at is the underlying mechanism which is targetable, but phenotype actually may not be the targetable thing. So when we evaluate a patient of moderate to severe persistent asthma, we try to look at the clinical phenotype, whether the history of atopic is present, whether the family history of atopic is present, whether the patient is obese, female, or the patient is a smoker. So accordingly we suspect whether we are dealing with a T2 high or T2 low kind of asthma. We perform the biomarkers, which are mostly pheno and the eosinophils. Also presence of specific IG or skin prick testing can help. If these are present, we are probably dealing with a T2 high kind of asthma, and we can devise our strategy accordingly. If these are absent, probably we are dealing with a T2 low kind of asthma. So this diagram just to show the different biologicals available with us for the targeted management of asthma or the precision medicine. Although this is not my area of talk and we have a dedicated lecture for this. So various biologicals are available like omalizumab, dupilumab, benralizumab, etc. And most of all of these are acting actually on the T2 high kind of asthma, and that is what GINA also states, that T2 high kind of a severe asthma is targetable. So when we are managing asthma, we should look at the host factors, the age, the family, genetic history, then the environmental exposures, then we should look at the pathophysiology, the inflammation involved, eosinophilic, neutrophilic, lung functions, what is the symptom patterns, and simultaneously patient education on adherence and correct technique is very important to form the individualized treatment for that patient. To sum up, asthma is a complex multicellular inflammatory disorder with strong environmental gene interaction, and severe asthma, some phenotype guided treatments are available. However, more research is needed to understand the clinical utility of the same, and also there is a need for better biomarkers to identify them. Thank you.
Thank you, Dr. Nitin, for your very first lecture. Thank you very much. So, continuing with the lecture, the next lecture is on the one of the important for this workshop is the aerobiology. We should know the fauna and flora of our area where we are practicing. So, for Dr. Elisi Sir. Sir has literally introduction. Sir is a former advanced scientist at CSIR, integrated by the university, with more than 50 years experience in the research in Poland and Pongan energy. Sir is to merit awards to the Charles Richard Prize or promoting energy and is continuously associated with these works.
Thank you, Dr. Sonam, for your nice introduction. Friends, I'm thankful to the organizer for giving me the opportunity. Actually, they were hesitant because I'm not taking good health. So they were little hesitant whether I will be able to join or not. But fortunately, I could make it. And I will try to give my efforts in identifying the various types of allergens and then how they are clinically relevant and relevant to your clinical practice in day-to-day diagnosis as well as management. So indigenous allergens, I will be focusing more on Indian-based allergens, such as pollen or fungal spore, dust mites and others. Once the patients come to you, the first and foremost thing is to make the patient symptom free. What are the various approaches which have been followed to make the patient symptom free? The first and foremost thing is to avoid the allergens or your mental management, provided you know to what your patient is suffering to, whether it's a pollen, dust mites, fungal spores, roots or anything. There are certain things which you can avoid. But there are certain things you cannot completely avoid. For example, pollen and fungal spores, which are present in the environment, they are microscopic structures you cannot see with the naked eye. So that's why, to some extent, if you know the flowering season or the pollen season, you can avoid to some extent. It will not completely eradicate from your inhalational pathway. Second approach is the medications such as permatotherapy, which we are looking the following, that these are not very supported. Allergen, next is allergen specific immunotherapy, that is immunomodulators. This is something where patient can be made symptom free for a long time, as the studies have indicated globally. Then patient education and awareness in another important part are free. But effectiveness of these strategies and methods that is based on a good understanding of the aerobiology of the area, maybe from district level to state to the country level or even the regional or global level as well. So you must have an idea what are various allergens, whether it's pollen, fungi, dust mites in the patient's environment. So to understand this, we should be well aware of the aerobiological pathway of the GIRA. How to define aerobiology? What is aerobiology? You must have studied in your school days or even later on in graduation. Aerobiology is defined as a scientific discipline focused on source materials of biological origin like column grain, fungal spore, dust mite, virus, bacteria, anything of biological origin, but carried by the atmosphere and finally having its impact on the animal system, human system, or even the plant system. However, abiotic or inorganic particulate matters like pollutants, gases and other things which affects the biological materials in the environment, they are also recently included in the concept of aerobiology. What is aerobiology? What are allergens? Clinically, the term allergen is often used for the source of allergenic molecules to which there is a cause and effect relationship. They are producing symptoms among the patients, like for example, dust mite, fungi, mite, insects, animal, and so on. But immunologically, the term allergen is used for an antigen which causes type 1 allergic reactions, and there are practically no physiological difference between high molecular weight proteins and the allergens. However, the allergenic activity of the molecule or the foreign rails or the fungal spores depends on its antigenic determinants at the molecular level and its chemical configuration of the proteins, extractions, and etc. So we are surrounded every day in our day-to-day life with a variety of biological materials, aerobiological materials like pollen grains coming from grassseed, wheat, and teas in different parts of the season. Then molds actually both as an indoor and outdoor environment. Dust mites as an indoor allergens. Then we have variety of dust, that is organic dust, not the silica dust. And the danders are the correct are evident in Italia, various varieties of plants are indoors. And then insects, as well as any food material, ducks, and other things. These are the things which are commonly involved into the presentation of the allergic symptoms. India, is not a country, is actually a sort of continent, and therefore there are the fauna and flora, the pollen grain, tree information, pollen plantations. They vary from one part of the country to the other. For example, you go to the high altitudes, you will find different types of fauna and flora like Citrus degara, palmas, ulnas, and so on and so forth. If you go to the coastal areas around the sea like Bombay, Chennai, Trivandrum, and so on, you will find Cophus nucifera, you will find the Borasias, you will find some other different types of fauna and flora included. Yes. Then plains actually, northwest India, in northern part of the country, we mostly find the various types of crops and others and grasses and beets. If you go to the desert area like Rajasthan and borders of Gujarat and so on, we will find different types of fauna deluded like pesopes, chichen. So we should have a knowledge of what are the important pollen, what is their season, so that you could correlate with the patient's symptoms when they visit to you, what are the various types of plants available in your area, so that you can select the appropriate allergy for diagnostic as well as for therapeutic practices. This allergen pathway, the pollen grains of fungal spores, they are released into the atmosphere not for causing allergy, they are the natural pathway. So it has the aeroallergens have been divided into two different categories. One is the classical fundamental or botanical pathway. They release their source material, various plants and animals, in the form of pollen grains and fungal spores, and these are dispersed into the atmosphere running from few days to several months, and they can travel from few kilometers to hundreds of kilometers in the atmosphere, depending on the shape and size of the pollen grains. And then ultimately, finally, they get deposited and have their impact on plant system, animal system, as well as man system also. So this is the natural pathway, and many people do not get the symptoms, is nothing. But what happens when they are released into the atmosphere, they penetrate our airways, either by inhalational route or by the other methods. Once they go to the they can impact our nose, they can impact our conjunctiva, they can impact our skin, and so on. So accordingly, they have, depending on the target organ, they have their allergic diseases. So once they are retained into the body, then the interaction into the body takes place. And 15 to 13% population which are genetically predisposed, they get the signs and symptoms of allergic reactions. But the others do not, because everybody is inhaling. Why only few people get the symptom? Because they are a genetic predisposition to nature of the disease. So these allergens are by and large divided into 4 different categories. As an inhalant like pollen grains and fungal spores, as ingestants like food and drugs, compactants like latex, trichomes, cosmetics, etc. And injectants, some of the insects are injectants like LOH, honeybee, and some are as a part of the waste material. What is the practical significance of these allergens to your practice? I mean, solutions, either national level, international level, or even local level, because they provide clue to potential allergens to which patients are exposed. Once you go into the history, actually, it is most important part of the diagnosis. But to interact with the patients, you can know to what type of plants they have been exposed to, what is there in the area where he is residing. That knowledge should have been very rare. And that's why it helps in selecting the appropriate allergens for diners. Manufacturers have provided you a list of hundreds of allergens present in your food. Now you have to select whether when the few allergens which are relevant to your patient should be selected for diagnostic or the entire, there are both type of practices there in the So I personally feel that those which correlates with the symptomatology of the patients or the symptoms of the patient and their seasonality, as far as classically we select them, maybe 20, 30 or 40, and then usually that gives you the better percent. It provides also short-term exposure roads for public exposure. Because sometimes what happens in the particularly in Inter, actually in Delhi or Northwest, you find lot of smokes and other things. So you know to what are the important pollen of fungi prevalent in the atmosphere during that rate, because most of the patients complain for the system can correlate to the symptoms of the patient during that period. And also it helps in evaluation of effectiveness of allergen immunotherapy. Whether your patient is getting gallipit because of that particular allergen have been devoid and the atmosphere is not present anymore, that's why it gets active, or this is because of the effect of allergen immunotherapy. And also take avoidance measures from exposure to the environmental. Environmental management, as I told you, to be low to heart, you could confirm this is the patient, this patient is suffering from this particular allergen. With that is avoidable, at least we can minimize the exposure injuries due to the body. So allergic reactions to de-offending allergens with the pollen contrast also helps the patient to handle the symptoms. Environmental pollution load in the area also, because these pollen drains sports, they exist in the atmosphere and these pollutants they interact with each other and make the allergens actually more virulent as compared to non-polluted areas. And then concentration of allergen is specific IgE patients is what routine to become because IgE based disease and depend on the concentration of the IgE antibody, particularly the specific IgE antibodies. I will just cover few photographs actually of the monitoring station, how they monitor allergens from the atmosphere. So a variety of sampling devices have been developed over the time, which are used both in India and for example, there is a bird part 7 day volunteer. 7 day means if you put some sticky material into the tail there, it can last for 7 days. You start today and take it out after a week, and then you can study what has been there during the last 1 week and the following week. So this process continues on year-to-year basis and month-to-month basis. This is what you will find an opportunity to look into it, because one of the samplers you installed at rooftop of the Vallabhbhai Patel Institute probably will be taken there as a PT. That was for outdoor pollen allergens. Then there are some sampling devices which are available for indoor allergens, maybe classrooms, maybe factories, maybe godowns or occupational sites. That is a petri plates here. We can see here Anyway, so after exposing those slides on the various devices of aerobiological monitoring, you can identify what are the various types of pollen there depending on their morphological features as it duplicate. Every pollen looks different actually. You can see some are multiporate, some are spinose, some are having tricorporate or tricorporate grains, some are winged grains. Here you can see is a fungi. You will find when the slides both fungal spores as well as the pollen grains into the atmosphere. So based on their morphological features, they can be identified not only up to generic level, even they can be identified up to the species radar. So we conducted an All India coordinated project on aeroallergens to monitor, funded by the ICMR and the Ministry of Environment, to find out the important allergens on countrywide basis. So we selected 18 centers wherever the facilities were available, and they were studied for important pollen and fungal spores both in indoor environment as well as in outdoor environment. and the local allergens found within different parts of the country, probably for like eastern India, for southern India or northern India. They were tested on the local centers, like northern India, we were tested at Vallabhbhai Patel Chest Institute and the PGI Chandigarh, where the expertise were available. In South India, they were tested at Trivandrum, Bangalore, Chennai, and in eastern India, they were tested in Assam and also in Calcutta. So, like we identified the important pollen and fungal spores prevalent in different parts, and also we studied the impact of those in the local population because they were exposed to different types of pollen in their area of residence. So ultimately you find a sort of a picture for the entire year. That study was based on 2 years, and we found that you can see here in the picture there are 2 peaks actually, although pollen are present throughout the year. Is the total pollen counts picture. There are 2 peaks. One is in the month of March and April, another month August, September, October. There was first one is more highly influenced by the tree pollen grains because most of the pollen are the plants flower during the spring season. That's why you will find also the patients reporting a higher number of visits to the various health centers in the month of March and April and also September. The first is influenced by the tree pollination, whereas the next is August, September, October mostly dominated by the grasses and weeds after the rains. So there are 2 peak seasons in the column in area. But we are more interested in the specific pollen of the individual types. For example, most of the grasses are found in September, October. You can see the first peak April, and that also varies from one part of the city to the other. You can see here slight variation is there in North India, North Delhi, South Delhi as well as East and West Delhi areas are, depending on the local vegetation. So even within the city also you will find some degree of variation in the pollen counts of specific gender and that person. Another you can see the richness comes in we find mostly they are most prevalent in month of February, March and April rather than just September, April. So like this you can find out the important allergens which you get manufactured to know what is their pollination season or what is their pollen season, so that you can correlate with the clinical symptoms of the patients and select the appropriate antibiotics. Our interest also again to know if the patient is there, you can try and catch it globally. You should know what are the important allergens of different parts of the world. So World Allergy Organization has compiled a sort of calendar where you can find out the important allergens of the North America here, North America here, South America, this is here the year, Atita, European region and Durable Asia Pacific. To our impressive what is there in India, you can click at India actually side like cursor and we find next picture like this one. So data from North India, Thailand, Australia and New Zealand is available from this app. If you click India, you will find pictures of important allergens of Indian region. Thailand in fact, because the data is available in Asia Pacific region only Cambridge vast. So if you click India, you will find important allergens of different seasons of India, for example, spring, autumn and winter. Various grasses and weeds are listed there within point parts. Pollen calendar of parasite plants to 12 different states, which was based on the study. The pollen calendar of 12 different states was published. This is a very old one actually, I think almost more than 20 years. So these to be revised actually and I think in future. What that contains is, we find from different states is a picture like this one. One side it is a botanical name which you are using in a day-to-day practice. Another is the local vernacular name, right side is the local vernacular name. And the whole calendar is divided into 3 color codes. Green is the start of the pollen season. Peak season is depicted with yellow and the red is the end of the season. So 10% this side, 10%. So you find 2 types of pollen grains here. One is a perennial in nature with seasonal exaggerations. You can see here. Yeah. Yeah. So the perennial in nature, the seasonal reservations, the yellow one, where a queue are confined only to certain marks. So another calendar, just to give you an example, they are very specific. There are no perennial in India. This is from hill regions, that is from Kashmir to almost Guwahati, including Arunachal Pradesh. So study conducted at 3 port centers are indicated. They have got their own calendar and there is specific in between system. Some are predominant in October, November, some are predominant in March, April. So just I will quickly go through the important allergens actually which you use in your day-to-day life. For example, ciliaris. This is a grass will come more predominant in July and September. The another one is Impereca. This is a summer grass and is mostly in June and to October. This is Cynodon brachylan, dhoop grass we find in day-to-day practice, and this is a perennial in nature with seasonal exudations. This is Ova patensis. Ova is not yet included probably in Indian list, but we have done a lot of work and find it allegedly. This is Artemisia. This is Parthenian right side, you know very well. Xanthium, Chilocodium, again Parthenia. This is Rismus communis. This also produces a lot of work has been done and is an important emergence of the country. Not only North India but also predominantly present in southern part of the region. The trees actually, this first one is Prosopis juliflora, most important northern part, particularly in Rajasthan, Beauty and Madhya Pradesh. The colon distribution of Holocalia and Trilocolia is again a very huge tree, and even one tree present in a particular city or urban area is good enough to induce this allergic symptoms in very high pollen production. The whole tree gets converted to this with no least effect. She just saying. Someone can utilize, what is this? This is Bhojpatra. This found at high altitudes actually. This is birch pollen, very important in European countries. But in India it's not that because when the fruit trees are there at high altitude more than 6,000 feet and above in the Himalayan region. But this is very important for the local population who are residing in the hilly tracts. So this birch pollen, this bedflower very precious. All plants have been elaborated in this particular book and Atlas of Euclid in the Praga written by us. This includes more than 100 plants at indigenous origin or Indian origin. So this is also the data aerological monitoring and information on day-to-day basis used for public awareness as also for physician awareness. For example, European pollen network, entire Europe actually 138 stations are available from where the data is made available to the patients on day-to-day basis, the electronic media as well as the print media. In US also there are 82 stations and the data is made available to the patients and physicians every day on the television network, on the print media and so on. So in Australia and New Zealand also. In India, however, Patel Chess Institute Delhi has initiated daily digital display of the total pollen count at BP Chess Institute there. However, the individual accounting allergens are yet to be not available corporate records. This is how the data is made available over in the print media as well, predominant pollen on day-to-day basis. The few words on new emerging pollen allergens in India which is likely to impact our population in future. Based on in vivo and vitro studies of the security energy patients in India were established the important allergens of high altitude, that is Betula, Citrus deodara, Miletus, Ulmus, and so on. After studying there in detail, goes into the skin prick test, we had bronchial challenge, and even ICD, specific IG monitoring. So we have found they are important, very from 3% cases carry 10% of the patient. Olive tree plantation in India. Olive means from which the olive oil is produced. It is not planted in India so far, but during the last 10-15 years, it has been planted in huge quantity in Rajasthan, Gujarat, and so on and so forth. So it is a very important allergen in Europe. It was already characterized their molecular level and important components have been revealed. So they are introduced in India, particularly in Rajasthan, like Bikaner, Jhunjhunu, Nagaur, Jaipur, and so on and so forth. Is planted more than 1 lakh trees have been planted. Our idea is to make the country self-sufficient in olive oil. But at the same time, knowing that they are highly allergenic, why should you introduce unless some pilot study is done with them in the Indian population now and also after 2-3 years? Thank you, Yildiz.
Thank you, sir. Thank you for your phenomenal lecture. Indeed, it's an opportunity for me to say a few words for sir. Sir, not only a doyen in the field of allergy, but also a person with a very human touch. And it's a grateful moment for me to chair the session with sir. Thank you, sir. Any questions from the audience? Yeah.
So is there any particular way, like in our clinical practice, how can we remember these pollens so that we can apply them to the patients? It's an ongoing process, basically.
Any other questions?
So we have a lecture that is a diagnosis of respiratory allergy. So in that whole one unit is about the allergens. So in that book it is given what are the allergens prevalent in that particular area, is north, south, east, west. And then we have come out with a pan-India common allergens. So you can start with the pan-India common allergens, and then after that your knowledge, with your knowledge, practice knowledge, and with the help of the medical department, and whatever the possibility is coming, so you can add or delete the element. So that will be covered under the topic.
I would now request Director Sir to please felicitate Dr. Nitesh Gupta. We can now break for tea.
Yeah, just wait, just wait. What we do quickly, we have another 5 minutes, so we can just introduce ourselves so that everybody knows each and every one. I think that will be better. So I'll start from myself. I am Dr. Rajkumar. I am basically a pulmonologist and the director of this institute, working in the field of the allergy since my studentship. So you should introduce yourself from where you are, what you are doing. So that's what basically, so that we know from which place you are coming from.
Good morning to all. I am Professor Fagis, Associate Professor in Pharma Medicine, UT Cambridge.
pediatrician practicing in Rohini, Delhi.
Hello, I'm Dr. Rupa, senior resident at JJ Hospital, Mumbai.
I'm Dr. Kriti Agarwal, I'm lecturer in JJ Hospital, Mumbai. Hello, I'm Dr. Shabila Karti, I'm assistant professor at JJ Hospital, Mumbai. Thank you,
Good morning, sir. Good morning, all the faculties. Nice being here. I am a senior resident from JJ Hospital. So our HOD was not very happy when we were giving her the letter for leave for 5 days. Ultimately, she was Dr. Preeti Mishra. So ultimately, she was fine when she didn't focus for our academic benefit. So she was fine with that. Thank you.
Hello, I'm Dr. Vinan. I am Director Professor of Community Medicine at KHS. Hello, I am Nitin Goyal. I am Associate Professor of Community Medicine here at SSU. Hello, I am Dr. Shyam Prakash. I am Professor of Community Medicine at College.
Hello everyone, I am Dr. Yogesh Kumari. I am assistant professor in NCR IMS Medical College, New
I'm Dr. Susan Sebastian from St. Stephen's Hospital, Delhi, and HOD of ENT.
Good morning, I am Dr. Mukul Patil. I am a pediatrician and a pediatric critical care endocrinologist. I am working as a pediatric PICU sergeant in St. Stephen's Hospital.
Good morning. I am Dr. Avinash Kumar from Sonipat, Haryana. I am an ENT specialist.
Good morning, everyone. I am Dr. Naresh. I am practicing as an ENT surgeon in Dhaka. Good morning, everyone. I am Dr. Lalit Kumar, Assistant Professor in the Department of Medicine, Government Medical College, Good morning, sir. Good morning to everyone. I am Dr. Okishwan Bhattacharjee from Kolkata. I am practicing in Kolkata. The consultant pharmacologist here.
Good morning, everyone. I am Dr. Salman Khan. I am ENT senior resident in Naras Medical College.
Good morning, everybody. Myself, Dr. Nitin Bhutani. I have completed my master degree from the Indian Medical College, and I am now practicing as a private physician, and I am interested in emergency and allergies. Thank you.
Good morning, everybody. I'm Dr. Prachi Gupta, practicing as a consultant pulmonologist in Zydus Hospital, Ahmedabad.
Good morning everybody, I am Dr. Melba Napoleon, a ENT consultant in Narayana Health, Gurgaon. Hi, I am Dr. Anshu Joshi, practicing ENT in Lucknow.
Hello, everyone. I am Dr. Harikrishna Reddy, working as Assistant Professor in the Department of ENT at Government Medical College, Goa.
Hello everyone, I am Dr. Ketchuman Shilpa. I am a consultant pulmonologist and intensivist at Shisham Hospital, Gurgaon.
Good morning, everyone. I'm Dr. Chirag, pulmonologist, assistant professor in Medical College, Kannada. Good morning, everyone. I'm Dr. Aditya from Ritesh Medical Console. I'm working at Good morning, everyone. I am Dr. Ankur Mishra, associate consultant, Lotus Villalabad, Pulmonary Medicine.
Good morning, everyone. I'm Dr. Zina Sultana, ENT surgeon working at Delhi ENT Hospital, Jessore, Delhi.
Good morning to all. I am Dr. Ajay Rai, senior resident in the Department of Pulmonary Medicine, Gurgaon Hospital.
Good morning, sir. Myself, Dr. Kuldeep Singh, practicing at Hospital. Good morning, everyone. Myself, Dr. Vijay Raju, practicing as a pulmonologist in Uttar Pradesh.
I am Dr. Ashwin, working as a senior resident in Good morning everyone. I'm Dr. Ritika Gupta, Senior Resident ENT in FH Medical College, Jaipur. Hi, good morning everyone. I'm Dr. Ashima Chopra. I am a private practicing ENT surgeon in Delhi. Good morning everyone. Myself Dr. Amavi Kumarato, ENT specialist in Jaipur.
Good morning everyone. Myself Dr. Vivek Mahadev, ENT surgeon from Gujarat Hospital.
Good morning everyone. Myself Dr. Sivasana Ashma, working as a consultant pulmonologist in the Institute of Medical Sciences, Global.
Good morning, I'm Dr. Asutosh, practicing at Mumbai.
Good morning everyone. I'm Dr. Lakshmi Singhal, Assistant Professor, Department of ENT, Muzaffarnagar Medical College.
So, Dr. M.P. Singh, I think you must be thinking the shift. So there is a drastic shift from pulmonary to the ENT basically. Very good. So that's basically our aim was to expand the allergy practice in our country, and I think we will be happy of everything to what people have thought of how it is expanding basically, and expanding and shifting. So I think we from the next workshop we have to also change some strategy basically. Earlier we used to have only one lecture and one ENT person in your faculty, and I think from the next step we have to include more faculties and more lectures. Yeah, so good, very good. So thank you so much, and we'll wait for the team for 10-15 minutes and then we reassemble here. Thank you. And Mr. Manoj, Dr. Manoj is also here. So anything if you require, if you want any services, anything, you just let him know. Yeah.
Versus irritant, which is prevalent. For this we have Dr. Parul Mekpuri. She is associate professor in our institute only. So over to you, madam, for the irritant versus allergen.
So I'll cover this aspect of allergy, allergen versus irritant, allergen versus irritant, which is relevant to us. So first of all, what an irritant is. Irritant usually are non-living substances or ingredients that are causing irritation by virtue of their physical property itself. Examples of irritants would be smoke, oils, detergents, and even cold air itself can act as an irritant. The other common examples include wood dusts, then you have welding fumes, solvents. Irritants can affect any part of your body, including the exposure. If it is to the eyes, then it will affect the eyes or the skin and even the respiratory tract. There are certain particular occupations that has been found to be associated with particular irritants, like the persons working in as laborers or at construction sites usually have exposure to the cement dust. The car mechanics usually have exposure to isocyanates. Then we have spray painters that again have exposure to isocyanates. Hairdressers that are exposed to various kinds of decoloring agents and hairsprays. The people working in hospitals, like the staff nurses or the cleaning people who are helping in the cleaning, are then associated with various kind of disinfectants. Now, what is an allergen? An allergen is, in comparison to the irritant, it is a living substance which is usually a protein or a glycoprotein. And it, by means of its reactions, these are usually causing IgE mediated reactions. Most of the allergens are very, very small proteins or glycoproteins, and the specific property of these proteins is to interact with the innate immunity. Allergens are broadly classified into 4 categories, that is the inhalants or the aeroallergens, contactants, then the ingestants or the food allergens, and the injectants or the insect allergens. The examples for aeroallergens would be house dust mite, that is very common, pollens, molds, animal denders, and insects. The examples of contact allergens would be nickel, cold, topical creams, formaldehyde, and the examples of food allergens would be seafood, milk, egg, and various other kind of food items. The examples for the injectants would be bee, wasp, or fire ant venom, latex, and drugs. Common indoor allergens include cockroaches, animal dander, dust mites, and molds. Common outdoor allergens most commonly are either pollen or outdoor fungal allergens. Coming to the pollens, as sir already told you, are broadly classified into 3 groups, that is weed, grasses, and trees.
Now, the pollens can be dispersed in the environment primarily by two means. Either they are carried by the insect, in that time we will call them entomophil pollens. That is, these pollens are usually scant, heavier, stickier, and of less clinical significance as far as the allergic disorders are concerned. The other type of pollens are the anemophilous pollens. Those are transmitted by the wind. They are of more clinical significance to us as these are smaller and can be dispersed to the far off places and are usually produced in large numbers. The pollen allergens lead to a group of diseases that we collectively called pollinosis. It includes the whole spectrum, that is the allergic rhinitis, asthma, conjunctivitis, and the atopic dermatitis. There are various risk factors for the pollen allergy, primarily being the age and the gender. The smoking also influences our susceptibility to the allergic disorders. There's always a diurnal variation that is seen as the release of the allergen per pollen is not constant and it varies from day to day. Other risk factors include the seasonal variation. As we all know that all the pollens usually will not be seen throughout the year except for few. Few pollens are perennial, but most of them, and even the perennial pollens will have some seasonal variation. Other include respiratory infections. If we are already having any respiratory infection, then we will be more susceptible to have allergies, or ethnicity as well as regional variation is seen when it comes to the pollen allergy. Other risk factors include the exposure to the air pollution, as it is known that the pollen particles combine with the pollutants to form bioallergens that are much more allergenic than the usual pollens, and their pollution thus affects the allergenicity of the pollens. Coming to the next important, that is the dust mite. Now, what are these mites? These are basically micro living organisms, minute sac-like structures, and the allergenic proteins responsible for causing symptoms are their dead skin and excreta. Mites are broadly classified into house dust mites and storage mites. House dust mite include the dermatophagoid species. The storage mites include the Blomia and the Tyrophagus species. Dust mites, as we all know, grow best in the humidity, especially in the mattresses, pillow, and bedding. The risk factor, thus, the most important is temperature and humidity. We have to remember that mites live only when the relative humidity is above 50%, and they could grow very well at 25 degree centigrade temperature and 80 degree relative humidity. Risk factors include, again, seasons and climate. Though house dust mite are present throughout the year, however, seasonal trend is there as the mite concentration is higher in the pre-monsoons and minimum during the winters. The species variation also has been seen. Various species are found in different parts of the country, and also it differs from country to country. Least population of the mites has been recorded as per study in the months of November to February, and high concentrations are seen in the month of July. That is just because of the temperature and the humidity factors that persist during that season. Coming to the animals, now pet allergy is again a very common form of allergy that we often encounter. Most often the allergy is seen to cats or dogs, but other animals like rats, mice, guinea pigs, hamsters, pet birds, horses, cow or poultry can also be involved. Risk factors are again younger age at the symptom onset, positive family history, and other associated allergic disorders. Coming to molds, another important allergen. Molds are broadly classified into outdoor molds and indoor molds. The risk factors associated with mold allergy includes humidity again, the ventilation, the content of the biodegradable material that is present at a particular site also influences the growth of the fungal allergens, and the presence of pets, plants, and carpets. The insect allergens, as the airborne allergens, the insect allergens can be fragments or products of the insect's vital activity. Common insects known to result in allergy are cockroaches, gnats, candy flies, moth flies, mosquitoes, and daphnia. Now, insect allergy may also have seasonal variations. Example would be vast aquatic insect emergencies, as candy flies, mayflies that is seen. Now, most of the insects are perennial, like the cockroaches would be an example of that. Then again, you can have indoor and outdoor form when it comes to insect allergy, as the redwood is found both indoor and outdoor. However, mayflies is found only in the outdoor rural environment. Coming to the main topic per se, that is allergens and irritants. Now, what is an allergen? As we already discussed, it is a substance that can cause allergy but is not harmful to most of the people. Allergen when present, it is not essential that it is going to cause harm to all the people sitting here, but only to the ones who are allergic to it. it triggers a Th2 response. And when we talk of an irritant, it is a substance that causes irritation, specifically tending to produce a physical irritation, and it will produce that irritation to everybody. The extent might be different for everyone. And it basically is triggering a inflammatory response. Now, how they differ at the pathology level? When we talk of irritant, now what happens? The irritation is a result of direct inflammation arising from the release of the pro-inflammatory mediators. The cytokines result in activation of the innate immunity, thereby directly recruiting and activating the T lymphocytes, and there is extensive denudation of the epithelium. On the other hand, when we talk of an allergic reaction, what happens whenever an antigen is exposed to the B cell, there is release of the IgE which goes and bounds to the mast cell. So this is your first exposure to the allergen. What happens when you are exposed to the same allergen again? The antigen bridges the gap between the two antibody molecules, resulting in degranulation and histamine release, and there is where you develop symptoms. So here we see, this is how we are able to detect allergy by means of skin prick test. So what happens whenever we prick the skin with the allergen cross-links the IgE and activates the mast cell to release histamine, and what we develop is the wheal and flare reaction. So one of the most important thing to remember is that allergen is something that may make memories that last forever, which is not done in terms of, the memory is not formed by the irritant if we talk about. So in contrast to the direct tissue damage that is being induced by the chemical irritants, which subsequently is leading to something that we call local inflammation, the induction of the allergy responses by the allergen results in antigen effector cell and memory T cells. So allergy will always be remembered by your system. So this is what happens whenever there is irritation. Non-specific innate immunity works and results in the chemical toxicity and cellular activation. In terms of allergy, there is specific immunity, adaptive immunity that is working, and activation of cytotoxic T cells. Both results in necrosis, apoptosis, cytokine release, and inflammatory infiltrate. So irritants do not mount an IgE antibody response. That is one of the most important aspect of it, and thus cannot be tested by means of SPT, as we already saw that how a skin prick test results in a reaction and we are able to detect it. So at that level, irritants cannot be detected by means of SPT. So also we need to understand that whether a house dust mite though is an allergen, house dust in totality isn't an allergen, cockroach is an allergen, grain dust, cotton dust is not an allergen. By definition, so irritant is a substance that causes irritation. Allergen is a substance that causes allergy but is not harmful to most of the people. Pathophysiologically, irritant is initiating an inflammatory response and allergen a Th2 response. SPT should never be done when in terms of irritation, and AIT is possible only when we are talking AIT, that is allergen immunotherapy, only when we are talking in terms of a allergen. However, avoidance works for both of them. That's all from my side. Thank you.
If there are no questions, I thank Dr. Parul and I request Dr. Sonam to continue with the session. Yeah. I now invite our director, Professor Rajkumar, to speak on allergy diagnosis in vitro.
Okay, so in fact there is some change. The lecture was history taking, and the next was after history taking, the next lecture was difficult asthma. So history taking will be taken by Dr. Ayendra Prasad. He is going to come, he will join. So I will directly go to the allergy diagnosis, but before that I just spend on the 5 minutes detailed history taking Dr. Ayendra Prasad will take, otherwise the continuity will be lost basically. So I will just express on the history taking. History taking is very, very important. Before you start the allergy diagnosis, history is very, very important. So whenever you are going to take the history, that's very important that you sit down with the patient. The patient should be comfortable, you should be also comfortable, and for the allergy history you have to spend some time basically. Spend some time with the patient and let the patient tells you whatever the patient wants to tell. You should not interrupt the patient unless he says, I have told whatever I have to tell. Because from that only history you are going to grab the important points. And after that only you are going to decide whether the patient need the allergy testing or not, and if the patient needs allergy testing, what are the allergens I need to keep in my kitty while doing the allergy testing. So that is very, very important. I'll just give you the example. Basically, whenever the patient says that the patient has a maybe rhinitis or the bronchial asthma, so you should go ahead with history, that what are the aggravating factors and what are the relieving factors. Very, very important. Then aggravating factors, suppose the patient says that during the change of the seasons, basically I have a problem. So from there you have to catch, during the change of the season I have the problem. So you can go ahead with more expansion of that change of season. Which month basically change of the season, maybe in the month of the April, May, or in the month of maybe October, November, and so on, September, October, November. So which month is very, very important. So then it is a perennial or the seasonal. So throughout the year the problem is there, or only during the change of the season or during a particular month. So I'll give you an example. When the patient says, I don't have the problem throughout the year, I have the problem only during the month of the March, April and the May, or April, May basically. So, and rest of the months I'm perfectly fine. So whatever the patient has a history, like patient has a rhinitis or the patient has a bronchial asthma, exacerbation occurs during the during the season, maybe April, March and April. So now it's very, very important indication that anything which is present in the atmosphere during the month of the March and the April may be the culprit basically. So here what you will have to think that, okay, after that you should ask the patient when the patient has a problem more indoor or more outdoor. So because these are very, very important. The patient has a more problem outdoor or more problem indoor. So if the patient says, no, indoor absolutely I don't have any problem, but whenever go out and in the month of the March and April I have a problem. So now your mind should start thinking, okay, which allergens may be culprit in this patient, a allergen which is outdoor basically, and a allergen which is more prevalent in the month of the March and April. So this is the culprit. So in this way the history, and then of course you need to know your pollen calendar. You need to know what are the pollens which are prevalent in the month of the March and April. So you can have the list of that, and then you can keep these allergens in your kitty for doing the test. This is the one example. Suppose the patient says, I don't have the problem, I have the problem only in the indoor basically. Whenever I come to the house, more in the night I have the problem, but outside I don't have the problem. No seasonal change is there. It's a perennial. Maybe basically whenever I go to the bed I have the problem. Coughing is problem, rhinitis exacerbation is problem, or whenever there is a dusting inside my home, at that time I have the problem. So suppose the patient has a problem only in indoor, no outdoor, there is no seasonal variation, perennial, then my mind will start thinking a allergen which is there in the house perennial throughout the year, and basically the allergen is the indoor only. So what are the allergens which are indoor perennial? Then my mind will start thinking about maybe the insect, maybe the fungus, maybe the house dust mite, maybe the pet at the home. So these are the 4 things which your mind should start asking for that, and then accordingly you prepare your kitty. When you want to do the allergy testing, you prepare the kit which are mostly the indoor allergens, and you do the tests. So very, very important. So 3, I think history he will be dealing more detail and everything, but 2 or 3 points are very, very important. 1, whether it's a perennial or the seasonal. Second, which is more outdoor or more indoor. So these, if you calculate with these 4 parameters, I think your 95% work is going to finish. Sorry. So this type of the history is very, very important. I am not touching the food allergy, because food allergy is a subject in itself where we are going to do how to take the history and everything, so that we are going to discuss separately. So, but for all these allergens, already Dr. Parul has divided into two parts basically: irritants, what are the irritants, what are the allergens, and what are the different types of the allergens: inhalant allergens, contact allergens, maybe insect allergens and everything. So how it becomes like the pollens, then the molds, then the your indoor allergens, insects, and the house dust mite, and the fungus. Fungus basically can be present outdoor also and the indoor also. Its characteristic is they are present outdoor also, the indoor also. So you should have idea that that if suppose the patient says I have a problem in the house and you are suspecting fungus, then you should ask the patient, is there anything dampness in the house or any fungus is there in the house, and so on. So in this way the history, you need to spend much more time in the history taking. This history taking will be dealt by Dr. Anand Prasad also, and while dealing with the diagnosis of respiratory allergy, a bit of history will be taken care here. With that background, I will go after the history has been taken, and you know that okay, the patient has to go, the patient is maybe the allergic to these are the allergens to which, and then I need to go for the allergy testing. So allergy testing in vivo and in vitro method, two different types of the allergy testing can be done. I am going to deal with the in vivo, and in vitro I think tomorrow Dr. Mahesh is going to deal with that in vitro method. So whenever I am going to do the allergy testing, I need to prepare two things. One, preparation of the patient, already history has been taken. I have to ask the patient that don't take any anti-allergic medicine. So any anti-allergic medicine should not be taken. And the second, I need to prepare my setting, my place, and I need to discuss what are the allergens to which I am going to test. Again, I told you in the beginning that there in the market you will find around 200 allergens are there. So don't test with 200 allergens. According to your flora and fauna of that particular area, you should prepare your kit with maybe 30, 40, 50, whatever the allergens you want to start with. To help you, already guidelines are there. You can start with the pan-India allergens. With that background, I will just go with in vivo allergy diagnosis, and I will spend much more time in the practical things, because after this, tomorrow we are going to do the allergy testing, skin prick test. So I will go slowly, but all the practical things, theoretically you can read it from the books and the manual also. Okay, so again I will not go into detail about the concept of the allergy diagnosis. I told you in the beginning, first slide was this only, that history taking, after that preparation of the selection of the patient, then preparation of the patient, and then preparation of your allergy testing room, and then doing the test and interpretation of the test. That is very, very important, which I am going to tell. Depends upon these allergic reaction, depends upon the offending allergens, like prior sensitization to the offending allergens varies according to the genetic predisposition, and exposure load and the duration of the exposure, very, very important. And of course the environmental pollution load in the area. Dr. Parul has told, whenever there is an increase in the pollution, the allergenicity of the pollens increases. So that's why when the pollens and the pollution contact each other, basically the allergenicity increase, the problem with the patients will increase. Concentration of the allergen specific IgE in the patient serum, these are the, and what are the indication of the allergy diagnosis? Food allergy, atopic dermatitis, allergic rhinitis, allergic rhinoconjunctivitis, allergic asthma, insects venom hypersensitivity. Testing can be done in the ABPA. In this, generally for the fungus, intradermal test is done, and for the diagnosis of the latex allergy, drug allergy, and so on. So basically these are the indications of allergy diagnosis. And again, there is a exposure in the beginning there is a exposure, basically in the first there is exposure and then the sensitization, and then after that you will get the allergic diseases. So this sensitization and the allergy are different basically. So whatever the test you do, positivity of the test is just a sensitization. So don't treat the sensitization, don't treat the positive result. You need to see that whether this result is significant or not. When it is significant, then only you treat that patient basically. So how can you make out that it is significant or not? Whatever the test is there, correlate with, again go back to the history, sit down with the patient, correlate with the history, and if it is correlated, then it becomes significant, it becomes allergy, and then you can treat with the avoidance or allergen immunotherapy, whatever you want to decide. Okay, so diagnostic pyramid is very simple. So diagnostic pyramid is first basically medical history is very, very important, then physical examination, then in vivo diagnosis tests, and in vivo basically skin prick test, then intradermal test are important ones, in which the skin prick test is the golden standard for the diagnosis. In vitro test, of course serological tests need to be done, and there are many cellular tests are also there, maybe basophil activation and everything, then specific IG determination, and sometimes you need to do the organ challenge provocation test, that is done in the tertiary center and very less for maybe research purpose and so on. So mainly we need to concentrate on the skin test, in that also skin prick test, and of course the specific IgE component tests are also there, that is also will be told, but on an average these are the two tests which are commonly being done and so on. So in vivo skin prick test, intradermal test, patch test, challenge test, so these are the in vivo tests. In vitro test, blood test, total IgE, specific IgE, component resolved diagnostic test. But out of these, what do we choose for this class? Practically these are the things which are very, very important. One is the skin prick test and the specific IgE test. So we'll see which is better basically, and what are the advantages and the disadvantages of both the tests, which we will see. If you see basically there is a need of the standard allergen for any test, whether it is diagnostic or the therapeutic, and how you can have the standard allergens or standardization and everything. There is a separate lecture on this, which I will not go into detail and everything. So what is the difference basically immunologically, what is the difference between these two tests? Skin prick test measures the reactivity to the mast cell bound IgE. So here mast cell bound IgE is measured, where in case of the in vitro test does not measures the bound IgE but only circulating IgE. So these are the two important differences, circulating IgE and the bound IgE test, and so on, and so on. Now if you see the difference between two, skin prick test is a quick results are there. So immediately you do the test, wheel formation, erythema formation, you see in front of your eyes, 15 minutes it take. Whereas serum IgE it will take basically at least 5-6 hours, next day result will be there. So advantages are quick test. It is recommended as a diagnostic test for the first choice of the various authorities. All the guidelines have recommended the skin prick test, better sensitivity and specificity, I will show you that. And then there is no interference with the high total IgE test, clearly demonstrates the patients in their allergy, so it will wheel formation will be there, and resembles physiological reaction to the allergens. So the clinical correlation is excellent with the skin prick test. It is good with the serum IgE also. The cost is very less in case of the skin prick test, whereas specific IgE is high, and then selection of the allergen is excellent, and serum IgE selection of the allergen is good, because a lot of problem will arise when you go into the practice of the allergy, because we are staying here in Delhi, maybe in our country, India, so skin prick test, the local allergens are available and you can do the test. Whereas for the specific IgE, for the some it is there, but not for the all basically. So these are the problems which comes when you start discussing. These problems are there, but still it is reasonably okay and so on. Now, advantages of the serum IgE test is that because specific when you do the skin prick test, you need a normal skin. Suppose there is a problem in the skin, you don't have the normal skin, what to do? At that time, of course, you have to depend upon the serum IgE test, and of course, if the patient is there on the medication, you are not able to withdraw the medication, the patient is not able to leave the medication. So, of course, serum IgE test, blood IgE test need to be done. And if suppose some of the patient has a dermographism, then what happens, as soon as you prick, there will be some wheal formation and everything, reaction will be there. So you are not able to do the test. So at that time, serum IgE test is good. In the pregnant female, basically it is advisable to do the serum IgE test, then the skin prick test. So serum IgE test has advantages in some cases. Coming to the food allergy, which I will discuss, because food challenge test, when you want to do, it's very cumbersome, it's very difficult. So for some of the foods, they have recommended serum specific IgE to be done as a diagnostic, as a diagnosis of the allergy, food allergy. Now coming to the sensitivity and the specificity, and the specificity is much more in case of the skin prick test compared to the serum IgE test and so on. And of course, if you see the difference between the positive predictive value of the skin prick test versus specific IgE done by the immunocap system, basically it favors skin prick test in both inhalation and the food allergen and so on. The SPT results were better correlated with the symptoms than the immunocap for the inhalant and the food allergens and so on. So with that background, basically how to do the test. So I'll go practically how to do the test and everything. So I have told you, these are after taking the history, you need to prepare. Now you have taken the patient, you need to prepare the patient, means withdraw the antihistaminics. On an average, all the long acting antihistaminics should be drawn for 7 to 10 days, and short acting maybe 24 hours to 48 hours. So you need to prepare. If the patient, the allergy testing can be done at the two places, arm, forearm and the back basically. So if in the arms there are hairs and everything, you have to shave the hair at least 24 hours before doing the test. So preparation of the patient is very important, one. And the second, prepare yourself also. So your allergy testing room or allergy testing center should be prepared. So you should prepare for that patient what are the allergens to which I am going to do the test, one. And the second, emergency tray should be ready. And you should be able to manage the patient if there is any anaphylaxis. So management of the anaphylaxis is very important. How to do that? Of course, there is a lecture on the management of the anaphylaxis and everything. So preparation of your allergy testing is divided, allergy testing room is divided into two parts. One, preparation of the kit, and then you be prepared for any untoward event which is going to happen. So, and then after that you do the test. And when you do the test, it's very important, the patient should be full stomach, it should not be nil orally, full stomach, and patient should be comfortably sitting, and the technician who is also doing the test should be comfortable while doing the test and everything. So selection of the patient, very important, essential component of the allergy diagnosis, selection of the patient. The knowledge of the allergen of that area is very important. Already Dr. A.B. Singh has shown you the pollen calendar basically. And then the preparation of the patient, I have told you, preparation of the allergy testing room, knowledge, emergency tray, etc., preparation of the allergen kit for the test and interpret. So these are the important component of the allergy testing. Already this has been dealt, I will not spend time on that. I told you the question which was asked by doctor, that how do I know that which are the allergens to which I will do the allergy testing and everything. For practical purpose, For the beginners, I think best is you should have the Pan India allergens which are there. You can start with that. Couple of tests you do, maybe 50, 60, then you'll find some test is coming negative. Omit that. That allergen may not be prevalent in that particular area, and maybe sometimes you can discuss with the botanical department and everything what are the prevalent allergens you can include in that kitty. So this will be also told while taking the lecture on the guidelines for the diagnosis of allergy and so on. Success depends upon how you are testing, basically how you have prepared your patient, then what are the devices you are using, and placement of the test, from where have you bought this tract. So all these things are very, very important for your success and so on. Skin test, already I told you in the beginning only that the confirmatory test, simple, rapid, low cost, highly sensitivity is high, and reproducibility is also there. So the skin prick test can be done by the lancet or the 26 gauge needle. So the lancet you can use, and you can use the 26.5 gauge needle also. So what is going to happen basically when you do the test, you have to basically, what happens, you need to clean that arm and the forearm, you have to clean it with the spit swab, and then you can just hold it, let it dry, and after that, whatever the allergens you have selected to do the test and everything, so take a drop of the allergen and put a drop on this. Before that, what you can do, you can mark basically. Suppose you are going to do with around 20 allergens and so on. So you can mark 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 allergens you can mark. And these marking, the distance between two allergens should be around 2 to 3 centimeters. Distance between two allergens should be 2 to 3 centimeters in case you are doing the skin prick test. In case you are doing the interdermal test, it should be 3 to 5. But 2 to 3 is okay, and you have to leave these creases, and these creases, you have to leave that area. And if there are any vessels, prominent vessels, so please don't do the pricking and everything in that area. You have to leave that place also basically. So after that, you can put a drop of that allergen, so you know that what is 1, 2, 3 mark, everything has been marked, what are the names of the allergen. You can put it a drop of the allergen, and then after that, after putting the drop of the allergen, from that allergen only, basically, either you can use the lancet or the needle, and you need to prick. The pricking should be around 45 degree angle, and just prick the skin. You will just prick the skin. Tomorrow we are going to show you, and you are going to do it. So, and after that pricking, so you should use the separate lancet for the separate allergen. Please do not use the same needle or the lancet. Most of the people use it, because last time also when we are discussing, most of the people were saying we will clean it, we will heat it and then use it. No. For all the allergens, separate needle or the lancet need to be used. So you can prick it, throw it, and then after that second you prick it, throw it, prick it, throw it, prick it, throw it. And after that you can put a blotting paper so that whatever the extra allergens are there, that will be absorbed, and after that you wait for 15 to 20 minutes and then see the results. The results will be seen, you have to see wheal formation and the erythema formation. But for the Indian condition, erythema formation is not taken into account. The wheal formation you need to take into account. Another thing is very, very important, that you need to have a positive control and the negative control. So positive control is taken as a normal saline is taken, negative control is taken as a normal saline, and the positive control is taken as a histamine basically. With that background, contraindication of the skin prick test, basically we have already told abnormal skin dermographism, the patient is not able to withdraw the medication. So what are the medications we need to withdraw? So these are the medication which you need to withdraw, already has been given in case in the manual. But on an average, long-acting antihistaminics around 7 to 10 days, short-acting around 24 to 48 hours and so on. So whenever you are doing the test, mind it, very, very important that the patient should be comfortable and the technician who is also doing the test should be comfortable. And very important that there should be a proper lighting, your antigen should be prepared beforehand.
sitting comfortably, you have to put your hand and then our technical person is doing the test. Inside your room there should be emergency tray, there should be a bed, oxygen and all those things should be there. If there is any untoward is going to happen, then you should be able to manage basically. So what is going to happen, it's a prick method, you can just prick it and that's fine. Through this drop, you need to prick it. That's the one thing. And nowadays you can do with a lancet. It's a basically puncture test can be also done. So what happens? You just through the drop of the antigen, you just puncture it. So prick and the puncture. These are the two ways you can do. But on an average, prick test is preferred much more. Intradermal test, we will explain you how to do it. Intradermal test can be done by putting the antigen in case of the dermis and so on. So what are the materials should be there when you are going to do the test? Already these tables are there in your manual book. So allergen extract, positive control, negative control, lancet, split swab, then disposal, where to dispose the lancet, marker, then ruler, and then blotting paper, gloves. All these things should be there. And of course, patient position, lighting, adequate, and all those things are there. Material I have already told you. And then allergens, we have already told positive control and the negative control. Negative control is saline, and in case of the skin prick test, is a 50% glycinated saline is there, and for the positive control, histamine is there. Important factor, importance of the standardized allergens. I am not touching it because there is itself a lecture is there, so I will just escape this slide. And of course, devices, I have told you that lancet should be there. Again, lancet also available in the market. Two types of the lancet are there. One is the 3 mm tip, that should not be used. And whenever you are doing the test and everything, the blood should not come. If the blood is coming, so that means your test is not correct basically. So 1 mm tip lancet is advisable. So whenever you buy the lancet, ask the company to give 1 mm lancet. Otherwise you will get 3 mm lancet, and that is going to injure the basically skin. Already told that it can be done in the arm, forearm or the back, and the distance between two allergen should be around 2 to 3 centimeter. And again, before the test, area should be clean, antihistaminic should not be used. Mark the test site with a marker and put a drop. Marking is there, then you put a drop, and then through the drop basically you need to do the test. All these things will be done by you, explained, demonstrated, and done by you people only. So if you go more detailed diagrammatically, so you need to go around 45 to 60 degree wrinkle and gently go beyond the skin and just push it basically. So there is a gap between the skin and the antigen goes inside. So that's the way basically you need to do the test and everything. And this is like cleaning of the process, dropping of the antigen, then needle use or the lancet, then how to do it, and of course then you interpret and so on. Again, it's a diagrammatic presentation. So drop is given, this is the drop, then needle goes inside, and then you just pull it basically. You have to lift it, rather lifting should be done. And the correct way is you should lift the needle basically. The needle has to be lifted so that the gap occurs. It's incorrect. If you needle last end is lifted, so there is no gap basically. The gap does not come, so that is incorrect technique. So this is the correct technique when you lift the needle. Basically, that will be the correct technique. And the wheel formation. Then after that, after 15-2, I told you. After that, blot it. Don't wipe it. So you blot it. If you wipe it, there is a cross-contamination is going to occur. So that is very, very important. So wipe it. You can keep the blotting. Ask the patient to wait for 15 to 20 minutes, and then you see the patient. Wheel formation has to be there. And again, the wheel formation, how to measure the wheel formation. There are
two ways of doing measuring the wheel formation by the scale, and there is circular scale is also there. So I don't prefer to use it because sometimes it is not circular. If any wheel is circular, then it's fine. Basically, you can do it. Otherwise, you have the maximum diameter. This is the D capital. This is the maximum diameter, and perpendicular to that, this small d. So capital D plus small d divided by 2 becomes your wheel size for that particular patient, and so on. So this is here also is given by the circular one. If the wheel is circular, I think that's good. Otherwise, if it is not, then please do not use the circular marking and everything. So again, what is for till you are coming with only positive and negative, this way of measuring is correct. When you are planning for the immunotherapy, then 1 plus 2 plus 3 plus comes into the picture. But till this place, any size which is more than equal to 3 mm of the negative control becomes positive for that particular patient. Again, I am repeating, any size which is 3 mm or more of negative control. That means if your negative control is 0, then any size which is more than equal to 3 mm is positive. If suppose your negative control is 1, suppose negative control is 1, then 4 mm becomes positive. You got the point? You are all with me? Yes, okay? So if the negative control is 2 mm, then 3 plus anything which is 5 or more becomes positive for that particular patient. That's okay? These are followed all over the country. These are the consensus statement which has been taken from American Academy and the American College of Allergy, Asthma and Immunology, which is prevalent till now. And then performing intradermal tests, I will not go into detail about that. Here intradermally you need to inject the antigen to formation for the formation of the bleb formation, or 0.01 to 0.05 ml of the antigen need to be injected intradermally. And if you see the skin prick test and the intradermal skin prick test, the concentration is more. It is around 1:10. Some places they are taking 1:20, but for the intradermal it is 1:500. So I have already told you about the wheel formation. Erythema formation we are not taking into account because in the Indian condition lot of dark skin is there, so erythema is very difficult to find out. So wheel is taken into account for the measuring the diameter for the skin test and everything. Again, now till now I have told you that any size which is more than equal to 3 mm of the negative control becomes positive for that particular patient. I'll slightly deviate from here because after that you have done the test, you have found out positive, correlated with the history of the patient, and it is clinically correlating. Then if you want to go for the immunotherapy, then conventionally whenever you want to go for the immunotherapy, then you need to grade this your test by 1 plus, 2 plus, 3 plus and 4 plus. So if your buffer saline is 0, means negative control is 0, then 1 plus is 3 to 5 mm, 2 plus is 6 to 8 mm, 3 plus is 9 to 11 mm, and the 4 plus is more than 11 mm. Got the point? So accordingly, if suppose your normal saline or negative saline becomes 1 mm, so accordingly everything will change. It will be 4 to 6, 7 to 8, 10 to 12 and more than 12. Got the point? So all are interlinked basically. So this grading also you should remember, because I think the need of this grading will come after maybe tomorrow or day after tomorrow, when we'll start with the conventional immunotherapy by SCIT method and so on. So this is clear basically till now, everything is clear. So anything more than
equal to 3 mm size of the normal saline is positive. Got the point? If this size increases by 1 mm, everything will increase by 1 mm. Again, for the grading purpose, 3 to 5 mm is a 1 plus, then 6 to 8 mm is 2 plus, 9 to 11 mm is 3 plus, more than 11 mm is 4 plus. Here also, if your normal saline negative control increases by suppose 2, then everything will increase by 2. Then it will become 5 to 7, then 8 to 11 and so on. Got the point? Absolutely no problem? Okay. So again, for the intradermal, I will not go much into about I will not go in the detail about the intradermal because mostly we are not doing with the intradermal. Test reporting is very, very important. You must pin down the test report, what is the size and everything, and the name of the center, name of the physician, contact address, date, time, current medication, which test has been done, what are the panel has been taken, which company panel you have taken, you have used Lancet or you have used needle, where have you tested and how have you measured and everything. A word about prick to prick test. In the juicy material, now the consensus comes. For the juicy material, maybe apple, maybe orange and so on. Juicy material, you can do the prick to prick test. So you prick the juicy material and you prick the skin. So it becomes prick to prick test. We also did the prick to prick test and we found out when we compared between the skin prick test and the prick to prick test, we found out prick to prick test was much better than the skin prick test, and this is also in the consensus statement and the other guidelines and so on. Patch test, I think there is a lecture for the patch test. I will leave that, I will not touch upon anything. Different forms you have to be there. The consent, before you do the test, the consent is very, very important. The consent form has to be filled up. Other forms are also there. Maybe tomorrow we are going to show you the forms. You can use the forms, just change the title, Patel Chess Institute, you can change it and you can put your brand and you can use these forms. You are allowed to do that. Food allergy, I am not going to touch. There is a lecture. I am going to take a lecture in full 25 minutes lecture for the food allergy. I just wanted to give you just a one-line statement that perceived food allergy, whatever you think or the patient thinks, perceived food allergy is much high than the actual food allergy. Food allergy is there. We did a study where we found out perceived food allergy was 60%, but the actual food allergy was 4%. So what should you do? Should ask the patient, all the patient to stop eating and everything? No. Before you ask any patient, please, that message I will give when I will take the lecture. So whenever you ask any patient to stop anything, rice, chawal, dal, chana, anda, banana, milk, curd, before you ask anything to stop, you should be 200% sure that the patient is allergic to that particular food. That's the one message I will give tomorrow basically. So food allergy, we will go into detail about that. Then the in vivo provocation test. The provocation test can be done with the allergens, directly by the allergens to see if they are hyperreactive or not. Hyperreactivity can be found out, but these are the things which can be done in the tertiary center and of course for the research purpose and so on. And so to summarize, we need better management for the allergic diseases which can be enhanced by appropriate diagnosis of the allergy. SPT is the preferred diagnostic method for IgE-mediated hypersensitivity. In vitro test may be utilized in case where the SPT cannot be done. Standardization of the allergen is the issue, which is very, very, very important. And of course, the nasal provocation test can be done whenever needed, but that should be done in the tertiary center for the research purpose and so on. I think I try to make it very clear that when you are going to deal with the allergic diseases patients, you should spend some time for the history taking. History taking is very, very important. I will go on repeating about this because till you start the immunotherapy, history is again has to be correlated. And for the testing, you need to prepare the patient, you need to prepare yourself, your allergy testing room, and then you need to do the test. While you are doing the test, it's very, very important that you should be very careful. You should have all the drugs available in the emergency tray to manage any kind of the anaphylaxis. Anaphylaxis is not the percent, is very less, but if it happens, you should be able to manage. We have a lecture for that, and then you should interpret the result. Test is only sensitization. Test positive test, you should not treat the positive test. You should correlate with the history of the patient. If it is correlated, then you decide whether you want to do the avoidance or you want to do the immunotherapy, which we will discuss. Avoidance and the immunotherapy we will discuss in the separate lecture and so on. So with that, my lecture is over. For this particular lecture, if you want to ask anything, you can ask. When we will talk about immunotherapy, we will discuss this. Only how to take the history and how to do the test. I am concerned about that. I can give you the answer, but let it happen at that time. On an average, basically testing, it is being told 2 to 5 years. 5 years there is no problem. 2 to 5 years, relatively yes. 102 years, plus minus. But it is now the consensus has come at any age there is no bar of doing the test. If you are 100% sure that the patient may be allergic to that, but this should be done by the pediatrician. That will come in the consensus statement which we are going to cover. But that's a pediatrician domain, so they should be allowed to go.
I think a kind of limited result. You said 16 to 20 minutes.
15 to 20.
15 to 20 minutes. So suppose somebody has a late reaction,
Reaction can be there, so that also you can tell the patient basically that if there is anything happens, you can inform me after maybe 4 to 6 hours. You don't have to ask the patient to wait.
do you consider it as a positive?
No, we will not consider it.
5 year or 10 year they should do for ENT? More than 5 years. More than 5 years. We can do.
Leave other things for the pediatrician.
About the negative control you told about the saline, what about the histamine control? I mean positive control.
Histamine is a positive control so that you know that actually the patient is reacting to the histamine. You are giving histamine directly. Here also you are releasing, when you are releasing histamine from the mast cell. So you know, if histamine is negative, so that means somewhere something is wrong. Means the patient might have taken any anti-allergic medicine. Your histamine itself may be not correct. So for that reason.
So histamine comes, normally histamine should be positive, or like if it is positive for 3, 4 or 5 mm, then how should we interpret it? It should be more than +2, more than histamine.
Positive should be there, that's all basically. Your skin should react with the histamine, that's all. All the grading and the interpretation need to be done by the negative control. How long? After doing the test, for the reading there is 15 to 20 minutes. So you can do, means you do all the tests, do the negative control. Ideally, basically what happens.
I just want to give a very clear message. Not all the patients should be advocated for the allergy testing. It's not like that you are practicing and you know that this much money I have to get it for the allergy testing. So whoever comes, you do the allergy testing, you do the another. No, that's a really wrong practice. What the point? Message is very clear. The selection of the patient is very, very important for allergy testing, more so for the immunotherapy. We'll discuss immunotherapy, how to select the patient as well. But selection of the patient for the allergy testing is also very, very important. Pardon? Repeat skin testing. For what? What is it? Okay, so suppose the patient has come negative and your history is strongly positive, you can repeat. Even it comes negative again also. If history is very, very strongly positive, they say, no, I have your reality is wrong, and then you can do different approach. So check it. With the skin prick test, false negativity is more. With this intradermal test, false positivity is more. So earlier the intradermal was done. All the patients used to be positive, false positive. So you can repeat it. What we do in Patanjali's Institute, you should not do it. That we do the allergy testing, then whatever the positive comes, then we repeat it. But that's not the way.
Sir, if patient is on antihistaminic, then how many, after how many times we have to do the test? The first dose, the patient has taken the antihistaminic tablets, and after how many duration?
I told you in the beginning, twice I told you. All the long-acting antihistaminics used to stop for 7 to 10 days. Don't do the test. But it's not like that. Today the patient has come, I have to do the test. Okay, I have to get rid of everything. You do the test. No, this is not point. So that's why use and the misuse of the allergy and immunotherapy is very, very, very important. And as a lot of people have started this branch of the medicine, it's more so important that use and the misuse of this branch is there, because till today there is no officially training center or degree and all those things. So everybody in a half-day course also the people learn and they start doing it. So this is just a sensitization. Today also I am telling you, after 5 days also this is just a sensitization. You cannot become allergologist. Do you know in the USA how many years you have to practice, you have to spend, and what is the degree you need to take and before you go to practice? You know? 3 years in allergy and immunotherapy. Then only you are allowed to practice. We cannot become a specialist in allergy. We are sensitized. So small things, very, very, very taking caution and everything you can start. Now you want to ask me.
Prick test, should we use the peel of the system or not?
You can peel. Because you can peel it off. You can make a juicy material of that and the prick. Not for, that's right. It's not advocated for everything, but to do juicy material. Suppose somebody says, I have a problem, I take the orange, I have a problem. Your skin prick test is coming negative. But he or she says, whenever I take in the mouth, there is some tingling sensation, some problem is there. So now what to do? I can try this also, prick to prick test also to prove this. So it has been found, it has been compared between prick to prick test and the skin prick test. It has been found in the consensus statement also the prick to prick test is slightly better than the skin prick test. Corticosteroid does not hamper with your skin prick test, but you should stop it. At least 24 to 48 hours before you stop it. You don't have to. Oral also you don't have to. That's why I am telling you, it is not going to happen the early reaction. But on an average you should stop it. Inhalation you can take it.
So, what if normal saline turns out to be 3 ml or more?
Accordingly everything will go through.
So, we will take it
It's not a drop. You have to just, the epidermis should touch your antigen. That's all basically. Drop because you cannot, how you put antigen has to go basically. So we have to do it in this way only. This is the technique which has been come out.
Like you sir told in for the intradermal test there was a value of
For intradermal it is a value. For the prick test there is no value. Intradermal you have to inject. Here you have to just prick. So you have to, when you have to inject, there also the line is just a bleb formation or 0.01 to 0.05 ml has to be injected. So when I used to do, now we are not doing, I used to do at that time only the bleb formation is there, forget about it. Yeah, the concentration I told you always that the concentration, there is no need of giving the antigen inside basically because the concentration is much higher than the intradermal dose. That is 1:500, this 1:10 or 1:20. Any more questions? Because this is very important. Why I am telling you here, you have to learn only three things: history, testing, immunotherapy. Only three things.
SPT.
Yeah.
Sir, when we write the results, we have to also mention the pseudopods and erythema or not?
Erythema, you should not mention. Pseudopodia is there, so whenever pseudopodia is there, what you are going to do? If the diameter will increase, the highest diameter you take, that's all basically. Earlier, with the intradermal, if there is a pseudopodia, it is 4+, earlier it was there, for the skin thickness it is not like that. So, like, this is like this, pseudopodia is there. The highest diameter is this, perpendicular to this. So your purpose is what? Pardon? 3 into? जोर से बोलो, हिंदी में बोलो, कोई बात नहीं।
If it is like 3 into 1 millimeter, then we consider the 3 into 1 ratio.
3 plus 1 divided by 2. So 4 divided by 2 is equal to 2 mm size. Then I don't know what he wanted to ask.
So
What was the question?
It is like rectangular set. Like
If it is less than, that's what, 3 mm or more is positive. If it is less, it's a negative.
so length लेना है ना स्टाफ के divided by 2.
ये wheel formation ऐसे होगा ना, ऐसे होगा wheel formation. This will be wheel formation. Phase is जरा नहीं so this will be wheel formation है ना, ठीक है. Then again, because there are many things which I am leaving for this. So where do you mark? With the marker you have to mark it, no? So if this is a wheel, so touch the outer portion of the wheel and marker should be like this. Mark. Then the maximum diameter is this much. So suppose this is 8 centimeter and perpendicular, in the mid perpendicular to this is maybe 6. So 8 plus 6 divided by 2 is equal to, the root is equal to 7 is the wheel formation, 7 is the size for this. So if it is more than equal to 3 mm size is positive, so this is positive. If I go with the 1 plus 2 plus 3 plus, if saline is 0, so it becomes 3 to 5, 5 to 7, it becomes 2 plus. कोई जरूरी नहीं, आप 7 लिख दो, as you plan your chart, so accordingly you can put it. So what we do after this, we put a adhesive tape on this wheel and then put it on the result chart so that nobody can challenge our result whatever we have given. अभी तक तो negative का है. Now some researchers are coming, they are doing the ultrasound and they will do the sometime in derma scan. For my research purpose. I don't know. वीडियो भी कर सकते हैं, है जी? Not recommended. That's a good question. I also did not know. Pardon? हाँ, normal में अगर वीडियो हाथ में है तो पीछे कर लो. So wherever there is a normal, इसको ना vertical I also wanted to know कि क्या है, but it is not recommended. But there are normal skin where you can do it. There is no problem. Don't do anything. Don't do the test. Treat the patient with the medication and let the patient be comfortable. When the patient is comfortable, you should be comfortable. Exactly, no literature says that cannot be done or something like that. For the safer, for the apprehension, basically it is told that not do the test. But for the immunotherapy, when we discuss that immunotherapy, if the patient is already on the immunotherapy, then continue the immunotherapy. If the patient has not started the immunotherapy, don't start the immunotherapy. But I feel personally, if the patient becomes pregnant, immunotherapy is there, the literature says the immunotherapy will affect and everything. But I feel immunotherapy should be stopped because anything will happen that will be correlated with the immunotherapy. So why unnecessarily create some problem in the mind? It's better to stop. What I feel. But the literature says you can continue. In between, if you stop, no, it will not. This question we will discuss when we will do the immunotherapy. Okay? So, till history and then diagnosis of the allergy. Okay? Any question? Because these are very, very important. Other things you can read it. If everybody is on the same pace, then I think, should we do another lecture? Haji? Ek lecture karna hai. Karo. So I think the next lecture will be taken up by somebody. Yeah. So thank you so much and thank you so much.
Thank you, sir. Thank you, sir. You will be the master class today.
And for the next lecture, I would like to invite Dr. Parul Mekpuri. She will be taking a lecture on Indian guidelines of diagnosis of respiratory allergy. I welcome you, ma'am, on the dais.
So now I'll be taking the lecture on the Indian guidelines for diagnosis of respiratory allergy. So these are standard guidelines that have already been published in the Indian Journal of Allergy, Asthma and Immunology as well as the Indian Journal of Chest Diseases and Allied Sciences. These guidelines basically comprise of three main parts. I'll just be able to sensitize you through because this is a very, very comprehensive document, about 100-page document with 1000 references. So I cannot do justice to it in just 20 minutes, but I'll try and move you around because some of the things that the guidelines deals, we have already covered that. The first is the history taking in the relevant examination, that is the part A of the guideline, followed by the allergens in the respiratory allergy, and then finally comes the diagnostic testing. It deals with both in vivo and in vitro part of the testing. The guidelines is basically in the form of questions and it answers most of the questions that are associated with the diagnostics in allergy. So, what are the common respiratory allergies? It starts with enumerating the common allergic diseases. What are the various symptoms of the allergic diseases? What are the signs? And what is the importance of the age? When we talk of signs, the guidelines deals with the various kind of signs present particularly in children, like the mouth breathing, the allergic salute, the allergic nasal crease, facial grimacing. I think these terms are very, very known to the pediatricians sitting here. For rest of the people, now what is this allergic salute? So when you have children with allergies, they start doing this thing. So that results in a depression here that we call the allergic crease. So allergic salute, such kind of signs you will see in patients who are allergic. Age is a very, very important factor. Asthma phenotypes we have already discussed. Then, does family history has a significance? Again, a very, very important factor. So, if a child is born to a parents who both are allergic, then there is 50 to 80% of having an atopic child. Then, what is the importance of area of residence when it comes to India? It has a wide geographical difference, and as you have listened to sir, who already told you that the flora and the fauna is varying from one state to another. So here comes the importance of residence, where you are living. So in the history, you have to take into account that what are the important allergens in that particular area. Then the relevance of indoor-outdoor allergens, as we have already specified, when we are talking of indoor allergens, our focus is going to be on the house dust mite, it is going to be on the insects, it is going to be on the pets, but when we talk of outdoor allergens, pollens come to the utmost importance. Now the importance of seasonal variation, here it is what are the seasonal allergens, what are perennial allergens. So most of the insects like cockroaches and HDM are examples of perennial allergy. If we talk of seasonal allergens, then pollens usually have seasonal variations. Even certain perennial allergens can come with seasonal variations. Then what is the significance of work or the occupational exposure? Again, where you are working is very, very important part of the history taking, because that is the place where a considerable amount of time is spent by the person. So you always has to ask you, what do you do, where do you work? For an example here would be beekeepers. Now if they are having allergy to bee venom, so they'll be very, very susceptible to have anaphylaxis. Then what is the significance of recurrence of symptoms? We already talked about this, as allergy makes memory. So recurrence is very, very important factor when you are eliciting a history. Whenever a person is allergic, the reaction is going to repeat itself. It is not like that, I had orange one day, I didn't have any allergy, I had it another time, I had allergy. So usually the patients who are truly allergic will give recurrent symptoms. What is the relationship of food? Now allergy is again a multi-system kind of a thing. It is not that only one system is going to be affected. So always ask to the symptoms pertaining to the various symptoms, including your eyes, ear, throat and skin, in addition to the respiratory symptoms. Relevance of treatment history. Treatment history again is very, very important. In terms of testing, as we were already discussing, if you have to take a patient for SPT, you need to stop certain drugs. Also, if the patient is on certain drugs and you are doing the testing or giving immunotherapy, then you have to see, because if anaphylaxis occurs, certain drugs interfere with your medications that you have to give while treating the anaphylaxis in that patient. So there comes the importance of treatment history. The second part is allergens in respiratory allergy. We have already seen 4 types of allergens, discussed them. So guidelines particularly focuses on these allergens, that is the pollen, fungal spores, house dust mite, insect allergens, certain animal allergens and occupational allergens. The question 1 is, what are the source, location, risk factors and clinical significance of pollens in causation of respiratory allergy? So this guidelines comes as a blessing to the practitioners, as it has give you a comprehensive location of the allergens, that which allergen is prevalent in which part of the country. So there is a complete table that shows, a red tick shows the symbol means prevalence shown only by the pollen concentration in the air. So it is basically 2 things. One, that that particular allergen is present in the air. The second is that it is causing sensitization. So the red tick denotes that it is just present in the air. However, the red tick, the black tick denotes that it is also causing sensitization on SPT. So it gives you complete detail along with the location in the various parts of the country in the form of northwest, south, east and central India. So there's a complete detail also enumerating the common names and classification into grasses, trees or weeds. The pollen sensitization that was seen was varied across different parts in India because of the varied geoclimatic conditions. Now, why is pollen calendar important? As we have already been talking, pollen calendar again is very, very important in terms of taking the personal protective measures. As we told you, we do have a pollen count display station. So that is of public health importance. Whenever their pollen counts are very, very high, they can be displayed and we can issue public health warnings. The other important comes in terms of diagnostic as well as the therapeutic purpose. Diagnostic when we are doing the SPT and selection of the allergens, therapeutic when we are planning allergen immunotherapy. Then what is the importance of pollen count in particularly? Yeah, that's discussed. Then what is the source, location, risk factors and clinical significance of HDM? So as per the guidelines, HDM sensitization was found in 11 to 88%, varying across India. Source, location and risk factors and clinical significance of fungal allergens. So again, the guidelines gives you a comprehensive detail of which fungal allergen is present in which part of the country in terms of north, south, east, west and central India. This is all based on the data that is already there and an extensive review of the old data. Now the common allergens that was found was Aspergillus, Penicillium, Cladosporum. And the common fungal allergens to which sensitization was elicited included Aspergillus fumigatus, Flavus, Niger, Tamari, Alternaria, Rhizopus, Cladosporium, Curvularia, Fusarium helminthosporum, Mucor, Apicocum and Trichoderma. So what are the source, location, risk factors and clinical significance of insect allergies? The prevalence of the insect allergy across India ranged from 6 to 64%. Moth, cockroach, housefly and mosquito were the more common insect that were seen. Source, location, risk factors and clinical significance of others may pet allergens. Now what they found was that dander allergen sensitivity was commonly seen to 3 main animals, that was cow, cat, cow and dog. Now the question comes, as is always asked, how will you choose the allergens for screening of the allergic diseases when it comes to the adults and pediatrics, and what are the different in the two? So there are 2 major aspects to it. First is your clinical history, as we have been emphasizing, and a further lecture will also be there. History is very, very important. First and the foremost thing is that you will take a pre-test history, and once you are interpreting the test, you will again take a post-test history to confirm that what the patient is sensitized on the SPT is actually correlating with the history or not. And second most important is the knowledge about the regional pollen calendar and the other allergens that are present in there. House dust mite, relevant pollens, insects, so you should know that. Only then you will be able to collaborate your history along with the sensitization results that you have. Now, area-specific allergy plan is basically different countries follow different norms. If we see in Europe, they have a common standardized allergic panel that is used for the testing of the patients. If we talk of US, they have a panel that consists of 10 allergens. Now, talking of the how to choose this allergen in the pediatric patients, what is different? So, when we talk of the pediatric patients, the first and the foremost thing that is different is that you have to take into account their food habits, 1, and their school environment, 2, because children are more prone to develop food allergies, 1, and the school environment plays a very, very important role when it comes to the pediatric patients. So, the history has to be very comprehensive, and you have to focus on the school environment as well. So this is the Pan-India Respiratory Allergy Panel. So when you're starting, even if we do not want to be very specific about the area, these are certain allergens that are of clinical importance throughout India. So this is the panel we can always start with. And these are the individual region-wise panels that has been provided by the guideline. Coming to the part C, that is the diagnostic testing. I'll not be going into detail of the in vivo testing. It has already been dealt. Even the in vitro testing will be taken independently, but I'll just sensitize you that what is all. So it deals with what are the various in vivo tests. We have already talked about SPT, intradermal patch test, and the allergen provocation test. Now what are the in vitro tests? It is total serum IgE, specific IgE, and cell-based assay, that is the basophil activation test that is available. Now which test is better? So always we have been telling you that SPT is the gold standard in collaboration with the clinical history. What are the qualifications required? This question always comes up, that what are the qualifications required for performing an in vivo allergy testing? So an allergy specialist, physician or a pediatrician formally trained in allergy testing should perform the in vivo testing. A nurse technician trained in allergy testing can also perform the in vivo testing under the supervision of an experienced allergy physician. And then third, an experienced physician well versed with the management of anaphylactic reactions along with all necessary requirements for the same should be present whenever an in vivo allergy testing. What is important is not that you know the technique of doing the test. Even more important is that you should know to deal with the complications associated with the test in case they happen. So what is the important time for performing? This was another question that was coming up. So at least 4 to 6 weeks after the systemic allergic reactions. Avoid in asthma patients with increased symptoms. Measure IgE levels and perform titrated skin test in those who have high risk of anaphylaxis. So some patient will come to you who says that I have had 4 episodes of anaphylaxis. So now you have to plan an SPT based on history in such a patient. Then usually we are talking about a concentration of 1:10 when doing an SPT. Now when you are dealing with such a patient, you might have to go for lower concentrations even for testing. Depending upon the kind of reaction the patient is undergoing, then you can have a concentration of 1:5,000, 1:50,000, 1:50. So that you have to depend that what kind of anaphylactic reaction is the patient, and gradually then increase the concentration for testing as well, depending upon the reaction that the patient has. Now avoid during the respective seasonal allergy. Again, the reason for this is also the patient might have exacerbated reactions. So what are the indications? We have already discussed. Contraindications, pregnancy, lactation, already discussed. Dermographism. Now why dermographism? Because here you will see that everything, the negative control is also going to become positive only. So you will not be able to get a idea of what is happening. So it is not done in dermographism. Absence of the normal fringe. Here comes the vitiligo part also. Whenever there is absence of the normal skin, जहाँ normal skin ही नहीं है, वहाँ skin testing नहीं होगी. Uncooperative patients, especially pediatricians के लिए ये relevant हो जाता है. You cannot do if the patient is not cooperating. Patients who are taking drugs that may hinder the action of epinephrine. We already discussed it. Epinephrine already अगर है and the patient lands up in anaphylaxis, then your response to the adrenaline will be hampered. So the patients like this, and also if the patient is on antihistaminics. Now relative contraindications, young children, it should be performed in young children when needed, but should be performed under supervision of a pediatrician trained in allergy testing. Lower limit of testing, so guidelines say it should be done in the children more than 5 years, but again, it has a nag in it. With the strong clinical suspicion, may be done in even less than 5 years, but again, under the supervision of pediatrician, that is what we recommend. Next comes the maximum number of allergens to be tested. Though we always say that the number of allergens to be tested should be minimized based on the history, but still if you are testing, maximum permissible limit is going to be 50 when we are talking of adults and around 12 when we talk of children. How should the patient be prepared? Already discussed in detail in the previous lecture. Patient preparation was discussed, the drugs to be stopped. All this is given in the guidelines, and we have already put the guidelines in the group also. Then what is the procedure? The guidelines also in detail describe the procedure, the materials required, the preferred device, how do we do it, the angle that is there, that has already been discussed in the previous lecture. How do we measure it? Complications, local complications, quite common, can occur, just local swellings, late phase response to IG, more in the IDT again. Localized wheal fear ho sakta hai. Systemic complication, anaphylaxis, very, very rare, none that we have seen in whatever experience we have. Vasovagal may occur, but there are ways to differentiate vasovagal from anaphylaxis. That will be dealt in the chapter of, in the lecture of anaphylaxis. Then indications for IDT, one of those was already discussed in the previous lectures. When you have a very, very strong suspicion of allergy and your SPT is again coming negative, then you can go for IDT. Other situations where we do IDT is venom allergy and drug allergy. Then what is the relevance of total serum IgE in the diagnosis of allergy? So it's the sensitivity specificity though is very low, but it is a reliable molecule when you are following the patients of ABPA. For specific IgE, if we talk of in vitro testing, what are the indications? Now, in case of inconclusive SPT and again a very, very high suspicion of allergy, and if you have inability to discontinue the skin testing suppressive medications, आप दवाई नहीं रोक पा रहे, the patient has very, very severe allergy, you are unable to stop your antihistaminics, then definitely you can go for in vitro testing. Then presence of extensive skin lesions. Basically the contraindications of the SPT becomes the indication of specific IgE testing. Uncooperative patient, again it becomes an indication. Clinical history suggestive of high risk of anaphylaxis, again it becomes an indication for the in vitro testing. Then briefly the guidelines have discussed the role of nasal provocation testing in diagnosing the respiratory allergy. So it is of limited value and more recommended in only for the research purpose. Role of FeNO has also been discussed. It is not necessary for making the diagnosis. However, we may use it in certain subset of the patients in follow-up or the assessment. That's all in the guide from my side. Thank you.
Thank you, Dr. Parul, for summarizing the guidelines so well. Any questions from anybody from the audience?
No, it is not required, because even if the patient has anaphylaxis, what you need to do, you need to give adrenaline, and adrenaline is recommended to be given IM. So we are never putting a IV cannula to the patient. See, they are two different. Total serum IgE means you are measuring the total IgE that is present in the blood. When we are talking about specific IgE, we are measuring the IgE that has been produced in response to a particular allergen. Say, if I give you an example of a ABPA, then what we do specific IgE for Aspergillus fumigatus. In a similar way, we can do specific IgE for HDM, house dust mite. So in the market, you have panels that are available, and you can, allergy panels, comprehensive allergy panels are also there that have an array of around 10 to 20 specific IgE tests that you can mark, or you can just ask for single also. So based on your history, you'll suspect some allergens and you'll have some indication to get a specific IgE done. So you'll write specific IgE for that particular allergen. Yes, definitely. So that is how you order it, specific IgE for that particular allergen, as a specific IgE for HDM. And usually when you'll see, say I take an example of some private labs, so they have comprehensive allergy panels that are doing specific IgE for various allergens. So you can ask them for smaller panels or complete panels also. So there are certain smaller panels also, and complete panel is also available. Specific IgE is a little expensive when we talk. I think the market value for the whole panel, though I'm not very sure, might be somewhere around 10,000. Am I correct?
Thank you, ma'am.
So that's why it is expensive. So if you suppose want to do just 10,
which allergen you want to test?
Okay, so thank you, Dr. Parul, and I think we stop here only, and we break for the lunch. If lunch is ready.
Sir, I would like to invite Dr. Parul on the dais, and sir, please present the memento to her, sir. So now we'll break for the lunch, and 2 o'clock again we'll assemble in the same hall, and we'll start with our lecture series. Thank you all.
A and group B. So the group A will be alphabets starting from A to K. A to K. You tell your friends also, A to K will be first group, group A, and the rest group B. So tomorrow, whatever the time is there, कितने बजे है? 9:30. Everybody will come here. So group A will remain here. All will come here only. Then our people will take you to the second group, to the department. So all of you come here. I think there will be 20 minutes lecture also tomorrow in the morning. Then after that, group A will remain here, and group B will go to the department. One announcement is this. Second announcement is, like on Wednesday, we have a dinner for the participants and the faculty. So all are welcome to that. So all will be coming on Wednesday. How many? All. So that's okay. So that we can calculate, no, basically how many. So it's a address and everything will be given. It's a nearby only, and we'll see how it has to be done. That's all basically. We can start, yeah.
Welcome back to all for the post-lunch session. For this session, I inviting the chairperson, Dr. Nitin Goyal and Dr. Vidushi Rathi.
We have with us Professor Ashok Shah for the first talk. Professor Ashok Shah sir is Professor and Head retired ESIC Medical College and Hospital Faridabad. He is former Director Professor of Pulmonary Medicine Department from this very institute and is also former Head University Department of Pulmonary Medicine and Faculty of Medical Sciences, University of Delhi. Sir is Fellow of National Academy of Medical Sciences, has been President of Indian College of Allergy, Asthma and Applied Immunology and has to his credit many international publications in peer-reviewed journals. Thank you, sir. Sir shall be taking a talk on Aspergillus associated hypersensitivity respiratory disorders.
About pulmonologist, about the ABPA, if you search any literature, forefront name will be Professor Ashok Shah. And sir, I still remember first day when I joined Vallabhbhai Patel Chess Institute as a student, first day I had a privilege to sit down in sir's room. I still remember, sir, afternoon, I was there with you, sir.
Thank you very much for inviting me and all the love and affection that you have showered on me for all these years. Nitin and Vidushi, chairpersons. Ladies and gentlemen, it's a pleasure to be here again, and for that I need to thank Dr. Rajkumar and his team. It's the love and affection that I come here, and it's always a pleasure to be back in this hall talking about ABPA and other things also. So I've been charged to talk on Aspergillus associated hypersensitivity respiratory disorders. It's a very perplexing disorder. The fungus Aspergillus can adversely affect the human lung in more ways than one. There are two major mechanisms, allergic and pathogenic. Allergic is when you get symptoms of asthma and rhinitis, and in this comes ABPA also. And pathogenic, whereas invasive fungal disorders and subacute invasive disorders, which have now been started being called chronic pulmonary aspergillosis, which is not the part of our topic today. However, you can still come across this in ABPA and aspergilloma. So, Aspergillus associated hypersensitivity disorders, this is another specific subgroup here, and the first and best known form is ABPA. And the analog of this in the sinuses is called allergic Aspergillus sinusitis, or when it is caused by fungus other than Aspergillus, then it's called allergic fungal sinusitis. Aspergillus-induced asthma, which is now been coming into its own, ID mediated. The first three are mostly in only atopic subjects, but hypersensitive pneumonitis due to massive exposure can be of Aspergillus can be in non-atopic subjects also. So every day we are inhaling a lot of Aspergillus antigens. On when the season is high, you inhale about 50,000 spores of fungus, and in one day you breathe about 10,000 liters, and that 10,000 liters is 20,000 breaths. So you can imagine the amount of fungus that is going in. So fungal colonization is the necessary antecedent event for sensitization in the pathogen. You must have sensitization first. But why some people are sensitized and some are not is still a matter of debate. We still haven't been able to find out after so many years. Now, global warming, you can see the climate changes that is occurring. Global warming is causing all that. And this, with that, severity of indoor and atmospheric mold exposure is going to increase. Fungal growths are going to increase now, so expect far more fungus disorders in times to come. In fact, last week, I think week ending 29th or so, the carbon dioxide levels touched 425, I think. When I wrote an article on that in 2008, that was 380. So you can just imagine what's happening. So the spores are trapped in the in the mucus of the viscid mucus of the asthmatics. They germinate, release the spores over there, and they evoke they have evoke a polyclonal response due to water. Thank you. And they release pro-inflammatory cytokines, and this causes elevated specific IgG and specific IgE and mucus formation. So when we tested aspergillus antigens in 105 asthmatics, we found that 28% of them were 30 out of 105 were sensitive to aspergillus. Out of these 30 patients, 8 of them had full-blown AVP, so that's 27%. And this is the data that comes out from when we published this paper, we tried to answer the question, do aspergillus sensitive asthmatics have a more severe form of the disease? The answer was a resounding yes. We found that, and these are all sensitive figures, they had more duration of asthma, they had more courses of oral steroids, their mean AAC levels are much higher, as well as the total IG levels were all elevated. They're all sensitive data. So sensitization to aspergillus appears to increase the severity of asthma. Sorry, my sinusitis is still persisting. So this is the meta-analysis from PGI where Professor Ritesh Agarwal does a lot of work on AVPA. He's really been yeoman's task in this field. The aspergillus sensitization was seen in 30% of asthmatics. AVPA in asthmatics was seen in 16%, and AVPA in aspergillus sensitization was much higher than ours, 48.2%. So in India, we have a very high prevalence of AVPA in asthmatics. So we do need to screen patients of asthma for aspergillus sensitization. So screening with patients could identify those who are under risk of AVPA. So the AVPA was first recognized in 1952. It's characterized by immunologic reaction in the lungs to the antigens of members of genus Aspergillus, mostly caused by Aphthymicatus, can be caused by other fungus also, but when it's caused by fungus other than Aspergillus, it's called allergic bronchopolymycosis. Usually occurs in atopic individuals only. So this is the first report in thorax. 3 of the 8 patients were a new kind of Aspergillus, and they called it allergic bronchopolymycosis. So in spite of more than 70 odd years, we still haven't been able to answer 2 very basic questions. Predominantly, it's a disease of the asthmatics, but why only few asthmatics are affected? We still don't know the answer. Asthma is known to run in families. In spite of female preponderance of asthma, female occurrence of asthma is a distinct rarity. So when we had 164 patients, till then we had there were a total of 6 reports of familial AVPA. 2 of them was ours, and then out of these we had 4 pairs, 2 parent-child, 2 siblings. Out of the 8 patients, 7 had rhinitis. Out of the 7, 4 had sinusitis. Out of the 4, 3 had concomitant AS. So about 5% of patients had familial AVPA. So we need to exclude AVPA in family members also. So this is the evolving criteria for AVPA. The first one was proposed by Professor Patterson. There were 8 criteria and 3 minor criteria. Then his very close associate and student, I think, Professor Greenberger, he proposed the minimal essential criteria and truly minimal criteria. And then came the Isham working group in 2013. I was privileged. This was the first one that came out with a consensus statement. And 2013 was the first one. This workshop was held in Siliguri, and I was delighted to be in Siliguri because it's about 40 odd miles from where I was brought up in Kalimpong. And this is they proposed this revised criteria for AVPA. So then this group from PGI again reduced that to a very more short one in 21, and they called it modified Isham AVPA criteria. Then came the Japanese group. They came out with 10 criteria, and they said that their ABPM criteria, it was more specific for ABPM criteria. They said if you meet 6 of these 10 criteria, you could call it ABPM. And they brought back the term central bronchiectasis, which was removed in the Isham criteria. And this is now the revised criteria again, 24. Again, the group was led by PGI, Professor Ritesh Agarwal. You must have asthma or cystic fibrosis and even COPD. These are the places where you can hunt for AVPA. Specific IgE and total serum IgE level should be elevated. Then any of these two components, specific IgG, peripheral blood eosinophilia, and 2 sputums, 1 lavage culture to find out the causative organism, and CT should be done. These are also important considerations. I'm sure you can read it up. So, although AVPA is the first, asthma is the first criteria to say patient has AVPA, you can get AVPA without asthma, clinical asthma, and this is a patient of ours who was referred for MDR tuberculosis. This turned out to be AVPA due to Aspergillus niger, and there was no asthma at all. So, in the absence of asthma, it's very difficult to think of AVPA and to recognize it. So, although AVPA is a disease with a worldwide distribution, and more so in India if you ask me, the variable prevalence rates probably reflects the lack of a single diagnostic criterion. We have to algorithmic approach, because you can't say if this is present, the patient has AVPA. There's nothing of it. If you ask me, the most specific ones, in my opinion, still is central bronchiectasis with normal periphery. Is one of the which comes to near standardization. So AVPA is an indolent disease with a protracted course. It ranges from mild asthma to fatal destructive lung disorders. It's characterized by repeated episodes of exacerbations interspersed with periods of remission. But if we do not treat it, the patient is going to have lung fibrosis. It is characterized by wheezing, dyspnea, cough, fluent sputum, fever, and malaise and hemoptysis. Just like any hemoptysis, there's bronchiectasis, chest pain. And a very characteristic feature is also expectoration of goldish brownish sputum plugs. This, you can see, this is a plug which was brought to me by a gynecologist, and this was a plug over there. You can see it takes the shape of a bronchi. But what I'd like to highlight over here is a third of the patients are asymptomatic and can have large X-ray consolidation. So ever since this first description, radiology techniques have been crucial to the diagnosis of AVPA. It helps not only to establish the diagnosis, but also to monitor the progress of the disease. So we can divide into plain chest röntgenogram. We have transient changes or permanent changes. Bronchography for demonstration of central bronchiectasis, which no longer in vogue. The dinosaur was no there. So we compared bronchography with computed tomography in 1994, and we found that it is an effective alternative to bronchography. So, transient pulmonary infiltrates is a very characteristic feature of fleeting shadows. It was called fleeting shadows, but as usual, the Americans have to change things. So, serial radiogram, and this is the best description from the original authors. Serial radiographs are essential to show the sequence of incidents of lobar or segmental collapse and consolidation, first in one part, then in another, and in either lung. So you get a consolidation in one part, then suddenly it disappears and goes. It's a very characteristic feature which should raise the antenna for AVPA. You can see it over here. This is a young boy who had first in the right lung, then in the left one. This is fleeting shadows. Then this is a consolidation, pseudohylar opacity. This is a last 17-year-old with bilateral consolidations. This is another pseudohylar opacity. It's very characteristic. These three patients are normally referred to as malignancy. And you can see the band-shaped opacity over here. This is the classical VY-shaped opacity. The wine glass shadow, the name was given by Professor Menon, not Dr. Bala Menon, but his father, who is no longer with us. And this patient also had fleeting shadows. This is a glove finger shadow that resembles the glove because of mucoid impaction. And lung collapse which opened up after appropriate treatment. Then concomitant occurrence of AVPA, Aspergillus sinusitis, and an operated aspergilloma. You can see this patient had a collapse. In fact, I remember this patient was taken up for bronchoscopy, and I was there. And when we retook the history at the table, we suddenly found maybe it is the AVPA. So he had an operated aspergilloma also. So you can see here, patient had central bronchiectasis, and there was a pleural effusion. Pleural effusion mostly due to mechanical intervention collapse. And this is another patient with middle lobe syndrome and presenting as a middle lobe syndrome, AVA with as well as sinusitis. So this is another rare presentation of allergic bronchopulmonary aspergillosis, that is middle lobe syndrome. This is childhood AVPA presenting with middle lobe syndrome. Air fluid levels you can see over here. Multiple ring shadows. Hydroadenopathy is, true hydroadenopathy was not suspected. Something's gone wrong. Let's go Atana, please. So this is a patient of hydroadenopathy with consolidation, and you can see the central bronchiectasis on CT. चल नहीं रहा. This is a 42-month-old child with true hydroadenopathy. Jay is now a nephrologist, onconephrologist, and Sandeep has just been awarded this year as they're both husband and wife, was the Outstanding Clinician of the Year award in the ATS, American Thoracic Society. So it's good to see that our students are doing so well. One example is just here in front of you, two over there. So you can get cavitation also in AVPA, and this patient was mercilessly treated for tuberculosis before it was recognized as AVPA. Of course, he was also treated for eosinophilia. So radiological changes commonly seen in upper lobe scan resemble those seen in pulmonary tuberculosis. When this paper was presented, 80% of the patients had already received ATT, but now things are much better. People recognize AVPA, and this doesn't happen too often. So this is the best description by Professor Scatting. He was the first to recognize that the first irregular dilatation of the proximal part of this bronchi with a normal bronchial pattern, distal and continuity is suggestive of AVPA. And he called it proximal bronchiectasis, but the Americans again came out with central bronchiectasis. So you can see the cartoon drawn by one of my students, Naresh Panchal. The upper panel is normal, the lower panel is post-infective bronchiectasis, or the normal ones you normally see. And the third one has AVPA. You can see that this is the proximal part is balloon and the other part is normal. But in a third of the patients, the bronchiectasis extends to the periphery. We were the first to demonstrate it. And this study was quoted to say that remove the word central bronchiectasis. I argued very much, but no one seemed to listen to me there. This bronchiectasis is bronchiectasis. So this is bronchiectasis occurs in areas where consolidation occurs. This is another 17-year-old who came up with, and this is a bronchogram you can see over there, central bronchiectasis, and this is a consolidation over there. And in the consolidation, we did the bronchogram, we did this central bronchiectasis. And this is again one part, you can see massive central bronchiectasis, and the left part also central bronchiectasis. This is done in 2 sittings. So these were the 2 studies that we did on CT with the help of Dr. Pant from INMAS. And this is the signet ring you can see in one panel, and the characteristic string of Reule's appearance. And the signet ring, you can also see that there is a which one is it? There is a aspergilloma over here. This is the signet ring appearance. This is very characteristic of a bronchiectasis. And this is a slide given to me by Anand Jaiswal, another student of ours. This is you can see that extending to the periphery over there. There's a central bronchiectasis in 30% of the subjects. So high-intensity mucus plug was first highlighted by Professor Mueller and from Canada, and this is the high atrial, and this was then brought into prominence by Ritesh Agarwal when he found out that when there is when there is HAM, it is suggestive of more severe form of the disease. This is another patient of HAM over here. So in CT, in childhood also, CT was very helpful in childhood AVPA. This is another patient of childhood AVPA, which we demonstrated that CT is very useful. And these are the bronchial abnormalities: bronchiectasis central, dilated bronchi with or without air fluid levels, bronchial thickening, parallel schedule, and HAM. And these are the parenchymal changes, and you also get pleural changes that can occur. So this is the largest series till date on 42 asthmatic children with AVPA. And out of the 349 patients we had, 42 were pediatric age group. And out of this 42, out of this 42, 32 had central bronchiectasis, 10 had AVPS, 6 had HAM. Initially, most probably we must have missed out because of the bronchography also. And out of the 30 with sinusitis, 8 was suspected to be allergic Aspergillus sinusitis, and 3 were proven when we received the consent. We could only receive consent in 3, and all 3 were. This is a glut finger appearance. HRCT showing mucus plugs and bilateral consolidation with air bronchogram. You can see central bronchiectasis in these patients, extensive bronchiectasis. So then the 5 groups have been recognized. This is first suggested by a group from Paris, AVPS, AVPA central bronchiectasis, AVPA mucus plugging, AVPA HAM, AVPA chronic pulmonary fibrosis. One of the first to highlight this was, of course, that what did you call it, Rajkumar? Other features, other radiological features, ORF. He called it other radiological features. Now these people have started calling it chronic pulmonary fibrosis. So in suspected AVPA, the current recommendation by ASHAM is you should get a thin section CT so that you can identify bronchiectasis, mucus plugging, high attendance mucus plugs, and other abnormalities. But the follow-up should be done with a chest radiograph. So this is the same classification, AVPS, but they call it AVA bronchiectasis, not central bronchiectasis. They're still stuck on that one. And mucus plugging, HAM is supposed to be a more severe form of the disease, and AVPA with chronic pulmonary fibrosis, where you can get a fungal ball, pleural thickening, and pulmonary hypertension and respiratory failure. So skin test is now should be positive in 100% of patients, and delayed can be positive in 33% with prick test. And this is the data long ago. 25% had asthmatics with a positive skin test. This is data of 1978, and they were not AVPS. So it was already highlighted as plus sensitization way back in 1978. So this is a patient with a type 3 reaction that took place in one of our patients, huge reaction. Revised ISHAM diagnostic criteria update. They said skin test is inferior to specific IgE, and IgG is superior to immunoprecipitation that we normally do. Lateral flow assays are now available. Recommendation in asthmatics with AF imitators, perform a total serum Ig, specific IgG, and a peripheral blood eosinophilia. So once you have peripheral blood eosinophilia, that's where you start from. It's not the opposite way. Then you do the rest. Because with every every patient you normally get a blood count done, and that is where you should be thinking about. So this is a fall of 35% of total serum IgE. Total serum IgE was thought to be a good response. Doubling of remission levels in asymptomatic is suggestive of a exacerbation. Now this has recommended. Now this is recommended as 20% in the new ISHAM criteria. So total serum IgE levels is, they said that 500 is more sensitive. Minimal diagnostic is more sensitive than 1000 ml. But we see most of our patients also come out with thousands and thousands. Someone the other day put up a question that if they normally give IG levels more than 25,000, they will just say more than 25,000. They will not give a specific. So you can get huge figures also. We once had a patient of 60,000 level also. So APS is a patient who satisfies all the diagnostic criteria but does not have an identifiable central bronchiectasis. It signifies either the earlier stage or the milder form of the disease. No overt damage to the lung, categorized as APS. So high index of suspicion is required in a patient with asthmatics with all these features. And you can see that high index of suspicion, these are patients of 35 steroid-dependent asthma. Those days oral steroids were given much before the inhaled steroids had been advocated. And out of the 35 patients, 3 of them had AVPA, which was masked by steroid therapy. So one has to be careful. So differential diagnosis, AVPA with aspirin sensitization, AVPA with SAFs, that is severe asthma with fungal syndrome. Most probably this is the phenotype of severe asthma. Then Churg-Strauss syndrome, nowadays the new name is EGPA. Asthma sinonasal disease can happen also in AVPA. Pulmonary infiltrates with small vessel necrotic vasculitis. Then this chronic idiopathic eosinophilic pneumonitis would also be excluded. It's a kind of form of an ILD if you ask me. So this is the revised diagnostic algorithm, and they, after thin section CT, they said AVPS, AVP bronchitis, AVP mucus plugs, AVP ham, and AVP chronic pulmonary fibrosis. So this is the new criteria. They have classification criteria: acute stage, acute and exacerbation should be treated the same, and infective. You should also watch out for infective bronchitis exacerbations. Responses when in 8 weeks' time, when this with treatment, all the parameters come down, and if these parameters are sustained for 6 months, it's called remission. And if they are continuously patients having symptoms and exacerbations, then it is steroid-dependent AVPA. And advanced AVPA is when you have all the features: chronic pulmonary fibrosis, pulmonal and hypertension and respiratory failure. So oral corticosteroids continue to remain the mainstay of therapy. This was the one advocated much earlier, 0.5 milligrams per kg body weight. We also tried biweekly and found it very useful. Apart from one patient, we didn't have to withdraw we continued biweekly, and still use biweekly for patient. If I see a patient, it's very useful. Reduces the steroid levels. Azole therapy improves clinical feature, exacerbations, and immune markers. No improvement in PFT. There is a concern about adrenal suppression with ICS and itraconazole. It's a useful adjunct in treatment of AVPA. What I'll highlight here is azole resistance can be seen in up to 54% of the subjects. So the jury is still out on this one. In case of resistance, avoid azole monotherapy, amphotericin B, and combination of voriconazole and echinocandin. So this is a study from PGI. They found that prednisolone induces more effective response in acute AVPA. Itraconazole is also attractive, but fewer side effects. But immediately, use of steroids is more effective. It's an attractive alternative. Then they tried prednisolone and prednisolone with itraconazole. They didn't find it significant, but they said there's a trend towards a decline in AVPA exacerbation at 1 year with prednisolone and itraconazole. But current recommendation is you should not use it together. So these are the other drugs. Nebulized amphotericin B can also be used. Voriconazole, liposomal amphotericin B can also be nebulized. Then there is pulse methylprednisolone can be used 3 days in severe exacerbations. But maintaining therapy using nebulized liposomal amphotericin did not reduce the risk of severe clinical exacerbations. Biologics are under exploration: IgE, mepolizumab, dupilumab. IgE is initially used as an off-label in children with cystic fibrosis. Benralizumab is useful in patients with marked eosinophil and HAM. So this is a study where this is a meta-analysis. Omalizumab, they found that annual exacerbations were reduced, oral corticosteroid usage and doses was reduced, FEV1 was improved, and so did asthma control. Omalizumab, conclusion was, is a useful treatment in refractory AVPA. So these are the doses of omalizumab, mepolizumab, benralizumab, and dupilumab. All have been used. Some of them are sporadic case reports. So this is an analysis of 29 cases, meta-analysis in fact. They got together all the cases. 20 treated with mepolizumab, 9 with benralizumab, and they found that exacerbations came down, oral corticosteroids came down, probably functions improved, and bronchial mucus plug shrank. So despite clinical and radical improvement, there is no change in total serum Ig levels. So it's still under explanation. Tezepelumab, the new kid on the block, has also been tried in one 83-year-old patient or 82-year, possibly a new therapeutic approach. The patient improved with this. It's frightfully expensive, not available in India as yet. Total serum Ig is a good monitor, and initially it used to be 35%, but now it is 20%. But word is, do not treat serum Ig levels. Just because it's high doesn't mean the patient is not improving. Just if it comes down from the initial level, comes down 20%, be happy. So now we come to the treatment recommendations. Asymptomatic AV treatment with systemic therapy not recommended. Only if there is poor control or recurrent exacerbation despite therapy, then you give treatment, prednisolone or itraconazole. And itraconazole treatment initially is only given if there is if corticosteroids are contraindication. First line combination therapy is not recommended, as I told you, is not recommended anymore. Our short course of glucose of steroids can be given for 2 weeks when the patient has got severe symptoms and is put on oral itraconazole also. In acute AAP, antifungals, ICS and biologicals are not recommended at all. Only use their contraindication indication is like systemic glucocorticosteroids or intolerance, failure or resistance to therapy. Is it gone? Yeah. Asthma acute exacerbation, treat like in AVPA. Recurrent exacerbation, combination of oral prednisolone and itraconazole can be tried. Not recommended exacerbation, biological agents or nebulized amphotericin B. And monitoring of therapy, you should use symptoms, chest radiograph, and at least 20% reduction in total Ig. And you should, as when there is when you are using itraconazole, please use therapeutic drug monitoring for these patients. Now we come to the other parts of AVPA, AVPA with aspergilloma, AVPA with AAS, AVPA with all three together. So AVPA with chronic with aspergilloma, even though it forms lung damage is there and it provides a favorable milieu for aspergilloma formation, is rather infrequent. In a background cavity lung disease, formation of aspergilloma may be accelerated by corticosteroid therapy. Is it a more fierce form of the disease? Yes, indeed it is. This is a patient with multiple aspergillomas and a blast from the past. This is a tomogram. It's much before CTs came in. You can see the multiple aspergillomas over there. This patient also had hypertrophic osteoarthropathy. So implications are may cause loss of control of asthma, elevated Ig can be there, more extensive bronchiectasis can be seen, and life-threatening complications, especially hemoptysis. And it can also go on to invasive disease. Now when you come to the nose, aspirin sensitization was seen in a fourth of the patients, and since rhinitis is an important predisposing factor of sinusitis, these patients could possibly be at a greater risk for developing allergic aspergillus sinusitis. The first description came out in from England, but they didn't publish a full paper, and it was Professor Cousenstein, Anna Louis Cousenstein from America, who called it allergic aspergillus sinusitis and established as a distinct clinical entity with the allergic mucin. So this is a study of ours with a patient of AVPA with AAS and familial occurrence. This is the first report of AAS from the country. You can see the sinusitis. We didn't have access to CT those days. So we had 95 patients of AVPA and 22 had radiologic sinusitis. Out of this 22, 9 consented for those that used to have to do a Cudworth-Lack, a very difficult operation to do, and 9 of them consented. Out of this 9, 7 had AAS. This is a patient of CT of perinal sinuses of hyperdense lesions, both ethmoid and maxillary sinuses. And this study, concomitant allergic bronchiolitis aspergillosis and AAS, was published way back. This is mucosal edema and eosinophilic, and scattered, you can see the scattered hyphae of the aspergillus. And this is a patient with all three together, AAP, AAS and aspergilloma. There's still a distinct rarity. Now, COPD shares a few features of pathogens of asthma. Concomitant COPD and IPA is a distinct rarity, and this is a patient of ours who had febrile with paraseptal emphysema, central bronchiectasis, and all the other immunological parameters of AVPA. So in summary, AVPA is a disease predominantly of asthmatics, first recognized more than 7 decades ago. Mystery, only a few asthmatics suffer from AVPA, while the vast majority are unaffected. We do not have a single confirmatory diagnostic test, so that's why a stepwise algorithmic approach is adopted. Oral corticosteroids continue to remain the treatment of choice, the first line of therapy and the cornerstone. Azoles are an attractive alternative for maintenance or remission those with recurrent exacerbation. Oral biologics is being explored. So it's a potentially destructive lung disorder. Early diagnosis and appropriate therapy possibly alter the course of the disease and prevent development of end-stage lung fibrosis. It's not uncommon in a country, so please hunt for it. And if you see a patient with AVPA, please, especially in patients with aspirin-sensitive asthma, please hunt for AVPA. And if you have a patient with AVPA, please exclude AAS also. So this talk was based on the following publications, and I leave you with the words of Professor Isaac Asimov: education is not something you can finish at all. And this is the morning site I used to have in school, the Kanchenjunga and Kalimpong. Thank you very much.
Thank you, sir.
I would now like to invite Professor A.B. Singh for the next lecture. He is an eminent biologist, allergologist with a huge experience and already been introduced earlier. Sir will now take the topic of standardization of allergens and their clinical importance.
Thank you. Thank you, Mr. Chairpersons. Again, we are going to talk about the standardization of allergens. The question whether is it country specific or is it global or common for all the countries. It's not so. I must make it clear the standardization is a country specific subject which is approved by the drug controller government of different countries. So here there is a lot of confusion since the Allergo Pharma came to our country about 4 or 5 years back and started providing standardized allergens. There was a lot of confusion whether the local allergens being produced by the local manufacturers has no relevance as compared to the one provided by the Allergo Pharma. So there was a lot of discussion on the standardization of allergens. Since it is country specific, depending on what the drug controllers of a specific country has approved for production and dissemination to various organizations. So to begin with, during the last 15 to 20 years, there has been a rapid progress on standardization of allergens globally for diagnosis as well as for allergen-specific immunotherapy. However, standardization has been used in different countries in different units. For example, those who are using here, mostly they are given in weight by volume concentrations. Means a definite amount of raw material is extracted in definite amount of volume. If you are using 1 in 50, means 1 gram of material is extracted in 50 ml of buffer, or 1:500 means 1 gram of material extracted in 500. That is the basic qualitative standardization, or the protein nitrogen units, that is PNU. These are the two which has been common in our country. But if you look at the globally allergens, it has been used in different countries as allergen unit, histamine equivalent unit, biological unit, and so far and so forth. So it is again, I will like to emphasize, this is country specific standardization. by which the local manufacturers prepare the antigens. So this confusion has not only due to the large number of different units in terms, but also reflects genuine difference of opinion about the objectives of standardization. What exactly we want to do with the standardization. So there are two contrasting positions that have emerged for standardization during the last 15-20 years. First one, as I told you, that the units used should help predict the biological potency of the allergen extract, so that it is consistent and reproducible. This is what is used by means of prepared, they are standardized based on skin tests or even in vivo tests by measuring the specific IG in this era of the individual patients. That is the standardization, which is biological standardization we call them. But the alternative view is also there. As patients' response are individualized and personalized, any evaluation based on skin test or even in vitro test or serological test depends on the selection of the patients based on skin tested on there and cannot be basis for any long term. Means if we are standardizing the patient's response based on in vivo studies like skin test or even in vitro tests, because every time the same serum set or same skin test facilities will not be available. The patients keep on changing and therefore the variability in their response is also there, so it cannot be there. This is another view. So this view is probably reflected. So there are another, as patients' response are individualized, another view considers that standardization should be aimed at making the quantitative measurements of chemical constituents of the extracts or the antigens we are using. That is referred to as a biochemical standardization rather than biological standardization. Probably this is the view which are reflected in the standardization of Indian extracts by the regulators. So characterization and standardization of allergens allows definition of potency of allergenic extracts and ensures that batch to batch variability from one manufacturer to the other or different batches of the same manufacturer should be consistent. That is the basic idea of standardization of allergenic extracts. If you go a little bit into the historical perspective, the historical units like Noon unit was discovered in 1911 by Noon and Freeman. And what the Noon unit means is 1 microgram of pollen, therefore 1 gram of pollen contains 10 lakhs of Noon units. So accordingly they were standardized as Noon unit, but is no more in use. Another one is protein nitrogen unit or the protein content, that is 1 PNU corresponds to 0.01 microgram of phosphotensic acid at the base. This means PNU. PNU is also no more continued, actually this is a historical unit now. Now coming to the biological actually units, histamine equivalent unit. There has been a procedure in Scandinavian countries, they are using histamine equivalent unit. They compare the skin reactivity with histamine 1 milligram of histamine per microgram, and that's how they are comparing with that one, and they have named it at histamine equivalent unit. Means skin prick testing as the histamine dihydrochloride control at 10 milligram per ml. Then in biological unit, then bioequivalent unit. So these are the various units which are country specific according to their regulators in their country. They are standardizing either on biological or right. I am going to discuss more about the biochemical standardization. That is what is relevant to our country. So partially standardized or the unstandardized allergens vary widely in the biological unit composition regardless of particular weight by volume which you are using right now or the PNU potency, and should not be considered as equipotent. Means the weight by volume, they are variable, very variable, and there are lot of variability from manufacturers to manufacturers as well as from the same manufacturer of different batches of the same allergen. So risk of systemic reaction might be more with non-standardized aqueous extracts which we are using because of this potential variability in the composition and potency of allergen extract. They are likely to vary to several fold. However, clinical experience in India indicates rare systematic reactions to the local allergens. Response to standardized allergens versus the aqueous extract are non-standardized allergens. Comparison of skin prick test in two formulations of allergen extracts can lead to variability in skin testing. If you use standardized and non-standardized, you are likely to find a great degree of variability in the skin reactivity, wheal and flare reactions. What they do, they conducted 123 patient sequential skin tests to subjects with standardized extracts and non-standardized extracts. The standardized extracts gave about 59 patients sensitivity or positivity, whereas non-standardized extracts gave only 35, almost half of what you find with standardized extract. Accordingly, the wheal and flare reaction was also variable. In standardized extract, it was almost 7 millimeter, whereas in non-standard extracts, it was 3.4 millimeters. The Indian guidelines on allergen immunotherapy about the standardized and non-standardized allergen extract, which was published in 1917, and they also again the coordinated efforts are required to upgrade the quality control of allergen extracts produced from India itself. However, recently DGCI has approved biochemical quality control of Indian extracts, that is protein content and protein profile, which are being separated by different protein analysis methods like SDS protein profile, because they are aqueous extracts, allergen extracts. They contain multiple proteins, varying 30 to 40 proteins in one particular extract. The basic idea of there is that if they are performed the standardization process, and in the standardization process they run the SDS protein profiling, means all those proteins 20 or 30 should be maintained in each and every batch from time to time, so that may contain biological activity or non-biological activity, both the proteins are there. This is, however, recently they have been approved by DGCI, but unfortunately is not yet completely implemented by the manufacturers. So guidelines recommends that standardized extracts as far as possible. Even in globally, hardly 10 to 15 allergens have been standardized. In India also, a lot of research work has been done for standardization of allergens, or they are characterized for various types of proteins, but they need to be implemented by the manufacturers actually. So, like European guidelines, also use of standardization of extracts has been recommended. You go to American guidelines, American Academy, they also recommend the standardized allergens as far as possible. So there are two, as I discussed, there are two types of standardization. One is the biological potency based on skin reactivity, and also the serological tests. So concentration of a major allergen is declared as, for example, if the DERP1 means dermatophagitis steronesinus 1, Ambrosia alatea, that is ambrosia means ragweed allergen. It means that DERP1 means doesn't mean that they are purely one. What DERP1 means, they run the proteins, 20, 30 are different proteins, and they react with the sera of the highly allergenic positive patients and see how many patients are reacting to that particular protein, maybe 10 kD, 15 kD or 20 kilodalton protein. So that is considered to be as a major allergen in the practice. Then DERP2, DERP3, so on and so forth. Means next possible, if you only reactive to the maximum number of patients 20, then another one is only 18 or 15, that is considered to be DERP2. Similarly, VETV1, Vetla varicosa, but no such tests are now, no such extracts are still available in our country, where they have done immunoblot studies to find out the major and minor allergens. Well-defined units which correlates, as I told you, bioequivalent unit, allergy unit, histamine equivalent unit, so on and so forth. This is based on
the biological standardization. Chemical standardization includes protein profile, mass spectrometry, ELISA immunoblot studies, and also the protein profiling like SDS protein. Means complete profile that is reproducible in every batch. There are 20 protein bands actually. So that protein band should be available in batch to batch variability as well as from manufacturers to manufacturer. Consistency. Why do we need them? Reasons such as heterogeneity in the natural resource materials. In the morning we discussed there is a lot of changes in the pollen from different parts of the country as well as in you can say from the same sources every time, but because they are preparing these extracts from different pollen collected from various places actually, and that's how there is a natural resources, there is geographical variations in the chemical composition as well as environmental variations in this one. That's why the basis of allergen extract is the raw material, and that we consistently present in every batch with the same purity and same concentration. Most important is safety and efficacy of preparations. And batch to batch consistency has to be maintained. Legal basis production conforms to GMP. Allergen extracts comply with European monograph allergen extracts in Europe and other guidelines for allergen extracts in the global market. This is just to give you an important actually how they are prepared, because these pollen grains they are prepared for the allergenic extracts as per recommendation of the guideline. They should be 90 to 95% pure, means are collected. This should contain only if you are having the particular pollen like prosopis or allergen extract from Ricinus communis or any of the one. This should be 90% pollen rather than the other plant parts. They are actually purified. Other plant parts, sometimes dust particulate matters, sometimes insect debris. They should avoid that. In the top one you can see here pure pollen, almost 90% pollen grains except few. But you see the other one, these are the red one are pollen. There are some fungus contamination, some other things because they process. The raw material should be consistent in every batch. That's why the final product will be. जो जैसे आप न्यू डालते हैं जो वो स्ट्रांग रहेगा तभी आगे फाइनल प्रोडक्ट भी स्ट्रांग और रिप्रोड्यूसिबल होगा. Allergen source materials should be obtained from validated and audited suppliers and are obtained with certificate of analysis confirming collection methods and the source materials. In India, producers collect from fields and process their own raw materials. Here there are 3-4 companies. They are producing from local fields actually, and that's why they are variable from batch to batch, and there was a product also is quite variable. Pollen source materials in Europe are subjected to strong quality regulations, and processes are include purity of foreign contaminations and stability of data. Consideration about pollen used in the production of allergen extracts. What happens in US, they certify only the final product, that is antigen, that is in-house reference, that is the final, this is the quality control is maintained based on skin test reactivity. Then in Europe, they are far more strict, and genetic and environmental factors affect the composition of pollen and the plant varieties by which pollen is obtained, weather and levels of air pollution during plant growth and geographical regions, they affect the pollen. So that's why in Europe they are more consistent. They only certify not only the final product but also the agencies certify the raw material by which the extracts are made. Therefore, appropriate guidelines and training of personnel to perform the activities associated with the pollen collection are essential. There are certain qualities, actually there are qualifications fixed for those who can identify pollen and also have the purity check. Various regulatory institutions which vary in different countries, including the Food FDA actually in USA control how much products should be produced. For example, FDA regulates the manufacturing of pollen extracts in USA, but not the raw material by which the plants are producing and they are prepared for the extracts. So contrary to this, European regulatory agencies, including the European Medicine Agency, control both quality of the pollen as well as the manufacturing process for the pollen extracts which are produced in Europe. So they are more stringent as so far as quality control is concerned. Therefore, Indian regulator agencies, allergen manufacturers, scientific institutions, and pollen collection entities should collaborate to develop and implement guidelines appropriate for the Indian resource materials as well. Just to give you the variability in the pollen, all the extracts are, you have got the extract from Elnas, Betula, Cedrus, Milotus, and see the quantity of protein present in every extract has been quite variable several fold. If you take Elnas, 0.2 milligram per ml, but if you take Cedrus Devdara, it is 1.6. So what I mean to say, this is quite variable and they have to be synchronized. Even pollen collected from different states, different places in the country, for example, Bangalore, Nagpur, Tiruchirappalli, Visakhapatnam, in the same season we collected pollen from these particular places and see the variability of protein content of the same plant, that is Ricinus communis, your castor bean pollen is variable. For example, Bangalore is 3.8 milligram per ml, but in Nagpur it is only 2, just half of that. Tiruchirappalli it is 4 milligram, Visakhapatnam also 4 milligram, and Delhi is 6 milligram. So Delhi is far more higher than the other plants of the that. This is probably, I mean, this is just a hypothesis. Those in South India as well as Delhi, they correspond more together. As Nagpur, actually central Delhi, India, they are only 2 milligram per ml. So this has to be, while preparing the extracts by different manufacturers, pollen collected or procured from different places, has to be standardized while processing the aqueous extracts for diagnosis as well as for immunotherapy. This is the variability I was telling, biochemical standardization. This is the pollen here from different places, and this is stored for different years and they vary. So there has to be reproducible every batch so that we can have a consistency in their biological potency. So non-standardized extracts has got a greater variability actually, from 10 to 100 fold almost, and large batch to batch variability, and variability will also, the variability in the extract will lead to variability in their skin test results as well. In non-standardized or semi-standardized standardized extracts, only 2 to 5 fold variation have been observed, more reproducible for skin test responses because the antigens are also reproducible, and lower frequency of false positive reactions. So it means non-standardized extracts are far more variable from batch to batch as well as from pharma company to different pharma companies, but standardized extracts is only 2 to 3 fold variability. So the main benefits of standardized extracts are improvement in safety and efficacy of the extracts while testing or while providing immunotherapy. We did some efforts actually to standardize, biologically standardize the allergen extracts from 2 allergens, that is Ricinus communis and Holoptelia integrifolia. Standardization of allergens were achieved by in vitro as well as in vivo method like skin prick test as well as serological test. Some of the allergens from Western countries are standardized using biological potency as I discussed. Therefore, we have attempted to standardize 2 important
So now I would like to invite Dr. Prashant Prakash for the next lecture. He is a professor and head of Department of Pulmonary Critical Care Medicine at SN Medical College, Agra, with a large number of publications and a special interest in allergy and immunology. He will be taking his lecture on indoor allergens. Over to you, Prashant sir.
Very good afternoon, august audience. I am a student of allergy, and I am being allotted this topic. I don't know if I will be able to do full justice to it or not. So my topic for today is indoor allergens, and as has been discussed already by at least two speakers, indoor allergens comprise an important part of the morbidity in respiratory allergy. And as we all know, most people spend more than 90% of their time indoors, and office and school are also part of indoor allergens. And indoor allergens play a key role in triggering and exacerbating asthma and allergic rhinitis. The indoor environment contains many allergens. The indoor allergens can vary in different parts of the world depending on a variety of geographic, climatic and cultural factors. Carpeting, upholstering, furnishing and clothing are important reservoirs for indoor allergens. So if we were to talk about indoor allergens, broadly speaking, it's house dust, dust mite, cockroaches, cat dander, dog dander, pet rodents and mold spores. These would be broadly categorizing the 7 different common indoor allergens. Indoor allergens, first of all, when we elicit a history and when we want to suspect if this is an indoor allergen, it has to be perennial, early morning and nocturnal symptom pattern, history of aggravation of symptoms while being indoors, and particularly while doing household work like dusting, blooming and opening old dusty books. Exposure to indoor allergens is not only in the house, it's in daycares and schools, and exposure to allergens can occur directly or indirectly. For example, clothing is the primary transfer mechanism and source of exposure for pet allergens. In Salo et al. In a survey showed exposure to multiple indoor allergens was pretty common in US homes. Nearly 51.5% had at least 6 detectable allergens, and 45.8% had at least 3 allergens exceeding the elevated levels. Elevated allergen levels are associated with asthma symptoms and other allergic systems. So this is house dust mite. This is the classification, won't go into the details. House dust mite. So as I said that we'll broadly categorize it into 4. House dust mite, nearly 1 to 2% of the world population affected with HDM allergy, equivalent to a population of 65 to 130 million. And European Health Survey shows that the mean prevalence of sensitization to house dust mite was 21.7%. The prevalence of sensitization to D. terronisnus was 37%, and D. farinae was a close 34%, so almost practically equal. The best recognized mites, we have basically house dust mites, which are 4, mainly D. terronisnus, D. farinae, Blomia tropicalis, and we have storage mites, which have Acarus, Glyciphagus, Lepidophagus, and as you see, if in the defined allergens, the house dust mites takes the lion's share of defined allergens, with D. terronisnus having 17 and D. farinae having 27. And this is the broad spectrum of HDM allergy, what it can cause. And this is a source from AIRCI, which shows that say if you have 100 mites per gram of house dust, chances are that you will have sensitization. If the frequency is something like 500 mites per gram of house dust, you increase the risk of asthma, and the higher the number of mites in dust, earlier episodes of first wheezing. This is the level of concentration. So we have carpets, we have stuffed toys, we have pillows, and the lion's share taken by mattresses. And the problem with house dust mite allergen is there's a lot of intermingling, courtesy a protein called tropomycin, which is there in house dust mite allergens, which is there in cockroach allergens, which is there in shellfish allergens, and even in helminths, Ascaris lumbricoides. So there's a lot of cross reactivity, and because, as Dr. Rajkumar sir just recently said, your success of immunotherapy depends upon your identifying allergens and zeroing them down to say 3, 2, 1. I mean 3 is probably the absolute maximum. So herein you would require a lot of experience in trying to see that whether there is the allergy really house dust mite or is it cockroach. This is the distribution of Dermatophagoides species. D. terronistus is abundant in Delhi and Bangalore, while Pune seems to have a bias for D. farinae. And the major allergens of D. terronistus are DER-P1 and DER-P2. Approximately 70 to 80% of house dust mite allergic patients are broadly allergic to DER-P1 and DER-P2, and this has the advantage that ultimately they can be, these two allergens particularly can be used for immunotherapy. These are available environmental control measures for house dust mite. Practically every one of them is not very useful. Allergen impermeable encasings are useful, but they are exorbitantly expensive. So the risk factors for house dust mite: the more the dose of exposure, the more chances of allergic asthma. Bed mattress is the major habitat for house dust mite. Pre-monsoon is associated with high count, winter is associated with low count. Increased temperature associated with increased SDM concentration. 50% relative humidity is needed for HDM survival. There is less HDM in higher altitudes because of less relative humidity. House types, air pollution increases HDM, and broadly speaking, again we come to the main factor, cross reactivity. Tropomycin creates a lot of confusion whether this is house dust mite allergen or is it a cockroach allergen or is it seafood allergens. So summarizing, HDM sensitization on SPT in India varies from 11% to 88%, and the dominant species is Dermatophagoides. And there is the only one catch point is the ambient temperature and relative humidity required for HDM to thrive is 25 to 30 degrees Celsius and 55 to 75% respectively, which fortunately or unfortunately matches the average household or office place ambient condition, hence the proclivity of HDM to be an indoor allergen. Coming now, the next is mammalian allergens. They also cause a lot of urticaria, angioedema, contact dermatitis, and anaphylaxis. It's an important group of inhalant allergens, and it's not only those households with pets. You have the source of animal allergens can be domestic or stray animals, lab animals, animals in slaughterhouses, dairy farms, and stables. So the exposure is pretty broad. Animal allergens are broadly produced in the liver or secretory glands and present on the animal's skin and body fluids such as urine, saliva, and blood. And with the exception of the main cat allergen, FeLD1, they broadly belong to one family, which is the lipocalin family of proteins. So mammalian allergens, broadly 4: cat, Felis domesticus, of which the main allergen is FeLD1. And the specific thing about FeLD1 is it's probably the only animal allergen which is not of the lipocalin family, but IgE from over 90% of cat sensitized individuals reacts with this major allergen. And then we have, of course, dog. We've just had a major Supreme Court debate on dogs. CAN F1, CAN F2, CAN F4 and CAN F6, they are all lipocalins. As discussed, about 70% of dog allergic individuals, they are allergic to CAN F1. And there is also one more specific thing, that CAN F1 is detectable not only in all homes with a dog, but also in 1/3 of homes without a dog. So that's the ubiquitous nature of CAN F1. CAN F5 is also now considered a major allergen. Then the next third category is rodents, whether it's rats or it's mice. The prevalence of rodent allergy among technicians, animal caretakers, physicians and scientists working in pharmaceutical industry ranges from 11 to 44%. Urine is the main source of the allergic proteins, whether it is mice is MUS-M1 and rat is RAT-N1, and they're both lipocalins. Insect allergens. Insects make 75 to 80% of the total animal species on this planet. It's a worldwide problem, found indoors, outdoors, homes and at the workplace. And there are host of insects, and their incriminating parts are wings, scales, saliva, dried fecal material and venom. Exposure to low levels of BLA-G1 and BLA-G2 allergens have been associated with wheezing. And this is the table which shows the proclivity for insect allergens. You have seasonal, we have perennial. Cockroach allergy, of course, is very important. There are two cockroaches, German cockroach, which is Bilatella germanica, and this is found more in cool and dry climates, while Periplaneta americana, or which is the American cockroach, is found in the larger hot and humid conditions. Occupational profile is of course important. This is slightly important that in Delhi a major study was done about the SPT prevalence of insects, which ranged from 39 to 44%, and the sequence was moth was most common, mosquito followed, cockroach was between 19 to 25%. This was followed by housefly and rice weevil. A similar study done in northern India, which included cities of Lucknow and Allahabad, they said cockroach female, cockroach male, moth, cricket, locust female, locust male, they are the main incriminating agents. So just a major variation of some figures. My last allergen, indoor allergen, is fungal allergens. Now we have broadly 4 of them, 2 of which are both important outdoor and indoor, which are Alternaria and Cladosporium, and Penicillium and Aspergillus are the more of proper indoor allergens. Various fungal genera, they induce type 1 allergies, estimated at 20% to 30% of atopic individuals. Of course, humidity, lack of ventilation, they account for the main factors. Alternaria, as we discussed, is both indoor, outdoor, and approximately 5%. The main allergen seems to be ALT-A1, which is accounting for 90% of the sensitization. Another one is ALT-A2 and ALT-A5. Cladosporium, another major culprit, and that is both indoor and outdoor. And while Alternaria is more of an allergen in humid conditions, Cladosporium is more of a allergenic mold in cooler climates. And CLAH8 is the one responsible for maximal sensitization. 7% of it sensitization is due to this particular antigen. Aspergillus fumigatus, well, of course, we have had a whole lecture on ABPA, and both ABPA and allergic asthma are characterized by hypersensitivity and presence of A. fumigatus specific IgE. ASP-F1 is responsible for 85% of the sensitization. The others are ASP-F2, ASP-F3, 4, 5, 9, 11, 15 and 18. And last, Penicillium. There are two species, Penicillium citrinum and Chrysogenum. The major allergens of Chrysogenum are Pen CH13 and Pen CH18. And Penicillium citrinum, the IgA reactivity is slightly lower than Chrysogenum. Now, to almost conclude the talk, the most important thing about indoor allergens is mainly two proteins, tropomycin and serum albumins. Tropomycins, they are found in a host of invertebrates such as crustaceans, arachnids, which are basically house dust mites, insects, cockroaches, and mollusks. Immunological cross-reactivity has been demonstrated between all these crustaceans, cockroaches, and house dust mites, suggesting that tropomycin is an important cross-sensitizing pan-allergen. And in this part of India, we have less of eating of seafood, but if we go to another part of India, which is close to the coast, there it will also create a problem when people eat shrimps. So you don't know exactly which allergen, what is the incriminating allergen. And allergic sensitization to serum albumin is also important. Serum albumins are found in the dander and saliva and are important inhalant allergens of cat and dog both. So suppose a household has cat and dog both, so we are in a quandary whether it is cat or dog which is the incriminating one. So cross-reactivity seems to create a major havoc when it comes to indoor allergens. Thank you. Any questions?
Thank you, sir, for that wonderful elaborate talk on indoor air allergens. And now if there's one question.
What kind of vaccination for pet dogs are we talking about?
Sir, routine vaccination of the dogs.
Vaccination of pet dogs, how will it help in causing less symptoms? There are only two approaches to a dog. See, either you go for avoidance or you go for immunotherapy for yourself, because that is the only thing which can be done. And as I just mentioned in my lecture, that even there are very many households where there is no dog and still you have the prevalence of dog allergen. If you go on a very rough way, you know something, suppose if I have a dog, I'm a dog lover myself, I have a dog and I go to somewhere else, I'll find that the dog is pretty attracted to me because he can sense all those that typical dog smell on me. So that's why that's the major problem with dogs. Of course, you have now hypoallergenic species of dogs, which are basically poodle and chihuahua. So they are less allergenic. So if you are a dog lover like I am, as I said, so if I want and I still have problems, so I can do one thing, I won't take a Doberman or a Rottweiler, and I can take a poodle or I can take a chihuahua.
Thank you, sir. So we will break.
Yes.
Sir, some literatures, they do advocate about encasement in case of HDM.
Yes, that is true. Out of my chart, I showed to you the above four measures were practically useless. This was the only one, but this is exorbitantly costly.
Yeah.
Exorbitantly costly. I mean, Dr. Reddy's is marketing house dust mite oral tablets for 300 rupees per day. I think it would not be a bad idea if you go for that option rather than encasement of things. I mean, that thing is going to thousands and thousands of.
No, second question, I've got the second question is that
Yes.
even after removal of animal source of allergens,
Yes.
how long does that antigen circulate in our indoor systems?
Well, actually speaking, Atiz, I cannot really answer that question. But yes, the dog ones, they circulate for a much longer time. And maybe that the reason for that is that if you have seen in India, dogs are domesticated more than cats. Now, the thing may be very different in, say, for example, amongst Chinese people, cats are domesticated more than dogs. So maybe that thing has not been studied.
Thank you.
Can I add something? Very good lecture. Excellent. Very good. So I just added to from the last point about what was the last discussion? Acha, how much? So if you have a cat or the dog at the home, and even if you throw the cat and dog for any reasons, so the danders and everything will remain almost about 3 to 6 months. So basically that can be one of the cause. Coming to the encasing, rightly he has told encasing is very costly and everything. When I was the student, basically, when with Dr. Gaur, Dr. Shaha, so one of the very senior person's wife came and she was allergic. She has a typical symptoms in the night time, cough and all those things. And she was allergic to the house dust mite, and then we told for the immunotherapy, she was reluctant for the immunotherapy. Who is going to take the treatment for 3 years and 5 years and so on. So she was reluctant. So at that time, anti-allergic bed covers and the pillows were not there, what you are asking. I think there is a lecture also, no, on the encasing, no? There is a lecture also on that. Anyway, so then at that time it was not there. So in fact, then we suggested her, why don't you do one thing? Because in the night only you have the problem. So simple, buy a plastic sheet, big sheet, put it on the mattress. But she says, ki after putting the mattress, I'll be not able to sleep. So then we advise her, after that you put 2 or 3 bed sheets so that you become comfortable while sleeping. And to your surprise, the symptoms were decreased. So these are the Gharelu jugads basically then can be done, but lot of like drugs he has told, immunotherapy and other things has come into the market. What was the third, last one was discussion? और उससे पहले क्या discussion किया था? हाँ, about the, I was very happy that he put it across the allergen-free dogs and the cats. So these are there, and plus the people have tried giving immunotherapy to the dogs and the cats also. Some literatures are there. So I just wanted to put across these 3 things. Okay, thank you so much. Please carry on. Rabbits, it should, the dander has, even these your mouse, rats.
Yeah, rodent
yeah.
allergens.
So all the discussion tomorrow will be more discussion. As you understand the subject, more and more queries will come. So, yeah.
Close.
Okay, then we shall disperse for tea and assemble back after 15 minutes.
Just
Before hold on, just hold on.
Before that, sir, you want to say something?
Yes. So somebody was talking about the avoidance measures, and my old teachers, and I think still it is very true that our old ancient practices of living in the house, and initially hardly there were carpets in India, especially in the rural part. There is no furnishing also. Sofas were not there. So probably these are the lifestyle which has brought, as you see that house dust mite is one of the commonest allergen throughout, not only in India, throughout the world. And our ancient system of living in, I don't know how many of you, at least I was born in village. My mother used to do, जैसे जब जाड़े, हिंदी में सब समझते हैं ना, बोल दें? तो हम लोगों के घरों में क्या होता था, माइट का सोर्स क्या है? रजाई है, गद्दे हैं, तकिया है, तो इसको जैसे ही धूप में रखने की प्रथा थी, अब वो भी प्रथा खत्म हो रही है. So these are the pretty small things, but and that has made everything. किसी ज़माने में तो डस्ट माइट इतना नहीं रहा था, लेकिन अब now because of what we have acquired in our lifestyle, we have become very rich, and that has leading to some of the old-fashioned, old things are still working. I know the avoidance is very difficult and a very, very complex area. Thank you, Prashant, for delivering a very good lecture.
So I am requesting Director Sir to please felicitate Dr. Ashok Shah Sir. Now, Dr. Prashant Prakash Sir, Director Sir, to please felicitate. Now I am requesting Rajendra Prasad Sir to please felicitate Rajkumar Sir. Yes, sir. With this, we will break for a 10 minutes break for tea.
Over to Professor Rajendra Prasad Sir for allergy-focused patient history.
Thank you, chairpersons and dear participants. My lecture was due, I think, before lunch, but unfortunately or fortunately, I'm a part of a governing council of National Academy of Medical Sciences, so parallel meeting was going on. So I asked Sonam to please postpone my lecture. So welcome, and you know that I'm traveling for last 5 days. This is the 5th day. I think tomorrow I'll reach Lucknow. So I'm very tired also. And what I have been told that around 40 participants, is it right? About 40 participants of various departments, including pulmonary, including medicine, including ENT, and some of them you must be from ISKCON department. So you know, allergy is a multidisciplinary approach. And while I was handing over memento to Dr. Rajkumar, since he has come, so let me say that I'll repeat it again, that he was, when I was here, director for 3 years, literally 12 to 15. क्यों राजकुमार साहब? So he, उन्हीं दिनों में ये दिखता था कि ये डायरेक्टर बनेंगे. So he was one of the very active co-partners to running the Patel Chess along with me. So my job is for next 20 minutes, I believe, is to talk to you about clinical approach for diagnosis of allergy. Especially will be more, since I'm basically a just physician, a pulmonologist, so will be more focused towards the nasobronchial allergy. Before I do that, I think I'm audible to everyone. And my objective for this presentation would be what is the relevance of history and clinical examination in the diagnosis of allergy, and I said particularly the respiratory allergy. You know, I still remember I delivered in 2010. This slide is very old. 2010 in Mumbai, under Dr. Mohanty carried that meeting. And in 2010, his theme was, what will happen to clinical medicine in 2020? So every aspect, he gave me the topic, what will happen to clinical, means history and physical examination. So I know that we have a lot of investigations today, very modern sets of investigation. And with this, people are forgetting somehow the history. And clinicians and their patient still value for the history. Many patients comes to me because currently I'm supposed to be a tetra penta care chest physician. So we know that what is happening in the society among doctors. So what I have felt, that clinician as well as their patients, their attendants, they still value the history. And कई मरीज, हिंदी तो मैंने आपसे परमिशन ले ली थी, कि कई मरीज आते साहब डॉक्टर साहब ने कुछ बात ही नहीं की, 12-13 दवाई लिख दी, डॉक्टर साहब ने कभी आला तो लगाया. So what I am trying, that even patients are complaining against us. So as you see, the biggest complaint of most of the patient attendants is that most of the doctors have not talked, listened to the patient seriously. वो क्या बात कर रहा, तो आप मोबाइल घुमा रहे हो अपना, हैं? तो मरीज सब समझ लेता है. Word is very transparent. I used to say when I was in KGMC, long time head there, I used to say my PG students, they have all become now heads and directors. So then those days I used to say, the word is very transparent. तो जब बोले, जब हम सर रेजिडेंट थे तो हमारे समझ में नहीं आता था क्या बात कर रहे हो आप, लेकिन अब जब हम हेड हो गए हैं तो हमारे सब बात समझ में आने लगा. सो मरीज सब समझता है आपकी बात को. सो और वो ये कंप्लेन भी करता है अगर हायर अथॉरिटीज के पास जाता है तो. एंड चलेगा नहीं है. And grounds for retaining, why history is important. I'm talking in general for 1-2 slides. All of the, for your information, if you see the second line, 88% of the diagnosis in primary care were established at the end of brief but good clinical history. And you know, you are all, I think, MBBS and MDs, MS, so you understand what do you mean by good history. And even I say in chest medicine also, if you are a good history taker, your 60 to 70% of the diagnosis, even the treatment will derive from the good history. I am pretty sure at this stage. After doing clinical medicine for now it is 50 years. I started my MD in 1976. So since then now it is 50 साल पूरे होने वाले हैं अब. And so I have realized this. And people now calling me YouTuber. I'll show you why, because many of my lectures are on YouTube. And even this lecture is there. I'll start with this study which we published in year 2000, very old study, 25 years back. A study of prescription habit of medical practitioner regarding allergy. You know, allergy is a very important subject. I just told in the absence of Professor Rajkumar, about 40 participants. So day by day it is increasing. People are taking interest. So we did in long back, who prescribes, sorry, ये भाई क्या हो गया, जरा आइए एक भाई कंप्यूटर वाले, नेक्स्ट प्रीवियस कहाँ से जाएगा, मैंने गलत बटन दबा दिया, छोड़ दो बस, हाँ दबा देंगे. So what I found in that study, that everybody does refer the doctor for allergy testing. You see postgraduate allopaths, graduates allopath, even non-allopaths. I still remember one of the patient who was an Ayurvedic, a very roaring Ayurvedic practitioner. He sent one patient in my OPD when I was in KGMC. उसमें जो पर्चे पे लिखा था, सर इसकी एलर्जी टेस्ट कर दीजिए, यानी उसको एलर्जी की स्पेलिंग भी नहीं पता था. एंड पेशेंट स्टार्टेड फाइटिंग विद माई PG. ये तो आया तो हमारे यहाँ रूल था भाई, हिस्ट्री लो, सब देखो, एग्जामिन करो, उसकी केस शीट भी बड़ी लंबी है. बोले साहब आप क्यों कर रहे हो? अरे हमको तो डॉक्टर साहब ने एलर्जी टेस्ट के लिए भेजा है, करिए, आपका काम है. तो PG मेरे पास लाया बड़ा मायूस होके, बोला साहब ये तो कुछ मान ही नहीं रहा, कुछ बता ही नहीं रहा. सो आई टोल्ड इन अ डिफरेंट लैंग्वेज. हमने देखो भाई तुम्हारे डॉक्टर साहब ने, डॉक्टर की कभी बुराई नहीं करनी चाहिए, हमने कहा तुम्हारे डॉक्टर साहब ने तो तुमको बहुत अच्छा टेस्ट लिखा है, लेकिन यार करना तो हम लोगों को है. और मैं थोड़ा सा और मैं हाइपर हुआ हल्का सा, क्योंकि बहुत हाइपर हो रहा था मरीज. तो मैंने कहा देखो भाई ऐसा है, कभी कभी एलर्जी टेस्ट के दौरान आदमी बेहोश भी हो जाता है, कभी कभी लिटरेचर में कभी कभी 1-2 डेथ भी रिपोर्टेड है. तो डॉक्टर साहब थोड़ा आएंगे तुम्हारे यहाँ संभालने, संभालेगा तो हमारा ये बच्चा, ये रेजिडेंट या हम. तो जो कह रहा है उसे फॉलो करो. एंड टू बिलीव मी, व्हाट वाज द पेशेंट वाज द केस ऑफ माइट्रल स्टेनोसिस. क्योंकि उसको ब्रेथलेसनेस होता था, तो वो डॉक्टर साहब के समझ में आया कि ब्रेथलेसनेस होता है तो ठीक, एलर्जी टेस्ट करा डालो. सो व्हाट आई एम ट्राइंग, नीड ऑफ एलर्जी टेस्ट इज वेरी हाई, व्हाट आई एम ट्राइंग टू से. And then, you know, all sorts of allergic disease, they refer for this. And even non-allergic diseases, I have seen many patients in our allergy clinic, which is run in KGMC. KGMC, I think after Patel Chest and after Jaipur was the third center where allergy clinic was started long back. I was PG, when allergy was started, I was a PG student there. And you know, only about 2/3 of them they were allergic, rest of them they were non-allergic problems. So, and there are all sorts of diagnoses you can see, TP, many, and distribution of allergic diseases, and only allergy tests in our that particular clinic. And those days, only about 50, half of them were require allergy tests. So what I am trying to, this is a good place of history taking, and I hope since morning you are listening. What is allergy? I'll not repeat again, क्योंकि राजकुमार साहब से सब हो चुका होगा. So what is allergy? Even newer definition in 23, but similar. I mean, essence is the same. And then there are various type of allergic disorders. Instead of 4, now we have about 7, 8. And another word, if you want to practice, how many of you are practicing still, already practicing allergy? Please raise your hands. So 3, 4, 5 people are there who are practicing allergy. And I hope rest of the people will do it soon. So many patients we say person is atopic. It is another name of, I must say, allergy, that it is a genetic susceptibility to develop IgE against common allergen encountered. So he is a predisposed person to develop a IgE mediated allergic disorders. And I was saying that, sorry, ulta chala gaya hai. And you know what are the common allergic diseases? What causes an allergy in general? They are known as allergens. It could be anything from inhalants to ingestants to even injectants and contact. Anything can cause allergy. I have heard people have allergy to individuals also. कहते हैं मैं बड़ा एलर्जिक हूँ उससे, उसको आते ही मेरा ब्लड प्रेशर बढ़ जाता है. I don't know what this term is, but it happens. And what Dr. Prashant has told a very good lecture on indoor allergens, and we did a study and published again in long back. So you see the insects and mites. Yes. I know Ashok Sir has written a topic in my, जब इन्होंने बात करी तो मेरे को याद आ गया. इन्होंने हमारे यहाँ टॉपिक लिखी सीमेन एलर्जी. तो जो कह रहे हैं ना, even husband has allergy to wife and though. So his topic I still remember. He wrote in my allergy book, sir, which has been updated in 2024-25. So what I'm trying to say there, so all sorts of allergens are known, but mite and insects, these are two very, I mean, this is an old study where component resolved diagnosis was not there. We used to do simply by skin prick test, and that too initially we used to do intradermal test. I still remember as a PG student. So now the things have refined. So still we found that the insects and mites, they are the most common allergen. Apart from that, pollen is next in India. In India, pollen is also very important. I was attending some allergy leaders meet organized in Delhi, I think two days back. And what I said to those companies, but you work with the Western antigens. We need our local antigens. That is the need of our. Sometimes I go to a skin test, I find someone, then I look that whether a specific IG is available for this particular allergen. So many of them are not available because they are still working with the concept of because they are outside, they are multinational. So I have advised them, please do see that what are our local fauna and flora and how you can go ahead with this. Pollen calendar, nowadays nothing like a pollen calendar. Now books and books after books are there of pollen calendar. But I usually tell that how I have learned a pollen calendar. Dr. A.B. Singh had just gone. Another name of A.B. Singh I used to say, although his name is different, but I used to say is Aerobiology Singh. So he's a great guy in field of aerobiology. And as you see, I'll give you an example. This was the tree which was present in KGMC TB chest OPD. Every resident, जब वो मार्च अप्रैल के महीने में जब वो रेजिडेंट वहाँ जाता था राजकुमार साहब, तो उन्हीं सफ़ेद सफ़ेद फूलों के ऊपर चल के जाता था. तो माई फर्स्ट एक्सपोजर विद एलर्जी विद माई पीजी स्टूडेंट्स, हमने कहा ये जो भी आए हो ये क्या तुम तुम्हारे पैरों के नीचे क्या पड़ा, फूल थे सफ़ेद सफ़ेद? बोले हाँ सर. हमने कहा ये पेड़ कौन सा है? अब आप शहर के लोग बहुत लोग, लेकिन नीम तो सब जानते हैं, ये नीम का पेड़ है और देखिए नीम के पेड़ में वो फूल आ रहे हैं सफ़ेद सफ़ेद. लेकिन ये नहीं जानता था वो हमारा पीजी की एजा डायरेक्टर है, वो एलर्जी किट में था उसके पास वो, लेकिन जानता नहीं. तो हाउ यू ट्रेन स्टूडेंट्स, हमने भाई ये यही है जिसका तुम वो किट में रोज लगाते हो. सो एंड द पॉलन कैलेंडर इज वेरी क्लियर. व्हेनेवर जब इसकी फोटो ली गई अप्रैल में, ये फूल आ रहा है, इसके मतलब दिस इज ए पॉलन कैलेंडर. एनीबडी हैज प्रॉब्लम विद एलर्जी एंड मोर इशू विद दीज मंथ्स, इट कुड बी वन ऑफ द एलर्जन. So that is why if you want to become allergist, you should know fauna and flora around you. Not in what is happening in England, not what is happening in USA. What is happening around you. And you should know when they fall. Although these things are now ready-made available, you need not to. But in our time, nothing was available. We have learned like this, what I am trying to share with you. This is another, riskiness is another allergen, which in month of February photograph was taken and all flowers are there in February. आपको ये भी बता दिया गया होगा कि how to diagnose allergy, लेकिन ये है कि diagnose allergy के मतलब history is also important. Means clinical is important, and skin test is also important, and then lab tests are, you must have been told, lab tests are also important. Even sometimes provocation and elimination tests, not done routinely, but in a higher setup they are done. And so what I am trying to say, my topic was what is the role of history and physical examination. So importance of adequate and careful history, by now you must have understood, is well known. It is not only allergy, any disease you treat. Yesterday I was in Allahabad and they made me a moderator for ILD without telling me. So I just moderate. हमने कहा भाई देखो ILD के अंदर तो अगर आपको हिस्ट्री लेने आती हो कि बड़े आप कुछ कितने लोग आप लोग चेस्ट वाले हाथ उठाओ, तो चेस्ट वाले काफ़ी लोग हैं. तो हम ये कहते हैं कि ILD से ज़्यादा आसान डायग्नोज करना चेस्ट डिजीज में कोई डिजीज है ही नहीं. You take about 2 minutes history, what cough, short duration breathlessness, and you put your stethoscope, जो आजकल लोग रखते नहीं हैं, you find inspiratory crepes at bases, and sometimes you may find a clubbing with the nails, so you find a clubbing. इसके लिए क्या चाहिए diagnose करने के लिए ILD का? But believe me, kilos and quintals of inhalers, all treatment of ILD, I have seen my own eyes in last 15-20 years, because disease is not very common previously. So I have seen people are doing that. इसके मतलब क्या वो आला रखते ही नहीं ना, सुनते ही नहीं मरीज की. अरे भाई अस्थमा के मरीज को तो रंकाई होगा या नॉर्मल होगा, यही दो चीज तो होगी. क्रस्ट तो अस्थमा वाले को नहीं आएगा usually. So what I am trying to say, it's a very important. But in ILD, what is difficult? ILD is a group of, आप चेस्ट वाले हो इसलिए मेरे को हिम्मत पड़ रही कुछ बोल दूं. ILD is a group of 300 conditions, not one. There are some treatable, some untreatable. So that is why history is and history can make all differences. So history in allergy is directed mainly towards establishing the underlying cause. Why detailed history? Diagnosis is obvious. As patient enters your clinic, if he is rhinitis, दूर से दिखता है. If he is asthmatic, वो भी दूर से दिखता है. अगर उसको एक्जिमा है वो भी दिखेगा दूर से. अर्टिकेरिया वो भी दिखता है. तो आपको उसके लिए समय नहीं लगाना है. Diagnosis is very obvious. But what you need to know is, that's why history is mainly directed towards establishing the underlying. What are the allergens? What are responsible factors in this particular allergen? That is why your allergy test will also depend upon a good history. How many allergens you are, how many antigens you are using in your kit? हमारे ज़माने में बड़ी कंपटीशन होता था कि उसके पास 50 है, उसके पास 100 है, कोई कहता मेरे पास 2. अभी भी हैं ऐसे लोग, हम जानते हैं यूपी में, कहते हैं मेरे पास 200 हैं. उससे क्या मतलब है? So what I am trying to say, a good history can prune down the number of tests, how much allergen you will use. So I say it's a very specialized history. And what is specialized? It consumes time. I am sorry to say, अगर आपने एलर्जी को अपना एक एरिया बनाना चाह रहे हैं, कुछ लोग तो कर ही रहे हैं, तो आपको थोड़ा टाइम निकालना पड़ेगा. Usually, allergy case sheets are entirely different than other case sheets. Every institute who are working in allergy, they have a different little sort of carrying everything into the case sheet so that आप छोड़ ना दे कोई चीज. So that's, I think it is a specialized history. Another word I'll emphasize and re-emphasize. And what is specialized? It consumes time. वो 2 मिनट में नहीं बात चलेगी. 2 मिनट में डायग्नोज तो आप कर सकते हो कि अस्थमा है, बट क्या है, एलर्जिक है, नहीं है, एलर्जिक है तो क्या फैक्टर्स हैं, ऑल दोज थिंग्स यू हैव टू. So history of so when you take history, you have got 2 things in your mind: whether patient has allergic disease first, because not every rhinitis is allergic, not every asthma is allergic. So you have to go through the history detail, and so that discover the underlying cause. And how I usually, this is my old slide, I made it long back. I still love to show that how you suspect allergy in any individual. Usually the points by which you suspect is the onset, usually allergic diseases, although late onset allergy is also known, but usually they start from childhood. Usually the family history will be positive. Not necessary that everyone family history will be positive. I have a slide another. And usually there are combination of symptoms. You know, it is not the asthma which is alone. Asthma comes with rhinitis. Asthma comes with eczema. So it is usually you find in such patients, there could be a combination of symptoms. There is a seasonal variation. I already talked about pollen calendar. You know, many of the patients, they come, sir, when season changes, I have more complaints. हमको उसको दूसरी भाषा में मरीजों से बात करते हैं, भाई होली दिवाली में क्या होता, पहले तो मरीज बताता ही नहीं. टेल मी, मैं बता रहा, मैं रोज हिस्ट्री लेता हूँ, अभी भी इस उम्र में भी हिस्ट्री, बिना हिस्ट्री ले काम नहीं चलना है. मरीज से पूछो क्या तकलीफ, अरे साहब कभी कभी सांस फूल जाती है. अच्छा मैं कब से फूलती है, अरे साहब अभी 1 महीना हुआ, अभी 2 महीना. हमने नहीं ऐसा, और सोचो यार कितने देर से हो. यू हैव टू बी फ्रेंडली विद योर पेशेंट. तो बोला साहब 3-4 साल हो गया. फिर बोला अभी भी तुम कि मुझे तो पता ये मरीज एलर्जिक है. हमने बताओ बचपन में क्या, अरे हाँ साहब बचपन में भी सर्दी जुकाम होता था, निमोनिया होता था. सो इट मीन्स हिस्ट्री इज नॉट फोर्थ कमिंग इमीडिएटली. आपने पूछा नहीं, उसने सब आपको खड़ा कर जवाब दे दिया. सो यू हैव टू स्पेंड टाइम, यू हैव टू बी वेरी परसुएसिव. सो सीजनल वेरिएशन था, वो बता, हाँ साहब मौसम हम ही को लीड करना पड़ता है. वो नहीं समझता मरीज को क्या सीजनल वेरिएशन, क्या फैमिली हिस्ट्री, बट वी हैव टू लीड एंड यू हैव टू टेक इट आउट फ्रॉम द पेशेंट. देयर कुड बी सीजनल वेरिएशन. एक और वेरिएशन होता है allergic patient में, geographical variation. When I say geographical variation, what it means, allergen may not be different from Lucknow and Delhi, but allergen may be different from Delhi to Kashmir, from Delhi to Bengaluru. So that's known as geography. बहुत मरीज आते हैं, साहब मैं लखनऊ में रहता हूँ, ठीक है, जहाँ मैं बेंगलोर जाता हूँ मेरी सांस फूलती है या मेरी छींकें आनी शुरू हुई. दैट्स अ जियोग्राफिकल वेरिएशन. सो ऑन दीज बेसिक पॉइंट्स व्हाट वी कैन सस्पेक्ट, yes, he might be suffering from allergic disorder. And I said case sheets are different, where in the case sheets you usually find you have to make, if you want to practice, probably you have to devise your own case sheet. I think Rajkumar will give you one from this institute which is being followed. Even you can modify it according to your needs and this. But chief complaints are essentially will be linked with nose, ear, eye, chest, skin, GIT, where allergy can occur. You have to take present illness in the detail. मैंने बताया प्रेजेंट इलनेस की क्या कहानी है, जो कुछ दिनों का बताते बताते वो जीवन भर की डिजीज निकल आती है. बट यू हैव टू बी केयरफुल. Then whether it is seasonal, whether it is perennial, whether it is irregular, whether it is perennial, with all sorts of combinations would be there, and then you have to find out what is more common in this situation. For example, if it is seasonal, pollen could be a very important issue. If it is perennial, probably house dust mite, animal dander, cockroaches, these could be the factor. What time attack do occur? What is the location of the attack? That may tell you so many things. अभी बताया प्रशांत ने कि नाइट में अगर सांस फूलती है तो माइट कुड बी वन वेरी क्लासिकल एग्जाम्पल. एंड देन प्ले टाइम पे हो रहा तो समथिंग अराउंड प्ले ग्राउंड, समथिंग मे बी इंपॉर्टेंट देयर. During house cleaning, you know, house dust mite and are very, very, very important. What are the precipitating factors? What precipitate? कभी कोई मरीज ये भी कहता साहब मेरे को अपने वाइफ से एलर्जी है, तो उसको don't take it lightly. I just said, I'll repeat. Ashok Saha has contributed in my allergy book, which is clear. Is that one chapter, seminal fluid allergy. मैं सही हूँ अशोक शर्मा, अशोक साहा सर, अशोक, मेरे पास बहुत अशोक हैं यार, हैं. अशोक साहब को मेरे बहुत पुराने दोस्त हैं, अभी भी हैं. तो वो सब चीज़ें आपको जानना बहुत ज़रूरी हैं. Thorough environmental history, what is around that particular patient, you have to go through. And then what is the impact of illness? कौन सा टेस्ट बता पाएगा कि impact of illness क्या है? कितने दिन स्कूल छोड़ता है? सोशल एडजस्टमेंट कितने करनी पड़ती है उसको? उसकी लिमिटेशन ऑफ एक्टिविटीज कितनी है? नॉक्टर्नल सिम्टम्स कितना है? बिकॉज दीज थिंग्स आर वेरी इंपॉर्टेंट इन एलर्जिक डिजीजेस. एंड पास्ट हिस्ट्री पे मैं एक मिनट जरूर दे रहा हूँ. मेरे पीजी जितने हैं, आजकल वाले तो खासकर, अभी भी मेरे पास पीजी हैं, मतलब पढ़ाता हूँ मैं उनको. तो जब वो हिस्ट्री प्रेजेंट करते हैं, आप लोगों में से बहुत लोग ऐसा किए होंगे जब पीजी रहे होंगे कि सर पास्ट हिस्ट्री इज नॉट सिग्निफिकेंट. एक बड़ा तकिया कलाम है, एक डायलॉग है कि जब हिस्ट्री प्रेजेंट करेंगे तो हमने भाई ये बताओ तुमने पूछा क्या जो पास्ट हिस्ट्री इज नॉट, यू मस्ट हैव आस्क्ड समथिंग, देन यू आर कमिंग आउट दैट इज नॉट सिग्निफिकेंट. कुछ नहीं पूछता. So I can take 1 hour in past history, but here I am especially focusing on allergic diseases. Somebody have to take history from infancy, childhood, during atopic diseases. Many patient comes to us, साहब बचपन में साहब एक्जिमा हुआ था, ये मेरी छींकें खूब नाक बहती थी, अब साहब मेरी सांस फूलने लगी. So those things you have to correlate. वैक्सीनेशन क्या लगा है, कोई एंटी का ऑपरेशन हुआ है, तो भी तो हो सकता है वो लिंक हो एलर्जी से उसका. खूब मरीज आते हैं, कहते हैं फेस हुआ, क्या हुआ, क्या क्या होता, भाई एंटी वाले करते हैं. एंटी कितने लोग हैं इसमें? हाँ बहुत लोग हैं, गुड होना ही चाहिए, गुड अमाउंट ऑफ. सो प्रीवियस हिस्ट्री ऑफ ड्रग इंटेक, कोई पीजी नहीं लेता है. ड्रग इंटेक तो सब ले लेते हैं, उसका और आगे क्या हेडिंग होती है कि दवा लिया तो उसका रिस्पांस क्या हुआ, ये बहुत कम लोग पूछते हैं. और एक सवाल और जो नहीं पूछते हैं, मैं कहता हूँ पीजी को कभी हंसाता हूँ, जेल जाओगे इसके लिए. वो दैट इज इफ एनी एडवर्स ड्रग रिएक्शन ड्यूरिंग द प्रीवियस ट्रीटमेंट. किसी ने मान लिया इम्यूनोथेरेपी ली और बेहोश हो गया, कुछ हुआ उसको रिएक्शन, सो दैट यू हैव टू ऑल फाइंड आउट इन द पास्ट हिस्ट्री. फैमिली हिस्ट्री, आई सेड इट्स इंपॉर्टेंट. इट इज नोन फैक्ट दैट if both parents are atopic, chances of being allergy is 50%. Last line says 13% is none of the parents are. So it's not, अपनी जान नहीं लगाओ फैमिली हिस्ट्री के लिए, कभी कोई बिना उसके भी ये डिजीज हो सकती है. And personal history is also very important. You have to look for everything, what is job, what is doing, what are the surroundings, everything. Then comes when you finish the history, I always say my PG students, think about the diagnosis. Not that at the end you will think about the diagnosis, because the physical examination and further investigation will depend on that. वो अमेरिका तो है नहीं कि वो नर्स ने एक सारी लिस्ट को टाइप कर दी और सारी जांचें हो गई. भी हमारा गरीब मुल्क है. सो फिजिकल एग्जामिनेशन, वन थिंग आई वुड लाइक टू से, अभी परसों मैंने एक मरीज देखा है, वेरी गुड हिस्ट्री ऑफ एस्थमा. मैंने आला मेरे साथ डॉक्टर साहब काम करते हैं, आले में तो कुछ सुनाई नहीं पड़ रहा. अब आपने लिख रखा है एस्थमा का मरीज है. अरे हमने कहा तो ठीक है, इस वक्त उसको कुछ नहीं सुनाई पड़ेगा. सो यू हैव टू रियलाइज दैट नो, देयर कुड बी नो फाइंडिंग इन एसिम्प्टोमेटिक पेशेंट. ओनली थिंग, देयर विल बी हिस्टोरिकल एविडेंस. हिस्ट्री में बताएगा वो सब चीज. So then that is a physical examination. What I said that there are a lot of YouTube, I'll just run through that. मेरे को अब राजकुमार, मेरे को लोगों यूट्यूबर कहने लगे हैं, पता नहीं कहाँ से, वो कहाँ से कहते हैं दिखाता हूँ अभी. तो इफ़ यू वांट टू डू लर्न समथिंग भाई फिजिकल एग्जामिनेशन में, उसका भी है, ये मैं एरा में पढ़ा रहा था, उसको उन्होंने कर दिया लगा के. अभी हम लोगों ने इंडियन गाइडलाइन, अभी आई एम हैप्पी, आई हैव हर्ड राजकुमार साहब ने अपनी पहली ट्रेनिंग शायद करी है, डायग्नोसिस ऑफ एलर्जी. दैट्स वेरी गुड थिंग, कीप इट अप. सो वी हैव डेवलप्ड इन दिस वेरी इंस्टीट्यूट अंडर Rajkumar Saab, and we have been all part of that. So my final slide, my take-home message is what I wanted to give you. Value of good history is undebatable. Beyond debate, नेता लोग आजकल डिबेट करते हैं ना, कहना नहीं चाहिए, कुत्ते बिल्ली की तरह लड़ते हैं. So it is, good history is undebatable and first step in diagnostic workup. And it needs good amount of time for complete workup. Careful history discovers the underlying causes. It is etiological history rather than diagnostic. I have already loaded. clinical history guides the allergen to be tested. Not that in every patient you do 50 or 100. So depending on, you can prune down. Clinical history, the knowledge of aerobiology is also very important. And the last thing is very, very important. You know, you do skin test, you do specific IG. Now even component resolved diagnostics have come. Nothing is gold standard. I must stay alone. Whether it's skin, what they tell the sensitivity to that particular allergen. Is it really important in this particular allergen? Probably you have to correlate with history, unless you have that, with all those tests, and then you come out. Somebody has asked a question, what is the efficacy of immunotherapy? किसी ने पूछा था ना? So what Rajkumar said, I used to say same word. If you find the correct diagnosis, पहले पता तो हो. अब आप स्केबीज में एलर्जी टेस्ट कराओगे तो क्या होगा? इम्यूनोथेरेपी लगा दोगे. तो correct diagnosis, you have to identify the correct culprit. टेस्ट करो भाई, आप अपने में कर लो, 5-10 आप में भी पॉजिटिव होगा, इसके मतलब थोड़ा कि आपको एलर्जी हो गई. Then you have to kind of collect. Then you have to find a quality antigen, what we are asking most of the companies. India probably lacks in this, little bit lacks. So we need a quality allergen. And then if you do immunotherapy, I'll go a step forward, Rajkumar, it's a wonderful effect in those patients. This I am saying from my own experience in last 50 years. Some of the patients, we did like that. So with this, I think, and this is, you know, and this is what I am telling is not just experience-based. This is evidence-based today. This is the guideline for diagnosis of IG-mediated allergy. What they say in that clinical history, though certainty of evidence is low, but the strength of recommendation is very strong. So you can understand this is important issue. And then finally, you know, adequate clinical history and physical examination are very important. Why people are asking me YouTuber? Because of this lecture which I put on. I was teaching in ERA, ERA has another campus in Barbados. When they come, I teach them. And this lecture I taught, and this was recorded. It was 273 likha, but about 3,70,000 person have viewed this YouTube lecture. तब मेरे राजकुमार जी समझ में आया कि एक्सरे कितनी इम्पोर्टेंट चीज़ है. हमने तो ऐसे ही हमारे पीजी ने किसी ने ले रहे थे उसने डाल दिया. But many people have viewed. By this time, I think 4 lakh people must have viewed. And then I was clinical allergy. I was talking about a book when Dr. Ashok Shah has a lecture. And there's my own PG, they said, sir, अब आप किताब लाओ. So we have brought a book on chest X-ray, which is in 2 volumes. And I would like to end my lecture with this very important quote. Anyone who keeps learning stays young. अभी तो आप लोग सब लोग शायद हम और शाह साहब थोड़े, हमारे और शाह साहब की थोड़ी शाम तो हो ही रही है. क्यों भाई? अदरवाइज आप सभी यंग हो. बट इफ यू वांट टू रिमेन यंग, कीप लर्निंग. That is the one formula I usually tell all the audience everywhere. Keep learning. That will help your patient, not only your patient, but help you also. बाला साहब समझ गए ना? ऐसे ही बने रहोगे, हैं? So with this, thank you very much, and I once again thank you, Dr. Rajkumar. Although I had but I came, and every year he remembers me, and I usually make a point to come. How much I am busy, I usually make a point to come, because you know these things are vanishing. राजकुमार साहब आपकी मुझसे पूछ रहे थे एक दिन फ़ोन करके, कुछ और तो नहीं पढ़ाओगे साहब? मैंने नहीं भाई, मेरा तो मन उसी में लगता है. समझ गए? मुझे वही पढ़ाने दो. तुम लोग अभी बहुत चीज़ें सब पढ़ाते रहो. मेरा मन तो उसी में लगता है पढ़ाने. पढ़ा तो मैं सब सकता हूँ, लेकिन मैं पढ़ाऊँगा वही. सो थैंक यू वंस अगेन राजकुमार, and my best wishes to all of you.
Thank you, sir. Thank you for the brilliant coverage.
So we'll move on to the next topic. It is by Dr. Vikas Dogra, sir, who is DM Pulmonary Medicine of Patel Chest Institute and alumnus from here, and currently head of School of Pulmonology, Rajiv Gandhi Super Speciality Hospital. He has been instrumental in establishing that institute with its various interventions in advanced critical care services, and was also instrumental in setting up the critical care facilities at Indian Antarctic stations. Sir would now be taking his lecture on allergic march. Over to you, sir.
Thank you, Rajkumar sir, for inviting me to take this lecture today. Now, my lecture is on allergic march. What actually it means is that we have the studies have shown that single individual develops multiple allergic comorbidities during the course of his lifetime. So there is a question that whether we can guess if a child is having particular allergic disease propensity, that he can develop another allergic disease further down the line. So as the parents usually ask that he is having this allergic dermatitis or atopic dermatitis condition, can he develop asthma in the later life? Are there any interventions which can do to stop this? So by definition, allergic march is sequential appearance of series of allergic comorbidities. They are different allergic comorbidities in the same individual. So this figure shows the classical atopic march or allergic march, starting from atopic dermatitis, then food allergy, then asthma, and then rhinitis. So this is the classical sequence which was studied initially. So this is a graphic visualization. What they found that patients in the infant first year of life, 80% had eczema and food allergy. Food allergy and eczema generally starts at the same time, and as in the same individual, they develop asthma and rhinoconjunctivitis later on. So what is the probable pathophysiology? Because again, as told that classical starts from atopic dermatitis, so they say that there is defect in the skin barrier. So they are exposed through the skin to food and inhaled allergens. So this is called epicutaneous sensitization. So because of this, there's release of alarmins, then they activate immature dendritic cells, then allergen presentation ultimately leads to Th2 cells and including memory cells. So further on, later on in their life, when they are exposed to this food and inhaled allergens, they develop asthma and allergic rhinitis. So this is sort of the trajectory through which it goes, and as you see, they are influenced by the genetics, environmental, and socioeconomic factors. It's not that simply single factor is responsible for developing serial allergic comorbidities in the same individual. So that was a classic trajectory which told start from atopic dermatitis. Now there is reverse allergic march also seen from asthma to eczema. Some studies shows pure respiratory allergic march of rhinitis to asthma without any eczema. So meta-analysis showed that only 7% of allergic children follow classic allergic march. So there are various trajectories. So eosinophilic esophagitis has been added to allergic march recently as another allergic disease, in which atopic dermatitis and food allergy later on goes to develop eosinophilic esophagitis. This is an allergic disease, as you can see in the figure. This is called, you can see prominent mucosal fold in the esophagus. This is called trachealization of esophagus. It looks like trachea, but it is the esophagus. So there is lots of fibrosis and stricture development, and maybe there needs to be it may be treated by dilatation also. So this is now considered a part of allergic march. Now this is atopic dermatitis followed by allergic asthma and allergic rhinitis, as already told. So already told that bronchial inflammation induced to epicutaneous sensitization at infancy, and these may be induced by viral infections. Now, it has been seen that not all allergic rhinitis patients develop allergic asthma and vice versa. So now the concept of one airway, one disease is being reviewed, and they are saying if person is having AR alone, then the signaling is different, and when AR and allergic asthma are in combination present, then the signaling is different. So this is the reason why there is some patient develop both and some patient remain single. Now again, mentioning the trajectories, this is one of the largest study, ISAC study. In the German cohort, they found 5 trajectories for wheezing, rhinoconjunctivitis, and eczema. This was other than the classical trajectory. They found 3 groups having only eczema followed by wheezing, 2 had the combination of symptoms, and some trajectories were infected more by environmental exposure, like rhinoconjunctivitis followed by wheeze, eczema followed by rhinoconjunctivitis and wheeze. So as you can see, there are multiple trajectories which were seen. This is not a single format. Again, in the Belgrave study, there were 3 clusters seen with temporal fluctuations, like some developed atopic dermatitis but did not develop any other disease. Some had early onset wheeze but they did not progress to other comorbidities, and some had the classical phenotype, AD, dermatitis, wheeze, and AR. And allergic rhinitis in all the cases appeared as a late onset phenotype. Now, the importance of adolescence, it's not that the adolescence, all the risk factors are present at infancy for allergic march. Even adolescence period, because of the exposure, environment exposure is an important part of this. If we can terminate the exposure even at the adolescent period, this march can be attenuated. Now, why, as already told, that there is something called exposome. It's not a single factor that leads, that can tell you that this person is going to go into march. The exposome has exposure to allergens, exposure to industrial chemicals, dysbiosis, like there is alteration in gut flora. So climate change, altered diet, microbiome change. So all these factors get together to suggest whether the patient can go into allergic march or not. So there are certain risk factors for allergic march that if you find this in infancy, this patient may develop other comorbid allergic disease later on. First is severity and persistence of the skin disease. Obviously, the more the skin is damaged, the more exposure will be to the allergens and Th2 sensitization. Onset before 2 years if the atopic dermatitis has the onset before 2 years. Parental, if the parents have allergy, family history, polysensitization profile, that more than one allergen they are sensitive to, and exposure to industrial environment. So these infants are more prone to develop other allergic comorbidity later on in their life. Now there is studies on genomics and allergy march just to check which genes predispose to allergic march. So as you can see the trajectory, atopic dermatitis followed by allergic asthma. It is loss of function is flagrin gene, FLG gene. This is the most studied genomic association of allergic masks. So other combination of allergic masks have different genes that have been marked. Now, filaggrin is the disease which causes atopic dermatitis because it leads to keratin cross-linking. It makes a proper skin barrier. If this autoantibodies are present to this FLG, then atopic dermatitis is severe and leading to more exposure to epicutaneous sensitization to allergens, and this can people have more propensity for allergic march. So as shown in this diagram, this is a normal skin, and that is if the FLG mutation is present. So the stratum corneum and superficial layers are disrupted and allergen is directly attacking inside and leading to Th2 polarization of the cells. So can we develop some biomarkers to see whether this patient is prone to allergy mark or not? So now the studies are going on by skin tape strips. This is actually because earlier the only way to use a punch biopsy was skin. In infant, it is not recommended to do repeated punch biopsies to see the serial values of the cytokines. So this is simply adhesive tape. We pull it off and the superficial layers come on the adhesive tape, and you can then sequence the RNA and the cytokines in that tape. So severity of AD has been correlated with innate inflammation markers, and also WNT beta catenin signaling has been suggested for this allergic mask. So if both parents have allergy, the risk of allergic march is 6-fold, and more severe and early persistent phenotypes. Now, polysensitization, if the infant is allergic, have sensitization to more than one allergen, then they have more propensity to develop airway symptoms later on in their life. And microbiome and allergic microbiome is actually in the nasopharynx, then your airways, then in the gut. So if there is dysbiosis or change in the microbiome, they skew the response toward the Th2 phenotype. So it is also responsible for allergic march in a few patients. So there is decreased gut microbiome diversity, which leads to allergic march, which is because of urbanization or cesarean versus vaginal delivery, early life antibiotics. This is other form of, previously we used to say hygiene hypothesis. So it is like latest, because of that only, that they are saying that it is leading to actually decrease in gut microbiome diversity. So decreased diversity leads to decreased tolerance and epidermal barrier, and activation of IL-33 driven pathway leading to allergic march. So some microbiome has been shown to, if they are colonizing that your nasal microbiota, nasopharyngeal or esophageal, they have shown to skew the response towards Th2 type. Like if the esophageal microbiome has predominant of Haemophilus species, then they may develop allergic esophagitis later on. pharyngeal, streptococcus, H. influenza, and Moraxia catalysis. They again go toward wheeze and asthma phenotypes. Now there is something called dual allergen exposure hypothesis, that allergen tolerance arises from oral exposure. So what is there? What we were talking about was the epicutaneous sensitization. So they are saying it skews toward Th2, but if early exposure to oral allergen is there, it will skew toward Th1. So there is one of the recommendation in dietary intervention that you go in for allergen diet early on in the infancy itself, so it will skew toward Th1. So if we know the proposed pathophysiology, are there any interventions which can be done to prevent this allergic marks in high risk infants? So first is you treat the atopic dermatitis properly once it is first detected. So it has effect on further development of future comorbidities, allergic comorbidities. So there may be emollients, the active treatment for skin inflammation like topical corticosteroids, calcineurin inhibitors like tacrolimus. So it has been shown that treatment of atopic dermatitis reduces subsequent development of food allergy at 2 years of age. And dietary intervention, well, there is not much conclusive data if any dietary intervention can stop this allergic mask in individuals. But it has been shown that early introduction of peanuts and boiled eggs at 4 to 12 months of age in high risk patient has been shown to be effective in preventing sensitization of food with no impact on atopic dermatitis. Now, high risk infants are like they have a family history, they already have a history of egg allergy or polysensitization. Inconclusive results with vitamin supplements, fish oil, use of probiotics. Now, probiotics recently have come into some allergy treatment guidelines, which I will come to in the next slides, but otherwise all are inconclusive. Not effective is dietary avoidance during pregnancy and breastfeeding, hydrolyzed formulas, cow's milk-based infant feeding. Now, breastfeeding is again like a double-edged sword, which they say. It is because, see, the infant, the baby may be exposed to the allergen in utero also. Now, the mechanism is that allergen have been found in amniotic fluid, and they are secreting Th2 cytokines. The cell starts with Th2 cytokines, but passive immunity is transmitted through maternal Ig antibody. Now, in this study, they showed that exclusive breastfeeding for first to 6 months reduced the severity of the skin disease by avoiding dietary antigens. Now, this is contradictory to the previous slide, in which it was shown breastfeeding has no effect. But what they are saying is that after 4 to 6 months, if you early add allergenic food, then it's beneficial. First 4 months, if you do exclusive breastfeeding and avoid them, then it's fine. So they have taken a cutoff of 4 months, that to institute allergen feeding, at least wait for 4 months after exclusive breastfeeding. Now, probiotics, again controversial, but recently they have come into this McMaster University guideline for allergic disease prevention. So in 2015, so they say that use probiotics in high risk mothers with eczema, asthma, severe allergic rhinitis, previous allergic children, or planned C-section, early rupture of membrane, and recent gut infection. So again, this is to increase the gut flora diversity. Other studies have showed that exposure to pet during first year of life prevents sensitization to specific allergens. Then prenatal contact with greater number of farm animal and pet species has been shown to have protective effect on developing atopic dermatitis. And obviously retent occupational exposure, smoking, and environmental exposure to molds have increased late onset eczema and airway symptoms. These are all studies, but again, what intervention to be done, we do not know. These are observational studies. Now, allergen immunotherapy is a very important aspect in preventing the allergic mass, and few studies have been done which shows that this does prevent allergic march. Now, disease modification and long-term tolerance have been seen even after stopping the treatment. So, follow-up after 3 years of treatment of subcutaneous immunotherapy or SLIT has shown that still the beneficial effect is there. Now, this is a PAT study which showed that subcutaneous immunotherapy prevents asthma progression, and the children with allergic rhinitis who were given SCIT, they had preventive effect lasting more than 10 years. They did not develop allergic asthma. So this was published in Allergy Clinical Immunology in 2002. PAT is actually preventive allergic treatment study. And now there are further advances in AIT, and it is supposed that these advances will also prevent allergic march. We are mostly studying immunotherapy in context of preventing asthma, managing asthma exacerbation, but here we are using AIT to stop this allergic march to prevent the further allergic comorbidities developing. So some studies have shown that combining monoclonal antibodies with this immunotherapy has also some effect on the allergic mass, like omalizumab and tezepelumab and SCIT. Now this is a recent study from 2023 which gives us importance of dupilumab to prevent allergic march. So there is 34 to 37% lower risk of new onset allergy and worsening of pre-existing allergy than placebo group, and benefits did not revert, attenuating allergic march. This study was specifically done to stop the atopic march by use of dupilumab. And now recently immune checkpoint molecules are being used. Now immune checkpoint molecules are the critical places where which determine the cell division. So they say that Th2 cells which are dividing and releasing cytokines, they can be stopped at immune checkpoints. Now they are not immune checkpoint inhibitors as used in cancers. They are called molecules because some of them have beneficial effect by acting as agonist. Some have beneficial effects by behaving as antagonists. So we simply use the term molecules. In cancer patient where we using this, they are inhibitors. So finally conclusion is that atopic dermatitis is considered initial stage of allergic march, but they have different trajectories and they are conditioned by exposome, which is environmental and patient related factors. So as already told, the outside in hypothesis is that the barrier is disrupted, epicutaneous sensitization is there, then and the other is hypothesis also given is inside out hypothesis, that the polarized immune response toward Th2 itself affects the skin barrier effect, and this starts a vicious cycle. So concluding, this is a slide for what is the etiology of this allergic march, then risk factors, then interventions already told which can be done. And again, this is not some guideline or any no guidelines are available, and we still do not know what is the proper pathophysiology of allergic mass. So future direction are precision medicine for allergic mass. We should endophenotype, and we should exactly know whether this person, this infant is going to develop other allergic comorbidities later in the life or not. It is still not sure. So there may be clinical data, omics, epidemiology, and mechanistic models to determine pathophysiology underlying different trajectories. So we can isolate the high risk infants and do proper interventions to prevent the march. Thank you.
Thank you, sir, for that brilliant lecture. So with that, we bring this session to an end.
Now I am requesting the director sir to please felicitate Dr. Rajendra Prasad sir. Now I am requesting director sir to please felicitate Dr. Vikas Dokra sir. Hi. So we'll starting with the inauguration ceremony. Please bear with us for a few minutes.
very good evening, ladies and gentlemen. On behalf of VPCI, it is my pleasure to welcome you all on the inauguration of 49th workshop on respiratory allergy diagnosis and management. To begin, I would like to invite our dignitaries to the dais. I request our chief guest, Dr. Rajan Chopra, Founder Chancellor of the Mahatma Gandhi University, Meghalaya, to please come up to the dais. I request Professor Ashok Shah, former Professor and Head, ESIC Medical College and former Director Professor VPCI, to please come up to the dais. I now request Professor Rajkumar, Director VPCI, and Dr. Balakrishnan Menon, Director Professor, Department of Pulmonary Medicine VPCI, to please take their seats on the dais. We will now welcome the dignitaries with a bouquet. I request Ms. Sanjana to welcome our chief guest, Dr. Rajan Chopra. I request Ms. Priyanka to welcome Professor Ashok Shah. I request Sanjana to kindly welcome Professor Rajkumar. I request Ms. Priyanka to welcome Dr. Balakrishnan Menon. Thank you. I now request the dignitaries to begin today's function by lighting the lamp. I now request Dr. Rajkumar, Director VPCI, to please give the welcome address.
Respected our chief guest, Dr. Rajan Chopra ji, I welcome you to the Vallabhbhai Patel Chess Institute, sir. डॉक्टर राजन चोपड़ा जी से मेरी बात करीब 3-4 दिन पहले हुई और मैंने रिक्वेस्ट किया कि सर हम लोग एक वर्कशॉप कर रहे हैं जिसमें कि हिंदुस्तान के कोने कोने से डॉक्टर्स आएंगे जो 5 दिन की ट्रेनिंग के लिए आएंगे। इन्होंने सहज रिक्वेस्ट को मेरी मानी और he has been very nice to the nation basically. अभी 4 दिन करीब कुछ दिनों से IPL क्रिकेट मैच आप लोग सभी जानते होंगे, उसी तरीके से उसी भाव से दिल्ली लीग चल रहा है, दिल्ली DPL। और DPL में जो वेस्ट दिल्ली लायंस टीम के जो ओनर हैं वो राजन चोपड़ा जी हैं। सो ही वॉज वेरी मच बिजी इन दिस बेसिकली। इतना ही नहीं, ओनर हैं, इतना ही नहीं, मैं एक मैच देखने भी गया था। इनकी जो टीम है इंथुजियास्टिक, वेरी मच इंथुजियास्टिक, और कल इनकी टीम चैंपियन बनी है। लेट अस क्लैप बेसिकली टू हिज क्रेडिट। इतना ही नहीं, बेसिकली इनकी टीम की मैं भावुक हूँ, इनसे हमारा जो संबंध है, रिलेशन है, उसकी वजह से, क्योंकि ही इज़ द पर्सन, आई विल टेल यू अबाउट हिम, बट ही इज़ द पर्सन। इन्होंने अपनी पूरी टीम में ऐसे लोगों को सिलेक्ट किया जिसमें 7-8 लोग पिछली कतार में बैठते हैं, जिसको कोई देखता नहीं है, पिछली स्टेट में बैठते हैं, और वहाँ से उठा के उनको 7 को आगे लाया। आगे लाने के बावजूद भी ही बिकेम द चैम्पियन फॉर बेसिकली दिस DPL। कल रात इनके लिए दिन बहुत शुभ था, भगवान का आशीर्वाद है कि ये शुभ था कि इनकी टीम पूरी जीती है। इतना ही नहीं, जो वहाँ पे उस ग्राउंड पे जो सफाई करने वाले जो लोग होते हैं, लोग समझते हैं कि शायद लोगों की कमी है, अच्छे लोगों की कमी है, ऐसा नहीं है, अच्छे लोग बहुत हैं, ढूंढिए आपको मिलेंगे। सफाई करने वाली टीम जो है पूरी, जो सफाई करती है, ग्राउंड को सफाई करती है, बीच में पिच बनाती है, ग्राउंड में बीच बीच में आते हैं, बारिश हो रही है, अपने साइकिल चला रहे हैं, अपना वो जो मोटे मोटे रॉड होते हैं उनको चलाते हैं, उनका कल इन्होंने 21 लाख रुपए डिस्ट्रीब्यूट किए उनको, उन लोगों के लिए। इट्स ए क्रेडिटेबल बेसिकली। सो ही इज ए एजुकेशनिस्ट, he is a nationalist, he is a social worker, और सबसे बड़ी बात है कि he is a very good human being also। human being होना बहुत easy नहीं है। अगर कोई आदमी अच्छा, अगर इंसान ही केवल बन जाता है तो मेरे ख्याल से, मैं समझता हूँ, वो अच्छा डॉक्टर बन सकता है, अच्छा इंजीनियर बन सकता है, अच्छा बिजनेसमैन बन सकता है। अच्छा इंसान होना बहुत ज़रूरी है, जो इनमें क्वालिटी है। ही इज़ द चांसलर ऑफ द Mahatma Gandhi University, and he is involved basically in the medical field also. He has lot of work in the paramedical work, nursing work, pharmacy work, lot of work he has been doing. He had the universities abroad, and जो यूनिवर्सिटीज़ अब्रॉड में काम कर रही थी वो काम कर रही हैं, अभी हिंदुस्तान में भी बहुत सारे काम कर रहे हैं। अगर मैं नरेट करना शुरू करूँगा तो शायद इनका जब इंट्रोडक्शन होगा वो मैं सारा कुछ बोल दूँगा, बट नटशेल ही इज़ वर्किंग फॉर द ह्यूमन बीइंग, ही इज़ वर्किंग फॉर द नेशन। और मैं राजेश जी से रिक्वेस्ट करूँगा कि हम लोगों का जो फील्ड है, एलर्जी का फील्ड है, इसको हम लोग चाहेंगे कि मैसिव कैंपेन अपने जरिए किसी तरीके से करिए, क्योंकि सर 40% ऑफ द पीपल आर सफरिंग फ्रॉम एलर्जी। कोई ना कोई एलर्जी के से ग्रसित हैं 40% लोग। और एक वाक्य है, एक कहावत है कि एलर्जी तो अल्लाह की मर्जी है, और वो जब ख़त्म होगी, जब अल्लाह बुलाएगा तभी ख़त्म, भगवान जब बुलाएगा तभी ख़त्म होगा। कहने का मतलब है कि जो एलर्जिक डिजीजेज हैं उसके बारे में लोगों को जानकारी होनी चाहिए। आप एजुकेशन में हैं, एजुकेशन में चाहूँगा इसको एक कैंपेन की तरफ लें कि एलर्जिक डिजीजेज होती हैं, इसमें क्या क्या प्रॉब्लमें होती हैं और कैसे हम उसका निवारण कर सकते हैं। राजन जी, हमारा पटेल चेस इंस्टीट्यूट में आप पधारे हैं। पटेल चेस इंस्टीट्यूट, the concept of the Patel Chess Institute was there before independence, और हमारे जो 49 में हमारा इंस्टीट्यूट फाउंडेशन स्टोन हुआ था, जिसमें हमारे इंस्टीट्यूट से सरदार वल्लभ भाई पटेल, डिप्टी प्राइम मिनिस्टर, देन डिप्टी प्राइम मिनिस्टर, मैडम राजकुमारी अमृत कौर, देन द हेल्थ मिनिस्टर, एंड ऑनरेबल प्रेसिडेंट डॉक्टर राजेंद्र प्रसाद, ये तीनों लोग जुड़े हुए हैं इस इंस्टीट्यूट से। इंस्टीट्यूट हमारा एक मंदिर है चेस्ट डिजीज का। We get the patients from all over the country, not only the country but the neighboring country. We have 3 objective only, जिसमें कि पहला ऑब्जेक्टिव है पोस्ट ग्रेजुएट टीचिंग, जो हमारी MD कोर्सेज होते हैं, DM कोर्सेज होते हैं, PhD प्रोग्राम्स होते हैं, और हमारी दूसरी जो ऑब्जेक्टिव है वो रिसर्च है। रिसर्च का हमारा इतना स्ट्रॉन्ग ऑब्जेक्टिव है कि रिसर्च हमारे फैकल्टी मेंबर प्रोजेक्ट लिखते हैं, प्रोजेक्ट लिख करके हम लोग फंडिंग एजेंसी को देते हैं, वो फंड्स देती हैं और हम लोग उसको फिर प्रोजेक्ट को एक तरीके से कंक्लूड करते हैं वो रिसर्च करके। हमारा प्रोजेक्ट, हमारा जो रिसर्च का विंग है वो इतना स्ट्रांग है कि जब हम चलते हैं तो सांस फूलता है। उसमें एक जे रिसेप्टर है, जो ये रिसेप्टर को जो इन्वेंशन हुआ था वो हमारे पटेल चेस में ही इन्वेंशन हुआ था। देन द डायरेक्टर पेंटल साहब ने, एस पेंटल साहब ने उसको इन्वेंट किया था। तो रिसर्च विंग हमारा बहुत ही अच्छा है। प्लस हमारा पेशेंट केयर का 128 बेडेड हॉस्पिटल है, जिसमें कि रेफर्ड पेशेंट आते हैं। वी गेट द पेशेंट्स फ्रॉम ऑल ओवर द कंट्री एंड द नेबरिंग कंट्री। और हमारी जो संस्था है, हमारी यूनिवर्सिटी से मेंटेन्ड संस्था है, और हमारा टोटल जो फंडिंग है, बजट है, वो हमारा सेंटर से हमारा फंड आता है। हम सारी एक्टिविटीज़ करते रहते हैं जो कि एजुकेशन को प्रमोट करने की, और यहाँ तक कि हम बल्कि दूसरे स्टेट्स में जाकर के अपना पटेल चेस इंस्टीट्यूट ऑर्गेनाइज करता है प्रोग्राम्स। इवन वी हैव गॉन टू द नेबरिंग कंट्रीज लाइक बांग्लादेश एंड द श्रीलंका। देयर वी हैव ऑल्सो ऑन द बैनर ऑफ द वल्लभ भाई पटेल चेस इंस्टीट्यूट वी हैव ऑर्गेनाइज। हमारे यहाँ कई सारे सेंटर्स हैं जो स्टेट ऑफ आर्ट सेंटर हैं, जिसमें कि नेशनल टोबैको क्विटलाइन सर्विसेज है, जो कि हम लोग टेलीफोन पे टोबैको को छुड़वाने के लिए काम करते हैं, जो कि भारत सरकार का एक प्रेस्टिजियस प्रोजेक्ट है, जिसमें सुबह 8 बजे से शाम के 8 बजे तक लाइनें रहती हैं, जो कि 15 रीजनल लैंग्वेजेस में काम करती हैं। हमारी सैटेलाइट सेंटर है निमैंस बेंगलोर, टाटा मेमोरियल कैंसर इंस्टीट्यूट मुंबई और रीजनल कैंसर इंस्टीट्यूट गुवाहाटी यहाँ पे हैं। और बल्कि गवर्नमेंट ऑफ इंडिया का अब गैजेट नोटिफिकेशन है कि कोई भी आदमी अगर निकोटिन कंटेनिंग प्रोडक्ट मार्केट में लाना चाहता है तो उन्हें हमारा हेल्पलाइन नंबर मस्ट है लिखना, नहीं तो नहीं ला सकते हैं। आप लोगों के लिए भी कभी भी अगर किसी को टोबैको सेसेशन कराना है तो नंबर इज़ देयर इन देयर पैकेट्स, यू शुड रिक्वेस्ट देम इफ़ यू वांट टू क्विट, दिस इज़ द नंबर, प्लीज़ डायल इट and be assured that our people are well trained and they are passionate to work basically। वो पैशन के साथ काम करते हैं। हमारे जो क्विट लाइन के जो काउंसलर हैं वो पैशन के साथ काम करते हैं। आपको कभी शिकायत नहीं होगी टेलीफोन लग जाने के बाद। हम लोग सर 7000 कॉल्स डेली हम लोगों को आती है, हम लोग टैकल नहीं कर पाते हैं, बल्कि हम लोग सोच रहे हैं कि किस तरह से AI को इन्वॉल्व करके हम लोग 2 या 3 हज़ार तक कॉल्स अटेंड कर पाते हैं। बाकी लोग छोड़ने के इच्छुक हैं लेकिन हम छुड़वा नहीं पाते हैं। तो बल्कि हम लोग AI पे भी काम कर रहे हैं, बल्कि AI का आपका बहुत सारा काम है, उसमें भी अगर हम लोगों की मदद कर पाएंगे तो बहुत सराहनीय रहेगा। इसके लिए हमारे कई सारे सेंटर्स हैं, जब माइकोलॉजी डिपार्टमेंट, वायरोलॉजी डिपार्टमेंट, ये सब डिपार्टमेंट अलग अलग तरीके से स्टेट ऑफ आर्ट्स काम करता है। मैं बहुत ज़्यादा वक्त नहीं लगूँगा और मैं फिर से राजन चोपड़ा जी को वेलकम करता हूँ वल्लभ भाई पटेल चेस इंस्टीट्यूट में। एंड थैंक यू सो मच दैट यू हैव टेकन द टाइम in spite of your busy schedule. Basically I was worried because yesterday night when I heard that he has won, I thought ki now they must be here and there, but you took the time basically to come out here. So thank you so much and welcome you from my core of my heart. Thank you so much.
Thank you, sir. I request Professor Ashok Shah, former Director Professor, VPCI, to kindly address the audience.
Dr. Rajan Chopra Sahab, Dr. Rajkumar Sahab, Bala, Professor Rajendra Prasad, and some of my former students over here, Nitin, Vikas, and Vidushi, I see somewhere. You know, when Dr. Rajkumar rang up to say, please sir, stay behind for the inauguration, I just thought it was a routine inauguration, theek hai. I didn't expect to be sitting on the dais and speaking today. 8 years ago, precisely on this day, I got up in the morning and didn't know what to do. I had retired. I retired on 31st of August on 2016 from this institute after serving more than 33 years over here. It was in fact, this institute has given me a lot, and I'm so proud to have people like Professor Rajkumar, Professor Bala Menon, and the others who are been students from here. Our students are everywhere, and it's indeed a great honor to have been associated with them and to have taught them. I've been associated with this allergy workshop since the 9th workshop. So this is the 49th, so you can do the calculation, do the maths. So, and allergy is now regarded as the 21st epidemic of the 21st century. I'm so glad to see the hall. I asked Dr. Rajkumar, kitne participants hai? He said 39. I was a little shocked because we normally used to take about 25, only 25. So, and he's saying that there are a lot of people from the ENT also, colleagues have come. So that's a good news. People are interested in allergy. They've been struggling to get a diploma passed in allergy or something, some super specialization. But you know how the this National Medical Commission works. Anyway, it's a pleasure to be here, and I'd like to wish you a very fruitful and enjoyable workshop. I'm sure you'll learn a lot. I'd like to thank Professor Rajkumar for inviting me, and I wish Dr. Chopra Saab all the best for in his philanthropic works. Thank you very much indeed.
Before Dr. Parul comes and requests, I think, chief guest to speak something, no? So, for last few years, basically, what we have done, we have, like this workshop is being held from since 1974. That's right, sir? 75. Yeah, 1975. So initially this workshop was for 15 days, then it was curtailed to 7 days, and then it was 5 days. So for actually what we thought, Rajan sir, what we thought कि कई सारे लोग जो हैं वर्कशॉप से जुड़े हुए होते हैं, and they are very passionate about the workshop. They work for the workshop, and they don't miss any workshop. They come passionately to teach the people and everything. So for last 2 years, basically, as per their seniority, who has been passionate for this workshop and working for the workshop without any agenda, without any thoughts, just to give the knowledge, impart the knowledge to the people who have come all the way from different parts of the country. Rajan sir, the people have come from the different parts of the country, let it be Rajasthan, Imphal, Bombay, Pune, Uttar Pradesh, Uttarakhand, and so every places the people have come. And for that we have, for last, I think, 2 times, we have started recognizing the senior most person or the stalwarts in the field of the allergy and immunology. And this time, sir, we are going to recognize Professor Ashok Shah for the Lifetime Achievement Award for this workshop. So I will request the chief guest to kindly give a memento and the shawl and recognize his services, because that is the need of the hour. I still cherish the memory when I told you, Rajanji, when I please sit down. When I first time came into Patel Chess Institute as a student, I did not knew anything, and at that time the director was Randhawa, Professor Randhawa Sahab was the director. He told me go and join Professor Ashok Shah, and I went to his room. Although I was working as a medical officer somewhere else, and then when I came on the study leave, and he was so nice and so affectionate, just like just like his own child, and still he gives me the blessing. Sir, thank you so much, whatever you done to Vallabhbhai Patel Chess Institute and me, sir. Thank you so much. I request Parul to continue.
Thank you, sir. It is a great honor and privilege to welcome Dr. Rajan Chopra, esteemed academician and distinguished figure, as a chief guest today. Dr. Chopra's unwavering dedication to education and his invaluable contributions to the academic community inspire us all. We are truly delighted to have him with us, and we look forward to the insights and wisdom he will share. Sir, please join us. Please join me in extending a warm welcome as we invite Dr. Rajan Chopra for his few words.
सम्मानित मंच, मैं तो बिल्कुल सुबह 5 बजे घर आया हूँ, तो कुछ भी तैयारी करके नहीं आया, लेकिन डॉक्टर साहब ने मेरे को बुलाया, डॉक्टर साहब का आदेश था तो मेरे को आना ही था। मेरे दिमाग में तो पूरा अभी तक 1 महीने से क्रिकेट खेल रहा था, क्रिकेट ही घुसा हुआ है। तो लेकिन आप लोग जो डॉक्टर्स होते हैं, मैं उनके बारे में ऐसा सोचता हूँ कि भगवान के बाद कोई दूसरा रूप है तो वो डॉक्टर होते हैं, क्योंकि डॉक्टर जितना रिलीफ देता है कोई दे नहीं पाएगा। लेकिन मेरा आपसे एक अपना कुछ एक्सपीरियंस शेयर करता हूँ। मैं जब ये क्रिकेट टीम खरीदी तो मेरे को लगा कि सब वहाँ पर क्रिकेट टीम में आना भी बड़ा मुश्किल है बच्चों का, तो तभी मैंने सोचा था कि ऐसे बच्चों को लाऊंगा कि जिनको कोई नहीं जानता, जिसके साथ चलने वाला नहीं है, जिसके साथ खड़े होने वाला नहीं है। हमारे यहाँ आईपीएल के प्लेयर हैं, मेरी टीम के 7 प्लेयर आईपीएल में चले गए। मैं उन बच्चों को लाया हूँ जिसकी एक बच्चे की मदर घरों में काम करती है, उसको कोई हाथ नहीं लगाने वाला था। एक बच्चा ऐसा है मेरी टीम में जिसके फादर 500 रुपये की दिहाड़ी करते हैं, और वो आपने देखा होगा रेड लाइट पे कुछ बच्चे करतब करते हैं, उसको लेके आया मैं। वो सब लोग बहुत डरे हुए थे, बड़े स्टेडियम में खेलने में डरते थे। मैं 1.5 महीना उन लोगों को प्रैक्टिस कराया, 10 बड़े कोच लेके आया इंटरनेशनल। अब वो लोग क्रिकेट में क्या है, हर जगह ही है इस तरह का, क्रिकेट में क्या है, इतनी पॉलिटिक्स है, सब किसी क्लब से जुड़े हैं, किसी ना किसी सिस्टम से जुड़े हैं, हर आदमी अपने बच्चों को लाना चाहता है। तो मैंने कोशिश किया कि इसको तोड़ा जाए, ऐसे बच्चों को लाया जाए जिनको कोई जानता नहीं है। तो आप ये देखिए, मेरे एक अंकित राजेश मेरा एक प्लेयर है, उसको 7 आईपीएल की टीम में बुला रही हैं ट्रायल के लिए, और वो ऐसा लड़का है कि उसके पास कपड़े भी नहीं है, जूते भी नहीं है, बैट भी नहीं है, और अब वो सीधा 100 करोड़ रुपए कमाएगा, मतलब 1 साल में 10-12 करोड़ का तो वो बिकेगा आईपीएल में। तो मेरा तो ऐसा मानना है कि मैं तो सिर्फ ये किसी भी चीज़ में एक चीज़ खोजता हूँ कि कैसे मैं जिसको नहीं जानता उसकी मदद कर पाऊँ। आप किसी को जानते हैं, उसकी मदद करते हैं, वो तो बड़ा आसान काम है, मैं तो उसको बिज़नेस मानता हूँ। लेकिन उसकी मदद करना जिसको हम जानते ही नहीं है। और दूसरा, मैं खुद भी दिल्ली यूनिवर्सिटी में पढ़ा हूँ, यहाँ कॉलेज में प्रेसिडेंट बना। पहले मैं यहाँ पास में स्कूल है रूपनगर नंबर में, वहाँ पढ़ता था। मैं वहाँ 10 टीमों का कैप्टन था, 10 टीमों का कैप्टन था। सब टीमों का कैप्टन मैं ही होता था, मेरी टीम होती थी, सिर्फ 5-6 ही दूसरे लेता था एक्सपर्ट। कॉलेज में आया तो देखा कि कॉलेज में इलेक्शन होता है, तो मेरे को लगा इलेक्शन लड़ा जाए। इलेक्शन लड़ा, 3 साल इलेक्शन में जीता। उसके बाद 20 साल से इलेक्शन लड़ा रहा हूँ। इलेक्शन लड़ाते लड़ाते डॉक्टर साहब बुला के डांटते रहते थे, मैं सीखता रहता था। तो डॉक्टर साहब से सीखते सीखते मैं एजुकेशन में आ गया। एजुकेशन में करते करते यूनिवर्सिटी इंडिया में, अब्रॉड में, कहाँ गया मालूम नहीं मेरे को। 7 यूनिवर्सिटियाँ मैंने अफ्रीका में बनाई, 1 लॉस एंजलिस में बनाई। कोविड के बाद कुछ धीरे धीरे थोड़ा सा बच्चे बड़े हो गए, मेरे तो छोटे छोटे बच्चे थे, बड़े हो गए, मैं उनसे मिला ही नहीं 20 साल, तो बाहर ही घूमता रहा। तो मैंने तो ये देखा कि बच्चों के काम के लिए आपका दिल होना चाहिए। मैं सब लोगों को एक ही बात कहता हूँ कि अगर स्टूडेंट्स का काम करना है ना, तो स्टूडेंट का दर्द समझना पड़ेगा, उसका दर्द आपके अंदर आना चाहिए, तब आप बड़ा काम कर सकते हो। तो मैंने तो बड़ा नीचे से काम शुरू किया। मेरे फादर बड़ी जल्दी एक्सपायर कर गए, मदर एक्सपायर कर गए। 6 महीने तो मैं अब टूटा पड़ा रहा, कुछ किया ही नहीं। मैं सिर्फ भगवान को मानता हूँ और जो मेरे को नहीं जानता उसकी मदद करता हूँ। मैं 20 साल से लंगर लगाता हूँ, 20 साल हो गया मेरे को आज। सिर्फ जिसको नहीं जानता उसके लिए काम करता हूँ। तो डॉक्टर साहब से सीखा, यूनिवर्सिटी बनाई, कॉलेज बनाए। मैं 15 स्टेटों में काम करता हूँ अभी। मेरे को पता नहीं है भगवान ने मेरे को कहाँ कहाँ पहुँचा दिया। उसके बाद मेरे को एक CVS कॉलेज है, वहाँ मैं चेयरमैन बन गया। दिल्ली यूनिवर्सिटी वी साहब ने मेरे को चेयरमैन बना दिया। चेयरमैन बनाया तो वहाँ प्रोफेसर्स के इंटरव्यू होते हैं। प्रोफेसर के इंटरव्यू देने जाता था तो एक बड़ा अच्छा कैंडिडेट था, बड़ा अच्छा इंटरव्यू किया। मैंने बाहर निकला, मैंने कहा आपका कर दिया, आप जाओ। वो मेरी इंतज़ार कर रहा था। बोला नहीं, मैंने सर आपसे मिलना है। मैंने कहा मैं थोड़ा जाना है मीटिंग में, आप बताओ। तो बोला सर मैं आपको पढ़ाता था सत्यजी कॉलेज में। मैंने कहा अच्छा। उसने मेरे दोस्तों के नाम बताए। मैं उसको वापस अंदर लेके गया, बिठाया, चाय पिलाई, प्रिंसिपल को बोला चाय पिलाओ इनको, सर को। और पूरे रास्ते में सोचता रहा कि ये कैसी भगवान की ताकत है कि जो मेरे को पढ़ाता था उसका इंटरव्यू प्रोफेसर का मैं ले रहा हूँ। पर कितना मुश्किल काम है। लेकिन अगर मेरे को पता होता तो मैं नहीं ले पाता उसका इंटरव्यू। लेकिन काफ़ी टाइम निकल जाता है, 20 साल। तो मेरा तो ये मानना है, मैं कुछ ज़्यादा तैयारी करके नहीं आता कहीं भी जाता हूँ। तो मैं तो नेचुरल बात करता हूँ। आज तो मेरी नींद भी 1 महीने से पूरी नहीं हुई है, लेकिन डॉक्टर साहब ने आदेश किया था तो मेरे को आना था। तो लेकिन मेरा डॉक्टर्स के लिए तो ये कहना है कि डॉक्टर साहब जितना काम करते हैं, मैं डॉक्टर साहब का ऊपर सेंटर भी देख के आया, जो कॉल सेंटर है। मैं डॉक्टर साहब की सब एक्टिविटी को देखता हूँ, कितना डॉक्टर साहब मेहनत करते हैं। हमारे लिए भी बहुत अच्छा कहते हैं। मेरे को बोलते हैं कि तू बहुत बड़ा बनेगा। मैंने कहा कब बनूंगा, कितने साल से कर रहा हूँ, कब बनूंगा। बोले बनेगा, इंतज़ार कर। तो मेरा तो आप लोगों से कहना है कि डॉक्टर्स को तो मैं बहुत बड़ा आदमी समझता हूँ। डॉक्टर्स जो है भगवान है। जब किसी को कोई बीमार देखता हूँ तो डॉक्टर्स के पैर पकड़ते हैं लोग। थोड़ा सा डॉक्टर प्रोफेशनल भी हो गए हैं थोड़ा सा, लेकिन अच्छे भी बहुत हैं। मैंने तो अच्छे भी बहुत देखे हैं कि अच्छे भी बहुत हैं। तो मैं और कुछ आपसे नहीं कहना चाहता, बस मैं इतना ही कहता हूँ कि आपके हाथ में जो भी है ना, आप जब भी निस्वार्थ किसी की मदद करेंगे तो भगवान आपको कहीं भी पहुँचा सकता है। बस मैंने ये देखा है। मैं अपने बारे में ये कह सकता हूँ, दूसरे के बारे में क्या कहूँगा। ठीक है सर, थैंक यू सर।
Thank you, sir. We would now felicitate our dignitaries. I request Professor Rajkumar to present a memento to our chief guest, Dr. Rajan Chopra. Before that, I request the dignitaries on the dais to kindly release the 49th workshop training manual. I now request Professor Rajkumar to kindly present a memento to our chief guest, Dr. Rajan Chopra, and shawl. I request Director Sir to kindly present a memento to Professor Ashok Shah. I request sir to kindly present a memento to Dr. Balakrishnan Menon. I now request Professor Menon to kindly propose the vote of thanks.
Thank you, sir. At the outset, I wish to thank our chief guest, Dr. Rajan Chopra, an eminent philanthropist who took time out of his busy schedule. Sir, your enlightened words will inspire us throughout. I thank you very much, sir, for gracing this occasion and for inaugurating this workshop. I thank our director, Professor Rajkumar, for organizing this workshop and for encouraging us throughout, and for also stimulating us to do more than what we usually do. I thank our teacher, Professor Ashok Shah, a teacher to many pulmonologists in this country, and many of you might be students also. I thank you, sir, for, I congratulate you for achieving the Lifetime Achievement Award. And I thank you, sir, for coming today from all the way from Gurgaon. It's very difficult. And I thank you, sir, for gracing this occasion. I thank all the participants for enrolling for this workshop. I hope you learn the true method of diagnosing and treating allergies. And I also hope you practice ethically and do good to a lot of patients. As our chief guest has already told, you should always try and do good to the people whom you don't know, so that you can achieve much better things in your life. I thank all the administrative staff of the institute, our deputy registrar, his team, junior engineer and his team, who has overcome many obstacles today also to have this function here. I thank our co-organizers, Dr. Sonam, Dr. Parul, our teachers, Professor Rajendra Prasad, our colleagues, Dr. Vikas and all such faculty of the institute for being here today for this function. Thank you.
All of you, please join us for the group photograph.